everybody to kindly be seated. And thank you so much once again for patiently waiting for us to begin. Thank you so much for being a part of it. Ladies and gentlemen, esteemed guests and medical professionals, it is my honor to welcome you all to the 6th edition of Cancer Summit and Awards here at the Constitution Club of India, New Delhi. This summit is an initiative by Integrated Health and Wellbeing Council and Rapid Global Cancer Alliance. My name is Harpreet Kaur and I'll be your host for today's event. The Integrated Health and Wellbeing Council of India is a prestigious health advocacy institution in India aligned and inspired with UN Global Holistic Approach to Sustainable Development Goals. It is a premier think tank engaged in everything concerned with the health and well-being of human enterprise and existence. Over the last decade, the IHW Council has successfully brought all relevant contributors in the healthcare ecosystem, from healthcare providers to government representatives and policymakers on a single platform to identify and address the issues in an accessible and inclusive healthcare ecosystem for all. Rapid Global Cancer Alliance is an organization of, for, and by the stakeholders, representing the cancer community and championing the patient causes. RAPID is dedicated towards supporting the common goals of reducing cancer, especially in resource-constrained settings, by promoting knowledge, awareness, research, advocacy, funding, and equity, thereby ensuring that cancer control continues to be a topmost priority in the global health and policy agenda. With rapid 100 days, starting from the month of September till the month of January, we conduct various sessions for cancer awareness with multiple industry partners. Over the next few hours, we will delve into the latest innovations, approaches, research, and advancements in cancer care and treatment. Our distinguished speakers will share their expertise on the key topics, and we will have engaging panel discussions along with Q&A sessions. We would also like to thank our sponsors for today's event: Gold Partner Pfizer, Knowledge Partners Indian Society of Medical and Pediatric Oncology plus Genoventa Health, Associate Partner Merck, Session Partner Tata 1mg, Supporting Partner OncoStem Diagnostics, and Digital Media Partner Only My Health. Now, before proceeding further, let me share with you all the agenda for the day. We will have our inaugural session in a while on current trends in cancer in India. This will be followed by a session on innovations in cancer diagnosis and treatment. After that, we will have a keynote presentation. Then we will bring you another session on innovation in onco research and development, followed by a session on revolutionizing cancer care through digital health, bridging gaps in accessibility, affordability, and support. We'll also have a session on collaborative approach to comprehensive cancer care, followed by a virtual session, and the event will culminate with award ceremony. And now, before we start the inaugural session, I request to have IHW Council video for all of us. Can we have the video, please? I request the team to kindly share the video with audiences, please.
In a world where health defines potential, diseases become barriers to growth. Weaving dreams of a world without sickness. Star Health Impact Awards, CME Excellence Movement, Ayushman Bharat Conclave, Jal Shakti Conclave, Digital Health Summit, Patient First Summit, the Good Air Movement and Summit, Rapid Global Cancer Alliance, and the She Alliance for Spirituality in Health and the Environment. These initiatives have received wholehearted support from policymakers, industry captains, community leaders, health experts, celebrities, and influencers. Respected brands and advocates have also joined the council, becoming allies in the mission for a healthier world.
I think this very nice. It's an important initiative. I would definitely be interested to know the conclusions of your deliberations, and I will definitely take these issues and your suggestions forward to the logical conclusion.
हेल्थ सर्विसेज कैसी होनी चाहिए, ये तो महत्वपूर्ण विषय है ही, पर उसके पहले हमको हॉस्पिटल या डॉक्टर के पास जाने की जरूरत न पड़े, इसके लिए हमारे एयर पोल्यूशन और वाटर पोल्यूशन को कैसे सुधारें, इस बात पर जोर देने की आवश्यकता है। कहते हैं कि जल पाओ गगन समीरा, पंचतत्व निर्मित या अदम समीरा, ये पंचतत्वों से निर्मित या शरीर पुनः पंचतत्व में गिर जाता है, और उन पंचतत्व का जिससे इस शरीर की रचना हुई है, आकाश, पृथ्वी, अग्नि, वायु, जल, इन सबका ख्याल ही नहीं रखना, बल्कि पंचतत्वों का रक्षा करना हमारा पहला कर्तव्य हो जाता है।
In the digital world, the council reaches millions with credible source of knowledge empowering them to protect their health and prevent diseases. Through its various initiatives harnessing the power of social media, the council impacts over 100 million lives annually. Join IHW Council in creating a world where limitless potential knows no bounds. Together, we can achieve a happier, healthier world for all.
Well, what an incredible journey that is. And now I request Mr. Kamal Narayan, CEO IHW Council, to please come on stage and deliver the key address for the 6th Cancer Summit and Awards. Please put your hands together for Mr. Kamal Narayan.
Good morning, everyone. First of all, I'm really sorry for making all of you wait, as we could not start on time today. Since today is the budget session and we are very close to the Parliament of India, there were certain road restrictions, so the people who were supposed to put the logistics here could not move that freely. And that's why the delay, but we are, really apologetic for the same. कैंसर समिट मैं हिंदी में बोलूँगा क्योंकि हम लोग ऐसी जगह पर हैं जहाँ पर भारत की कई सारी नीतियों पर बातें होती हैं, नीतियाँ बनती हैं और नीतियाँ बनाने वाले लोग आते हैं, और भारत की नीति हिंदी में ज़्यादा अच्छे से बन पा रही है और ज़्यादा अच्छे से समझी जा सकती है। कैंसर समिट हमने 6 साल पहले इस मिशन के साथ शुरू की थी कि ये जो कैंसर की महामारी है, जो कोविड नहीं आया था उस समय जब हमने कैंसर समिट शुरू किया था, द फर्स्ट कैंसर समिट वी डिड इन 2019, and at that time the COVID had not come to India at least, और तब भी एक बहुत बड़ी संख्या में लोग कैंसर का शिकार हो रहे थे, और कैंसर का सिर्फ शिकार नहीं हो रहे थे, कैंसर से हम उनको बचा भी नहीं पा रहे थे। भारत में आज भी करीबन 15 लाख केसेस, हमारे साथ बहुत सारे एक्सपर्ट्स आज हैं, वो और स्पेसिफिक फिगर्स बता सकते हैं, लेकिन करीबन 15 लाख कैंसर के केसेस हर साल भारत में डिस्कवर होते हैं और उसमें से करीबन 8 लाख जाने जो ऐसी हैं जिन्हें बचाया नहीं जा पाता। तो कैंसर जिस तरीके से बढ़ा है और जिस तरीके से बढ़ने की जो गति है या जो स्पीड है, उससे ये ज़रूरी है कि हम इस बढ़ती हुई महामारी के अगेंस्ट अपने को कितना प्रिपेयर कर पा रहे हैं। क्या हमारा हेल्थ केयर सिस्टम कैंसर की इस बढ़ती हुई संख्या को एड्रेस करने के लिए रेडी है तो उसमें अभी कितने गैप्स हैं? क्या हम वो सारे जो 15 लाख केसेस डिस्कवर होते हैं या 14 लाख केसेस डिस्कवर होते हैं, क्या उन सभी को सही ट्रीटमेंट, टाइमली ट्रीटमेंट मिल पाता है? और ऐसी बहुत सारी नई जो ट्रीटमेंट्स हैं, जो थेरेपीज़ हैं, जो हेल्थ केयर की सुविधाएं हैं, जो कि रोज़ जो है इनोवेट हो रही हैं, डिस्कवर हो रही हैं, साइंटिस्ट्स जिन पर काम कर रहे हैं, क्या वो चीज़ें भी हमारी भारत की जनता तक पहुंच पा रही हैं? पिछले कई सालों में और स्पेशली व्हेन आवर ऑनरेबल प्राइम मिनिस्टर स्टार्टेड आयुष्मान भारत, we have seen that Ayushman Bharat has brought substantial intervention, support और हेल्थ की सुविधाएं लोगों तक बहुत पहुंची हैं और बहुत सारे नंबर ऐसे भी हैं जो आयुष्मान भारत के अंदर कैंसर के ट्रीटमेंट भी हो रहे हैं। बट क्या वो सफिशिएंट है और उसमें और आगे कितना ऐड ऑन किया जा सकता है, या कितने और लोगों को जो ये सुविधा नहीं पहुंच पा रही या जो सुविधा में इम्प्रूवमेंट किया जा सकता है उस पर काम कर सकते हैं? तो कैंसर समिट का मिशन यही है कि हम कैसे कैंसर से होने वाली प्रीमेच्योर डेथ्स और कैंसर से इम्पैक्ट होने वाली वो तमाम जिंदगियां, वो तमाम परिवार, उनको वो रिलीफ, उनको वो सपोर्ट सिस्टम पहुंचा सकें और लोगों को कैंसर बहुत समय तक हमने समझा कि कैंसर को नॉर्मली वी हैव बीन एसोसिएटेड विद द लाइफ स्टाइल एट्रीब्यूट्स ऑफ द पीपल, कि कैंसर इसलिए हो रहा है क्योंकि लोगों की एक सर्टेन लाइफ स्टाइल है या कोई लाइफ स्टाइल की जो चॉइसेज हैं उसकी वजह से हो रहा है। लेकिन ये आप सभी लोग जानते हैं और बहुत सारे एक्सपर्ट्स भी इस पर आज ऑब्वियसली बात भी करेंगे कि कैंसर की जो का रीज़न है वो सिर्फ लाइफ स्टाइल चॉइसेस नहीं है। द एनवायरमेंटल फैक्टर्स, द जेनेटिक फैक्टर्स, देयर आर सो मैनी थिंग्स which are causing this problem. So for that we have to ensure that people who get to that side of the line, they are getting that kind of support from the society, from the industry, from the government, and they are able to get the best of the care which is available. So with this I welcome you all again for being part of this 6th कैंसर समिट। 6 साल से ये जर्नी चल रही है और इस समिट साल में एक बार होती है, साल में एक बार हम करते हैं। वर्ल्ड कैंसर डे के अराउंड करते हैं। 4 फरवरी इज़ द वर्ल्ड कैंसर डे। आज 1 फरवरी है और इसलिए हमने आज करना इसको मुनासिब समझा क्योंकि ये वर्ल्ड कैंसर डे के पहले लोगों तक इस मैसेज को, पब्लिक तक, मीडिया तक, गवर्नमेंट तक इस मैसेज को एम्पलीफाई कर सके कि कैंसर की जो रोकथाम है, जो कैंसर का के लिए जो प्रिवेंशन की ज़रूरत है और कैंसर में जो केयर की ज़रूरत है, उसे हम कैसे आगे और बेहतर बना सकें। आप सभी ने वीडियो में ऑलरेडी देख लिया है। ISW काउंसिल का जो फिलॉसफी और मिशन है, हमारा मानना है कि हेल्थ सिर्फ हॉस्पिटल, डॉक्टर और मेडिसिन तक लिमिटेड नहीं होती है और ना ही बीमारियां और डिजीज़ेस तक लिमिटेड होती हैं। हालांकि आज बहुत सारे लोग जो अभी इस समिट में हैं वो किसी हॉस्पिटल, किसी मेडिकल कंपनी या बहुत सारे डॉक्टर्स हैं। तो मेरा कहने का मतलब ये नहीं है कि उनका रोल किसी भी तरीके से कम है, लेकिन बीमारियों की जो जड़ें हैं वो अस्पताल के बाहर हैं। और वो बीमारियों की जो जड़ें हैं वो हैं ना साफ़ हवा का ना होना, साफ़ और सुरक्षित पानी का ना होना, मे बी न्यूट्रिशन और खाना और फूड की अनअवेलेबिलिटी, या लोगों की चॉइसेस वैसे हैं। तो वी वर्क ऑन द मिशन ऑफ गुड फूड, गुड एयर, गुड वाटर, गुड लिविंग एंड गुड हेल्थ केयर फॉर ऑल। तो जो हेल्थ केयर का पार्ट है वो सबसे बाद में हम रखते हैं, लेकिन वो उतना ही ज़रूरी है जितना बाकी चीज़ें ज़रूरी हैं। तो इसीलिए ISW काउंसिल का जो स्पेक्ट्रम है वो बहुत वाइड है। मैं अभी किसी को बता रहा था तो कई बार लोगों को लगता है कि हवा, पानी और खाने की बात करने वाले कैंसर की बात क्यों कर रहे हैं। तो ये जो हमारा स्पेक्ट्रम है, इट्स वेरी वेरी होलिस्टिक इन टर्म्स ऑफ हाउ वी लुक एट द हेल्थ, एंड वी लुक एट हेल्थ फ्रॉम एवरी possible angle, that how the diseases are increasing, what is the root cause of that, and how we can address those fundamental aspect of life, so that a better, healthier nation, society and individuals can be created. So with this, welcome all of you again for this 6th Cancer Summit, and we are looking forward some really insightful discussions, and also celebrate some wonderful work of the people who are working in the cancer care space. Thank you so much.
Thank you so much, sir, for the key address and for this wonderful initiative. Ladies and gentlemen, now it's time for our inaugural session on current trends in cancer in India. Most of us know that cancer in India is witnessing a rapid rise, with changing lifestyle factors, environmental influences, and genetic predispositions playing a significant role. The session will explore the latest epidemiological trends, advancements in diagnostics and treatment, and the evolving landscape of cancer care. Experts will discuss policy initiatives, technological innovations and strategies to enhance early detection and patient outcomes. Now, I would like to invite on stage Mr. Kamal Narayan to kindly come and moderate this panel discussion. So, please, thank you. Please put your hands together for the moderator of the session. And now I would like to invite all our distinguished guests on this stage, starting with Ms. Sujaya Krishnan, former Health Secretary, Government of India. Welcome, ma'am. I would also like to call on stage Dr. Shyam Agrawal, Vice President, Indian Society of Medical Pediatric Oncology and Chairperson Oncology from Sir Ganga Ram Hospital, New Delhi. So, welcome to the session. Please, thank you. We also have with us Mr. Prabhat Sinha from Boehringer Ingelheim. So, welcome. Please join us. Thank you. Now I invite Dr. Ashok Sharma, Additional Professor from AIIMS Jhajjar. So, a very warm welcome to you. And now I would like to invite Dr. Shashi Balian, Founder and Managing Director, Clear Medi. So, a very warm welcome to you as well. Now, let's start the session. So, over to you.
Thank you. So, good morning once again, our esteemed panelists, and it's a kind of a dream panel in a way. We have with us somebody who is almost the largest care provider in the cancer space, Dr. Shashi Balian, Ms. Sujaya Krishnan ji, who has spent a long time in the Ministry of Health as Joint Secretary. She is a former Joint Secretary in the Ministry of Health and Family Welfare, and was involved in a lot of those important policy making process, Dr. Syam Agrawal, one of the finest oncologists in our country, Prabhat Sinha ji is a very, very passionate health advocate and also patient advocate, apart from his role as a public affair and government affair in the medical company, and also Mr. Dr. Alok Sharma. So before we start the session, there is a very interesting news I just got. As I said, as we are doing this summit, Cancer Summit here, the budget session of our country is going on just next door. And something very interesting has been just announced. So it's not only we talking about cancer, even they are talking about cancer inside the parliament. And the news alert is that the government announces daycare cancer centers in every district of India. So that's where I think the relevance of this summit is more important, because जैसे मैंने पहले भी कहा कि कैंसर की जो समस्या है उसके लिए इट इज़ इम्पॉर्टेंट कि हम बहुत रैपिड एक्शंस लें, और यही एक रीज़न है कि हमने जो एक ग्लोबल कैंसर अलायंस सेटअप किया उसका नाम रैपिड रखा, क्योंकि सेंस ऑफ रैपिडिटी इज़ वेरी इंपॉर्टेंट अगर हमें कैंसर को रियली एड्रेस करना है। जो तेज़ी, जो रैपिडनेस हमने कोविड में देखी, चाहे वो पब्लिक हो चाहे वो सरकारें हों, उन्होंने एक सेंस ऑफ अर्जेंसी के साथ कोविड जैसी महामारी को निपटने की कोशिश की और उसको अचीव किया। हमने वर्ल्ड का लार्जेस्ट वैक्सीनेशन प्रोग्राम चलाया, हमने वन ऑफ द हार्डेस्ट लॉकडाउन लगाया, बट इन सारी चीज़ों के बीच में, और हमने खुद की वैक्सीन बनाई, तो उस सब के बीच में एक सेंस ऑफ अर्जेंसी जो थी कि हमें ये करना है और समय पे करना है, ये एक इम्पॉर्टेंट पार्ट था। एंड दैट्स वेयर कैंसर का जो समस्या है उसको एड्रेस करने के लिए ये बहुत ज़रूरी है। तो लेट मी स्टार्ट विद डॉक्टर शशि बलियान। सेशन का जो थीम है वो ये है कि व्हाट आर द इमर्जिंग ट्रेंड्स इन द कैंसर, एंड ऑल्सो हाउ द कैंसर सिस्टम is addressing that. So I'll begin with Dr. Shashi Balyan and let me go like this. So Dr. Balyan, आपने कैंसर, मैं हिंदी इंग्लिश बीच में बोलूँगा, आप अपने हिसाब से वॉट एवर लैंग्वेज यू आर कंफर्टेबल यू कैन यूज़ दैट। तो कैंसर के स्पेस में डॉक्टर बालियान, यू हैव डन वंडरफुल वर्क एंड यू आर रनिंग अ लार्ज सेटअप, ऑलमोस्ट 8 हॉस्पिटल्स इन द कैंसर स्पेस। आपने थोड़ी सी जर्नी के बारे में एक बार अगर इफ़ यू कैन पुट सम लाइट ऑन इट, what are the changes you have seen in terms of the cancer care availability over the period and your journey along with that, and how do you see it going forward, and how do you see government's attention, the government's priorities also becoming more focused toward cancer prevention and care?
So first of all, good morning to all of you, and a big thanks to Kamal for inviting me. I mean, being a panelist over here. And I would want to say that if I talk about the journey, so it started in a conference like this, nearly 1.5 decades back. So if I would not have gone to that conference, probably I would not have been able to set up. And it was nice to hear from Kamal that yes, we are one of the India's largest cancer service provider now. And the journey started from, I was happily living in UK after doing my medicine from India, and I'd come to see my parents on a holiday, and one of my friend, who was a radiation oncologist, he took me to this conference in the small city in Haryana, Hisar, and after going over there, I realized that the whole state of Haryana did not have a single equipment to treat cancer. And I'm talking about 2010, so just 1.5 decades back. The only thing what was available, everything was available in Delhi NCR. There was nothing available in whole of Haryana. And that thought was so strong while coming back from there, I decided I'm not going back to UK. And my wife is sitting over here, and I came back and announced the news to her that look, probably this is my calling back home, and I'm not going back to UK now. And she said, what are you talking? I mean, all your life you wanted to go to UK and work over there, and now we have established everything. I mean, we have kids, I mean, family, I mean, everything is fully done, and now you want to again, you know, I mean, relocate back. I said, no, this is what I want to do. And I went on to establish ClearMedi, and I can very proudly say that yes, I mean, today in last 15 years, but the focus was again clearly that how we can bring the facilities more closer to the tier 2, tier 3 cities, more closer to the patients. So all the patients were traveling. So imagine from Pakistan border till Delhi, there was nothing. So all the patients were coming to Delhi for the treatment. And I often use this kind of a statement which was made by one of the ladies in the hospital where I'd put up the first linear accelerator. She realized, because I was surrounded by a lot of people in the hospital, she realized that I am the guy, I mean, who is actually, I mean, done that. She came and gave me blessings. In Haryana, you just touch your head and gave me blessings and said that, look, it is only because of you that I'm living today, because I would not have preferred to go to Delhi because it is too far for me. And the cost of the treatment and everything, you know, would have been, you know, so much. So as part of the focus, what we have done is that we are moving out in all these smaller cities of India, right from Hisar to Darbhanga to Patna to Mysore to Coimbatore to Madurai. In fact, we have got one of our biggest facilities in a small village outside Baroda, where there was nothing else, I mean, available. And I really feel nice that yes, we have been able to make some difference in making cancer treatment much more accessible to those people who could not have either afforded or could not have gone to those bigger cities to get the treatment. Talking about the epidemiology and all those things, I would say that I was told that there are particular cancers available only in certain areas, and I would say that I've been proven wrong, that practically wherever we have put up a cancer facility, it has been inundated with patients. A small facility we have in a city in Nanded, a lot of you might not have heard of it, and even now after 10 years, that is the only facility in a radius of almost 300 kilometers. All the patients were traveling to Hyderabad or to Aurangabad, I mean, you know, from there. And we can see that the impact, especially, and if I talk about what Kamal was talking earlier, that the government policies have been able to make, that we were treating hardly around 20 to 25 patients over there. And the moment the Ayushman Bharat came into being, I think we started treating more than 100 to 120 patients, I mean, in the same thing. To an extent that I was asked by Ayushman, Dr. Indu Bhushan, when he realized that I was speaking about the same thing in a conference in London, he invited me for a lecture in the NHA that what impact Ayushman Bharat has been able to make. And I can say that Ayushman Bharat has really made a commendable difference, especially into oncology. It has made a huge difference. In bigger cities, I don't know, because we don't operate much in the bigger cities, but in the smaller cities, it has made a huge difference. It wasn't that the cancer was not there, the affordability was not there, and the accessibility was not there. And that is what we have been able to make a difference by both having the affordability and the accessibility of the cancer treatment. So I think I'll not take, I mean, too much of time. Yeah.
Thank you so much, Dr. Balian. And I think the country was fortunate that you decided to stay back, and not only just stay back, but also create something which is really helping people save those, lives, and helping those families who go through the trauma of this disease. And so a big round of applause for Dr. Balian for that. Policy के बारे में आपने कहा कि when you started 10 years back, you saw in a a state like Haryana also did not have much of a facility for cancer care. And now after 10 years, while you have also contributed immensely, you also see that the whole country has seen transformation in terms of cancer care also getting closer to the access to the people, and also in many not only those concentrated pockets of Delhi, Mumbai, Bangalore alone. Sujaya ji, as Dr. Balian also said, that after Ayushman Bharat came, their capability and their possibility of helping more people increased. You have been seeing the government policy, and then including that what announcement is being made today, and many other announcements may be coming with that. How do you see government waking up at the right time in terms of addressing the problem of cancer, and how much more need to be done from the policy point of view, from the government's contribution point of view?
Good morning, everybody. Kamal, thank you so much for bringing me here. Now, when you talk about cancer, it's not that we didn't have a program. It predated me and many others who think. There was a cancer control program right in 1975. But if you think about it, it was more about treatment. It was somewhere in the 80s, they started out talking about how to prevention, because always it was a treatment, this thing. Then in 2010, we really came, that was when the big major change happened. We had the national program for control of cancer, diabetes, cardiovascular diseases, and stroke. And the cancer program was integrated into it. Here, actually, the change comes in when we talk about prevention, promotion of health awareness, and also rehabilitative services, etc. But starting with from 2010 also, it was, we started out, I think, if I remember correctly, in some 100 districts that was there, and not all states were covered. Slowly it has picked up, and it's, moved into, it's become a major program. And what was I saying, when we talk also about it, we see the WHO also says that 60 to 70% of cancers are preventable if we have the awareness, if we know what to be done. So in the rural areas, when you think the primary health care, there was no screening. It is also, this program introduced that you have to screen, opportunistic screening has to start for everybody about 30 years. So that was a major step when people were actually looking at, what was the possibilities and so on. And also, Government of India, of course, all of you know that his health is a state subject, but it's also, centrally funded, where policies come in and we do the thing. So Center brought in the steps to build in the infrastructure, to augment the workforce, and also to build up IEC activities and so on. So initially, we had these regional cancer centers, then came the tertiary cancer centers also, and also screening and others happening at the district and the CHC levels. Because even then, it was not happening. Then you had this also. What about data? We never knew. There is this thing. Today, you have almost a robust data collection system through the hospital-based National Cancer Registry Program, which was started out under the ICMR. It has gone on. You have about, today, I think, 36 hospital-based cancer registries, 236, population-based registries, and about 236 hospital-based registries. And this is throwing up data that is, making it. So we know, okay, that if you know, Aizwal has got the largest this thing, or if say Papampure in Arunachal Pradesh has the largest number of cancers. But when you talk about the facilities, it's less there. And when you talk about facilities, again, I think it's concentrated urban areas, and you'll find most of the cancer hospitals are either in the south or the west. And most research or whatever is happening there. Today we are saying you started out in Hisar. You'll be happy to know that the National Cancer Institute has been established in Jajjar as part of the AIMS. It is a 710 hospital. It is one of the largest that will be. Its main activities will be into looking into research and others this thing. And it also has the first tissue repository in India. So I think today facilities, either through the programs which have been there, I think, yes, affordability, when we talk about affordability, it's not there. You talk about modern treatments, I think the reimbursement rates are missing. And if you talk about homegrown, cost-effective therapies that are there, that is not available to everybody. So, and also clinical trials. So we talk about what research should have gone. We know that certain areas of certain cancers are predominant. There is a predisposing, but still we don't we do not know whether it's because of genetics, whether it's lifestyle, and whether, or it's a combination of both. What is the epidemiology? What is the etiology of these? We still have not this thing. And when we look at the cancer trials that are happening according to the registry, I think it's about 300 odd. And even there, when Northeast has the highest levels, I think the registries there have not, or have, I think, little or nothing to show. So why is, there is still a difference. We need to look into these aspects of things. And again, we need to look at why is the reason that certain cancers, it's there. Can we study that out, or even look at this thing? And when we talk about this thing, affordability, of course, today we are talking about the budget. Last budget, I think there was an funding of 4,000 crores added to the National Health Mission for cancer treatments alone. And also, I think one announcement that was made out, I think, of course, doctors will know, I think 3 medicines were exempted from custom duty, which is a major step forward. Again, we talk about making things affordable. If you talk about magnetic hypotherapy and the nanotechnology, Indian scientists have been contributing to that, and it's a major step forward again. We also have, I think...
Ma'am, I'll come back to you. Yeah. So you have made some important points. As from the policy point of view, from the government's efforts point of view, there has been a consistent effort from the government, and which we are seeing, budget after budget also, as you mentioned about the allocation last year, and then also exemption of the certain cancer drug from the custom duty. We also played our role in terms of demanding for that, so we'll take a bit of credit for it, but obviously it was government to take that call. So these are important, aspects, and also, the registry helping is that taking the data-driven decision. Let me go to Dr. Syam Agrawal now. Dr. Agrawal, you are at the, the care provider side. You are the one who is seeing, the emergence of this disease, and then the prevalence, and then what all, and the causes, and epidemiology, and all that. What has been the changing trends in the cancer space? We saw that cervical cancer at one point of time was the biggest killer, for that matter. Now that is going down because of certain things. Now we also are getting vaccine and all that. So what are the new trends, and where do you see, as a care provider, government to chip in, industry to chip in, and also public?
Right, so good morning to everyone, and thanks to Kamalji and his team for putting us together here on this platform. There's so much happened over the last 4 or 5 decades in the field of cancer, and the journey has been astonishing and amazing since we are seeing major changes in the management of a variety of cancers. So as you pointed out, breast cancer in women has become #1 now. Nearly 2 lakh new cases occur every day. And as was being pointed out, so it's a lifestyle disease related to obesity, related to your food intake, related to lack of exercise, late marriages, and so on. Why has cervical cancer, which was #1 cancer, come down is because of the improvement in the socioeconomic status and the understanding of HPV as the causative role, and of course, little role of the vaccine, which is now become more and more readily available. So these are 2 trends in women which are there. So 50% of the cancers are occurring because of tobacco, which we all understand. Oral cancers, 33%. So if you can stop that, you can prevent 33% of cancers happening in our country. In America, for example, the incidence of oral cancer is just less than 5%. Why? Because they don't chew tobacco. So we know the causes. Alcohol is contributing. Vivek Murthy, the US general surgeon, recently said 100,000 cancers are occurring because of alcohol, and 20-30% deaths are due to alcohol-related cancers. So we all know this. We know alcohol, we know tobacco, we know obesity, but these are things which we are living with, and we are not going to be able to stop because they are money churners for people, for government, and so on. So we know the etiology because less than 5% of the cancers are related to heredity. Breast cancer, ovarian, so they are not hereditary cancers. So people who smoke, people who have obesity, people who have consumption of alcohol accumulate mutations in their genes, in their cells, which has resulted in the occurrence of high incidence of cancers. And as projected over the world, the incidence is increasing in spite of our understanding of the cause. All over the world, whether it is India or Europe or America, the incidence is still continuing to increase. So now coming to the basic thing which is happening in the cancer arena is, now we've understood that we all acquire mutations once we are born. And people who smoke, drink, etc., they have more mutations and therefore more chances of developing cancers. But at the hub of the crux of the problem is driver mutations in the cells, whether it is lung, whether it is oral cavity, whether it is kidney or liver. So that understanding has evolved very rapidly now in the last 15 to 20 years, and we have developed tools called next generation sequencing, which we apply to tumors, and within a span of 15 days we get to know what are the genes which are mutated and causing this patient suffering with cancer. And what is the next step is that if I can block those genetic mutations, I can control the cancer. So the biggest and the first example was chronic myeloid leukemia being driven by one gene, BCR-able gene rearrangement. You take a pill, 99% of the patients become all right. But that's not the story for majority of cancers, because majority of the cancers have 10, 15, 20 driver mutations. And therefore, you need to have those 20 pills or 20 injections to kill those driver mutations and to control the cancer. So we have made, a rapid stride in the understanding of molecular biology of cancer, but then the drugs are coming slowly, steadily, and definitely. So earlier, for example, we had just one pill for CML, now we have 5 pills for CML. And you name the tumor type, whether it is lymphoma, whether it is myeloma, whether it is kidney cancer, whether it is lung cancer, you have targeted therapy. So when we joined medical oncology or oncology, there were 3 pillars of cancer treatment: operation, radiation, and chemotherapy. And today, for the first time, I was reading somewhere that chemotherapy on the decline, immunotherapy, targeted drugs, and other modalities coming up front to take care of these patients with cancer. So the third pillar was chemotherapy, and that pillar is still with us, medical oncologists, and the medicines, which now include targeted drugs, immunotherapy, bone marrow or stem cell transplants. You're talking about antibody drug conjugates, bispecific antibodies, CAR T-cell therapies. So these are becoming available in our country in a big way as well. So we are following the Western, because all these are coming from America and from Europe, but these are becoming available and now patients are not dying. So this is what I was referring to, that Moonshot in the US says that in the next 20 years, there should be, the goal is to achieve 50% reduction in mortality with cancer. So we may not be able to eradicate most of the cancers, but people are going to live long with excellent, good quality of life with these targeted drugs, immunotherapy drugs, antibody drug conjugates, bispecific antibodies, CAR T-cell therapy, etc. So in terms of our country, what has happened in the field of medical oncology is that in the last few years, the government has taken the initiative to train more and more medical oncologists by way of providing more seats, not only in the government sector, but also in the private sector. So when we joined medical oncology maybe 30 years ago, there were hardly 200 medical oncologists. Now, every year, 300 new medical oncologists are joining the country, you know, the hospitals, private sector and the government sector. So that is where those district cancer centers, which the government has today announced that 200 new district cancer daycare centers will be opened, will be manned by these doctors who are now coming up from different institutes. So that's going to be a big help, because like Dr. Balyan said, so we need to reach the people. So radiation, of course, requires 5-10 people, but in each district you need a medical oncologist, you need a surgical oncologist, you need a team of nurses, a need of technicians to look at the prevention part. So I think the government is doing its bit, you're doing your bit, everybody is doing their bit, but I think the field is really opened up now in a very big way, moving away from chemotherapy, getting into a different set of drugs which are not that harmful and are helping our patients live long.
Wonderful. Thank you, Dr. Agrawal. So you talked about certain and some really important new therapies which are potential enough to change the way cancer is being treated, the way the outcomes are being drawn, and also have a lot of possibility of improvising the quality of care and also the quality of life for the patient. Prabhatji, you have been working with patients and a lot of patients and many of them in the cancer space also. You have kind of seen the struggle, the challenges, and also the potholes in the system. When we look at the system from outside, it may be all great, and up to a certain extent it's definitely great. For a patient who is going through that journey, the ride or the drive may not be that smooth. So how do you see the cancer care system, the policies, the kind of adoption of these new therapies? Is it that easily happening? And how all that is important from a patient's point of view? How do you see that from the patient's angle?
Thank you, Kamal, and really honored to sharing this seat with all the dignitaries here. I think I was in Udaipur 2 weeks back, and I just want to recall one small incident. I was in R&T Medical College in Udaipur, and I was talking to somebody whom I knew and had cancer. Incidentally, I met. And this person was saying that, he was devastated, but he said that it's also important when you get cancer, आप कहाँ पैदा हुए हैं और किस क्लास में पैदा हुए हैं. कैंसर तो किसी को भी हो सकता है, कोई नहीं छूट सकता है, बट ये बहुत जरूरी है सर कि आप किस जगह पे पैदा हुए हैं और किस क्लास में पैदा हुए हैं, बिकॉज यही दो चीज डिसाइड करता है कि आप जिंदा बचेंगे या नहीं बचेंगे. एंड ही सेड, आई एम फॉर्चुनेट कि मैं राजस्थान में
affordability of
many things. It's not only the affordability but accessibility. He said कि मैं बहुत फॉर्चुनेट हूँ कि मैं राजस्थान में पैदा हुआ, और मुझे तब पता चला जब मुझे कैंसर हुआ, तब पता चला और ज़्यादा फॉर्चुनेट हूँ, क्योंकि मैं आज जिस हॉस्पिटल में खड़ा हूँ वहाँ मुझे 8 लाख की दवा फ्री मिल रही है. We have pocket of excellence in our country. शायद हर जगह राजस्थान है नहीं, right? But intent of government is to make models like Rajasthan, and many states have been doing this. But what is happening कि सारी जगह पे चीजें एक जैसी नहीं है. It's a journey, it will happen, right? But we have enough pocket of excellence to learn how one state is addressing this, right? Affordability is one issue. आज अगर chemotherapy drugs even affordable, accessible हर तरह है, but still do we feel that everybody who require chemotherapy is accessing chemotherapy the center? No. Maybe diagnosis is delayed and all. So Kamalji, I was trying to, I'm a big fan of acronyms, right? So I was thinking that how do I summarize? So I thought I'll put five things, and it covers some of the gaps. So when we see cancer, there are 5 words, right? CANCER. And I was trying to understand that what is needed, what has happened, and where the gap is. The first thing is C is collaboration, right? I think cancer care, it is not that collaboration is not happening, but I think we need more and more. As sir was saying, for example, cervical cancer. The collaboration starts with school. If it is oral cancer, it starts with younger population in maybe Nehru Yuva Kendra. So I think collaboration, as you were saying, is way beyond the discussion in cancer care. It goes beyond the sphere. And we need to reach out if we really want to prevent the disease at early stage so that we don't have to treat everybody in stage 4 and to become bankrupt either individually or from a government side. So collaboration is the key. And I think we have done a lot, but I think more needs to be done in collaboration. That is where I think everybody feels that need to be done in terms of collaboration. The second, which is A, is not awareness. Is not awareness. I think we have made people aware. Everybody knows breast cancer. My wife and me we know breast cancer because we lost my mother-in-law because of breast cancer. But still, I struggle to take my wife for a mammography every year because she will say, "Acha, 3 mahine baad chalte hain, 2 mahine baad chalte hain." There is a fear. There's a fear that this may come to us. So we always delay. So it's not about awareness, it is all about action. Do we take action? What we hear. Today, even in this room, I don't think any of us will not got touched by cancer in our family, in our friends or relatives. So it's rampant, it's everywhere. But are we taking action? Most of the time we feel कि मुझे नहीं होगा, बाकी किसी और को हो सकता है, right? But किसी ना किसी दिन कहीं किसी तरह से it touches us. So it's enough of awareness. I think it's more of action that how do we make it compulsory. I remember a long time back I was in Sri Lanka visiting a primary healthcare center, and in Sri Lanka the primary healthcare workers are called health inspectors. They go in a khaki vardi mein, they go, and it's for immunization. That time I remember I used to work in UP. My immunization percentage in my state was maybe 30% 20 years back, and in Sri Lanka that time it was 80-90% because it was inspectors. It was they were compelling you to get 100% immunization. So we need action. There has been enough of awareness, right? The second is N, which is navigation. Now, if somebody is being hit by cancer, it is very challenging to navigate that journey. As Dr. Balian was saying, that I may be in Nanded, but do I know that I have a center which is closer to my home? And this navigation is a big issue. Even sometimes people reaches to hospital. For example, I come from Bombay, Tata Hospital. Even you reach Tata Hospital, right? It will be difficult for you to navigate through the hospital. Leave a city. Even in that hospital, you may not know where to go, and how to reach out. So navigation is becoming very important, very critical, because it is not only going to a doctor, it is many other things, as you were saying, when a cancer hits, be emotional, access to government scheme. Somebody knows we can get some support from Prime Minister's Relief Fund, but who will guide you to fill those forms, get that endorsement? You are already devastated when you got this. So you may know this when somebody has passed out. उस टाइम पे आपको बिल्कुल समझ में नहीं आएगा करना क्या है, and you need somebody who will navigate. Dr. Ashok comes from Jhajjar, and I know AIIMS has a very good social work department, right? There's a person called Vivek, I know, he used to be in AIIMS Delhi. You need people like Vivek and his team in AIIMS who used to guide patients that how you can get access to this. If there is no scheme, there are some funds which AIIMS has and AIIMS helps them. But do people know to go to that social work department in that institute? So navigation is very critical, and we need to do more of navigation. And C is community of patients, right? We often forget patients who are caregivers. And again, I would like to thank Kamalji, for example. You have been running specific forums to listen to patients. I was there in Bombay Patient Summit, because it's very important to listen from patients. They are not passive participant in healthcare. They are very active participant in healthcare. But many times we feel that no, they are beneficiary. They are not beneficiary. They need to come forward. But they will come forward provided we empty the seat where we are sitting. So we need to empty that seat to give them that seat. E is equity. Very recently we heard, for example, tremendous work in Ayushman Bharat. No doubt about it. Yesterday's economic survey, if you read, there's a decline of the out-of-pocket expenditure from around 60% to around 23%. The government expenditure on healthcare is increasing. Absolutely fine. But what is missing, or what can be done even in Ayushman Bharat, is the equity of care. Do patients in Ayushman Bharat, as sir was saying, the way cancer was treated is changing. It has changed. But still, in program like Ayushman Bharat, patients are only and only entitled for chemotherapy drugs. Why can't they can get targeted therapies which are even beyond that 5 lakh rupees limit. A patient who is coming from Nasik to Mumbai may get a free chemotherapy in Tata Hospital, but he spends maybe 20,000 rupees just coming, staying, and everything. So the intent of the program is to reduce out-of-pocket expenditure. It will only and only be reduced when they get the best of therapy. And sitting next to the Constitution, the Sansad Bhavan in Constitution Club, I think the one thing if it can change in this country is the equity. If I am a CGHS beneficiary, if I am an army retired person, if I am part of ESIC, what I get and what I get as Ayushman Bharat. It's not easy from a policy making perspective, but I think there should be a drive to make that happen within that limit at least to start with, if not beyond. And the last one, let's talk about, which is registry. I think we talk a lot about success of COVID, and I think because it was a notifiable disease. I think it's a time when we should think of making cancer a notifiable disease. Only thing improves what we count. If we don't count, we will never be able to understand whether we are making progress in Nanded or where we are making progress in Jhajjar. It's very important to kind of record and make this system. So I took a lot of time, Kamalji, but...
no problem. Wonderful. Such a, I think, potential and strong acronym, and covers most of the part of the where we need to act. Dr. Ashok Sharma, so you come from Jhajjar, the National Cancer Center and Center of Excellence for that matter now from the Government of India. From the research point of view, how do you see the India capability increasing in terms of addressing the cancer challenge, and how you have been involved in that, and how what kind of trends you are seeing from the Jhajjar Center of AIMS?
सभी को नमस्कार. मैं हिंदी में ही बोलूँगा. कमल जी, नंबर एक तो मैं आपको कॉन्ग्रेचुलेट करता हूँ. आपने जो पैनलिस्ट यहाँ बिठाए हैं बहुत अच्छे बैलेंस्ड हैं. पॉलिसी मेकर्स हैं यहाँ पर, पेशेंट एडवोकेटर्स हैं, सर्विस प्रोवाइडर हैं, रिसर्चर भी है. जनरली हम लोग रिसर्चर्स को भूल जाते हैं. मेरा बैकग्राउंड MSc PhD फार्मा बैकग्राउंड से. I did my PhD from AIMS New Delhi and went to US. 2015 I came back by getting a prestigious award Government of India and assisting Professor G.K. Rath to develop NCI Jhajjar campus, जो कि मैडम ने भी अभी बताया. NCI Jhajjar इंडिया का लार्जेस्ट कैंसर सेंटर है. इज ए ट्रांसलेशनल कैंसर रिसर्च सेंटर विच इज़ द विजन ऑफ गवर्नमेंट ऑफ इंडिया. और वहाँ पर 300 एकड़ लैंड्स हैं जिसमें 710 बेड्स, डेडिकेटेड एकेडमिक ब्लॉक, रिसर्च ब्लॉक, आपका OPD. सो दे वंडरफुल इंफ्रास्ट्रक्चर. और वहाँ पर एक धर्मशाला भी है पेशेंट्स के लिए, के अटेंडेंट को रुकने के लिए. एज एम्स मेन वर्क इज द टीचिंग एंड रिसर्च. Because we are talking about translation research, so we need a patient. So NCI Jhajjar around 40 kilometers away from here, and wonderful infrastructure under the process of development. So there we are trying to develop high-end research infrastructure. As sir told me, we need the NGS-based technology, chemotherapies, vaccine development programs. So that is the need of हमारी country की ये ज़रूरत है. Because next 10 years में at present around 15 lakh patients every year are having the cancer. But next 10 years is going to double. But you see the research, translation research happen in India only depend mostly on the government funding. Budget only 0.7%. So we need a collaboration, public-private collaboration. Our entrepreneurs come forward to invest in the R&D. Like public-private academia and private company, as per the requirement of our country, we dedicate targeted project we design and we make a product which is required for our patient. This is a pyramid. On the tip of the pyramid is a clinician. He and base is a researcher like us, where medical researchers, molecular biologists, immunologists, bioinformatician, computational biologist, जितना ज़्यादा हम base हमारा strong होगा, जितना ज़्यादा टेक्नोलॉजी हम डेवलप कर पाएंगे उतना ही स्टैंडर्ड हमारा क्लिनिशियन होगा, देन ही ट्रांसलेट द प्रोडक्ट इन द सोसाइटी। अब जैसे कि हम लोग आज कैंसर की बात कर रहे हैं, मैं पब्लिक से पूछना चाहता हूँ आज कैंसर की बात हम क्यों कर रहे हैं? हम लोग यहाँ पर हैं, हमारी डेथ होगी, तो 3 रीजन मुझे बताइए जिससे हमारे मरने के चांस हैं। आप बताइए 3 कारण जिससे हम मर सकते हैं, बताइए। आपसे क्वेश्चन पूछ रहा हूँ। और दूसरा डायबिटीज से कभी आदमी जल्दी से नहीं मरता, उसको मैनेज कर सकते हैं। हाँ, ये तो बहुत छोटे छोटे यार, इनसे कौन मरता है आजकल? बहुत अच्छी मेडिकल साइंस बहुत अच्छी तरक्की कर चुकी है। कार्डिक अरेस्ट, तीसरा वो तो कार्डिक में आ गया ना, वो भी कार्डिक में ही आ गया, उसी में आ गया। हाँ, मैं बताता हूँ 3 जो मेन कारण हैं जिससे हमारे मरने के आज के टाइम में चांस है। वो पहले कार्डियोवैस्कुलर नंबर 1 पर होता था, दूसरे नंबर पे कैंसर आता था, तीसरे नंबर पे एक्सीडेंट, रोड एक्सीडेंट। हमें कोई मलेरिया चिकनगुनिया इनसे कोई नहीं मरने, हमारे डॉक्टर साहब बहुत अच्छे हैं, बहुत मेडिकल साइंस तरक्की कर गई है। लेकिन 2019 मैकमास्टर यूनिवर्सिटी ऑफ कनाडा दे डेवलप्ड बिग 21 कंट्रीज में एपिडेमियोलॉजिकल स्टडी किया, प्योर स्टडीज वी कॉल दैट वन। मिडिल इनकम कंट्री, लो मिडिल इनकम कंट्री, हमारी कंट्री लो मिडिल इनकम कंट्री में आती है। वी फाउंड दैट कैंसर सुपरसीड द कार्डियोवैस्कुलर डिजीज। और आप देखोगे इंसिडेंस ऑफ कैंसर हमारी कंट्री में एज कंपेयर टू वेस्टर्न कंट्री कम है, 250 पर लैख इन द नॉर्थ ईस्ट एज मैडम सजेस्टेड, एंड बारसी महाराष्ट्र 49 या 50 अप्रोक्सीमेट पर लैख। एक ही कंट्री में इतना चेंज होना एक सरप्राइज नहीं है। ये एक रिसर्च क्वेश्चन है कि भाई हमारी कंट्री में सबसे कम इंसिडेंस भी है और सबसे ज़्यादा इंसिडेंस हमारी ही कंट्री में है। वेस्टर्न कंट्री में अराउंड 500 पेशेंट पर लैख है, क्योंकि हमारा, फिर मैडम ने सभी पैरामीटर्स बताया, फूड हैबिट, एनवायरमेंटल, यस आई एम फुल्ली एग्री। जेनेटिक्स से आगे और हम बोलते हैं एपीजेनेटिक्स। जैसे कि आप एक क्वेश्चन में आपसे एक लाइन बोलता हूं, रोको मत जाने दो, रोको मत जाने दो, दोनों सेंटेंस 100% इक्वल है कि नहीं है? थिंक इन द जीनोम, जो ट्विंस हैं, मोनोजाइगोटिक ट्विंस हैं, उनका जेनेटिक प्रोग्राम 100% सिमिलर है, लेकिन एक पेशेंट को कैंसर हो गया, दूसरे को नहीं हुआ। क्यों भाई? ये जो मैं सेंटेंस आपको बोला ना, रोको मत जाने दो, रोको मत जाने दो, कोमा का ही तो इधर से उधर हुआ, दिस कोमा कॉल्ड एपिजेनेटिक मार्क्स। सो ये जो एपिजेनेटिक मार्क्स हैं, ये इधर से अगर उधर हो गया तो पूरा जीन, इवन जीन में म्यूटेशंस नहीं है, फिर भी फिनोटाइप चेंज हो जाता है। तो ऐसी प्रॉब्लम्स अब कैसे होती हैं? ये होती है हमारी लाइफस्टाइल से। आज का देखो फूड हैबिट, जैसे कि हमारे यहाँ फीमेल में ब्रेस्ट, सर्वाइकल, ओवरी, फीमेल में लंग, और मेल में लंग कैंसर, ओरल कैंसर। लेकिन अब हमारे बच्चों में कोलोरेक्टल कैंसर भी आ रहा है। क्यों आ रहा है? टुडे फूड हैबिट जो हमारी हो गई है, पिज़्ज़ा बर्गर जो कल्चर आ रहा है, ये ऑल अफेक्टिंग आवर लाइफस्टाइल जो हमारी चेंज हो रही है, उससे सारा ये एपिजीनोम भी हमारा चेंज हो रहा है, और ये इनहेरिटेबल है, एक जनरेशन से दूसरी जनरेशन में जाता है।
डॉक्टर शर्मा, आपके साथ पूरा पॉडकास्ट करना पड़ेगा इन चीज़ों को समझने के लिए, और मुझे ये विश्वास है कि अगर आपके साथ पॉडकास्ट किया जाएगा तो ये बात लोगों तक बड़े अच्छे से पहुंचेगी। रोको मत जाने तो बहुत समझ में आएगा। थैंक यू। अभी तो मैं आई विल जस्ट रिक्वेस्ट यू टू कंप्लीट हियर, क्योंकि वी हैव ऑलरेडी स्पिल्ड ओवर द टाइम। तो क्विकली 2 words maybe, how you see the India's cancer prevention, cancer control, cancer system improvising, becoming strong, becoming effective, becoming strengthened, and helping India fight cancer and effectively. उस पर 2 वर्ड आप सारे लोग एक बार बोल दें और उसके बाद we close the session. Sir.
No, I'm fairly positive, as I said, that what I've seen the journey in last 1.5 decades, and I'm sure it will not take that long. So whatever is, the progress is exponential rather than being linear. Progression as far as the cancer is concerned. That's my feel. Yeah.
So the journey is not going to take that long as we have to. Wonderful.
Well, the theme for the World Cancer Day 2025 is United and Unique. And I think that's very important because significance of patient-centered, individualized care. We need to move towards that also. And as I see the journey, we have come so far, and we are fast advancing. And let us see that the deaths are few when the treatment is there, because that has been a major concern.
Wonderful.
So I think we should work towards
Wonderful.
that. Thank you.
So we are going fast, we are marching fast, we will be able to save more lives.
Few things. I already said about the education system in which the super specialty of cancer is being given importance, and hundreds of oncologists, including medical radiation surgical oncologists, are coming out each year. That's number one. The second is, when we joined 30 years ago, there were hardly 110 or 115 radiotherapy centers. And now I think they're crossing 800, 900. So there is an exponential growth, and things revolve around radiation oncology centers. And finally, I mean, as United by Unique is the theme for, 4th February this year, and continue for another 2 years. And each cancer patient is unique, which needs to be identified by doing NGS, next generation sequencing, not only at the tissue level. What you have to do is to go deep sequencing by doing blood DNA testing to look at minimal residual disease and target the tumor mutations there. That is where you're going to succeed in the end. And that's, I think, the dream for the next 40, 50 years to take care of cancer cases.
Wonderful. So every patient matters, and we have to look at that unique case.
Absolutely.
And go.
Absolutely. Each patient is unique.
Wonderful. Wonderful.
So two things. One is equitable access to care. Right? I think equitable access. I think program like Ayushman Bharat has to penetrate more and expand more. That is one. And second, what you have written, rapid. I think we need a rapidity so that we can save few people, or we can add life to few people by the time this program.
So we are increasing our army, we are moving, marching fast. We need to march rapidly, and we need to, ensure that equitable care to reaches to every unique patient.
2 points. One, we adopt the technology like artificial intelligence to give the personalized treatment to the patient. Second, we need a teamwork. Together, everyone achieve more. अगर हम टीम में वर्क करेंगे तो definitely we make our country cancer free.
Wonderful. So we as a team, India, we as a team of all those who believe that health is the fundamental of whatever we achieve as human being, as a nation, as a society, and that's where we need to build a really healthy and equitable country which can achieve the dream of डेवलप्ड नेशन. तो आपने अभी बोला कि इंडिया मिडिल एंड लोअर इनकम कंट्रीज़ में आती है, तो ड्रीम हमारा है कि 2047 तक हम भी डेवलप्ड नेशन बने. तो डेवलप्ड नेशन तो तभी बनेंगे जब हम इन समस्याओं को, इन चुनौतियों को इस इफेक्टिवनेस से और रैपिडिटी से एड्रेस कर पाएंगे. थैंक यू सो मच ऑल द वंडरफुल पैनलिस्ट टुडे दिस मॉर्निंग. एंड
वी नीड निरोगी भारत, सो विकसित भारत.
वंडरफुल. निरोगी भारत. जी अच्छा, किसके लिए? डॉक्टर.
I'm not a doctor.
Unnotified as has been, I'll repeat the question. So Ministry of Health has recently made snakebite notified, but cancer still remains not notified. And this is despite 17 states individually notifying cancer. And the reason given by the Ministry of Health is that cancer is not communicable and it does not have community spread. And you mentioned about the NCRP. Only 16% of the country's population is covered by the National Cancer Registry Program, and the casualty is because there's no legal mandate to report the cases. So what is your opinion on this, and when will the country have cancer as a notified disease?
Seems like a lengthy question. I think we can, because अच्छा, तो एक notifiable का क्या हो सकता है आगे? What is the maybe the thought going on?
Suppose people are petitioning the government, so we'll say of course usually the notifiable diseases started with the communicable diseases. So that is the reason probably it has not happened. But for the registries, you see progress We know how it happens. It's happened. Initially all these were with the regional cancer centers and thing. So slowly the numbers are increasing from where I was in government, and now I find, okay, it's already 236 population, hospital base. Earlier there was just 16 of them. So it has taken, and I think that movement itself is about 2012, about 7 to 8 years. So we need to give time. Things don't change overnight.
It's happening. बाकी मैम से आप थोड़ा और डिटेल में.
I am a die-hard optimist. I believe things happen, and it will sing. If we have come this far, we will go further also.
Thank you. Thank you so much for the question, and thank you so much all the panelists for sharing those insights on current trends in cancer in India. Now I request Mr. Narayan to kindly felicitate our guests with a token of appreciation, starting with Ms. Sujaya Krishnan. Thank you so much, ma'am. Can we have the certificate? Ms. Sujaya Krishnan, former Health Secretary, Government of India. Thank you so much, ma'am. Dr. Shyam Agarwal, Vice President, Indian Society of Medical Pediatric Oncology, Chairperson Oncology, Sir Ganga Ram Hospital, New Delhi. Thank you so much, sir. Mr. Prabhat Sinha from Boehringer Ingelheim. Thank you so much, sir. Dr. Ashok Sharma, Additional Professor from AIIMS, Jhajjar. Thank you so much, sir. Dr. Shashi Balian, Founder and Managing Director, Clear Medi. Thank you so much, sir. Now I request all the panelists to join us for a group photograph. Ladies and gentlemen, please put your hands together for such a wonderful session. Thank you so much.
Thank you so much. Thank you.
And now it's time for me to introduce our next session on innovations in cancer diagnosis and treatment. The landscape of cancer care is being transformed by cutting-edge innovations in diagnostics and treatment, enabling early detection and more precise personalized therapies. This session will explore breakthrough technologies such as liquid biopsies, AI-driven diagnostics, immunotherapy, and targeted treatments. Experts will discuss how these advancements are improving patient outcomes and shaping the future of oncology in India. Now I would like to invite on stage our panelist, Dr. Narayana Subramaniam, Director, Head and Neck Oncology and Director of Clinical Innovation from Sparsh Hospitals. Welcome, sir. I would like to now invite Dr. Ravi Gaur, Founder Director, DRG Path Labs. A very warm welcome to you. Please put your hands together. We also have with us Dr. Tejinder Kataria, Chairperson Radiation Oncology from Medanta Hospitals, Gurgaon. A very warm welcome to you. We also have with us Dr. Sridhar Sivabasu, Chief Diagnostics and Research Officer and Lab Director from Keynote. A very warm welcome to you, sir. Now I would like to invite on stage our moderator, Dr. Chirantan Bose, Dr. Chirantan Bose is an expert in creating personalized treatment strategies for patients of advanced and complex cancers based on their molecular genomic profile, and heads the Department of Molecular and Precision Oncology at MOC Mumbai. Please put your hands together for Dr. Chirantan Bose. Thank you so much, sir. Yeah. Over to you. Thank you. And yes, before I leave, may I request the team to kindly show us the presentation? Yeah, thank you.
Thank you. A very good afternoon to everybody. I think we have been having brilliant discussions on the impact of this disease, cancer, from a public health perspective. And I'm very thankful to the panelists for accepting to participate in this discussion. And although a relatively complex area, as all of you are scientists, I have tried to put together certain aspects which will help everybody understand the recent advances and why innovation is so critical in current times for cancer care. So I welcome Dr. Narayana Subramaniam, Dr. Ravi Gaur, Dr. Tejinder Kataria, and Dr. Sridhar to be panelists. And the agenda for this discussion is very simple, and I have divided it into two components, considering why precision oncology is very important in the real-world cancer care practice. And then later on in the second half of the discussion, we will like to have your views on the newer technologies of cancer screening. So just a quick real case scenario so that everybody in the audience can relate to the criticality and the importance of the subject we are discussing. This is a fairly young 41-year-old male who presented at our cancer center with a non-small cell lung cancer, which is one of the most common cancers, as we all know, in India. And the molecular profile showed that there was a particular gene mutation positive, which is the ALK gene. And there is target drug available for this particular genetic alteration, which is called ALK inhibitor. The name of the molecule is crizotinib. The patient was put on that, did well for about 2.5 years, then progressed. Now, thankfully, we have newer generation of each category. Most of the categories of target drugs have newer generation drugs. So there's a third generation of ALK inhibitor also, which is called lorlatinib. The patient was put on that. There was a good response for about 1.5 years, and then last year, about a year back, he presented again with metastasis in the brain and in the cervical lymph nodes. A comprehensive tissue biopsy-based NGS testing was done from the cervical lymph node, which showed again a particular ALK mutation called the F1174L with a significant frequency of around 30%. And a TP53 mutation. So the National Cancer Comprehensive Network, the guideline which we all refer for cancer treatment, doesn't specify actually this particular genetic alteration, but says that you can use second generation or third generation ALK inhibitors. When we interpreted this molecular report, it showed that this particular genetic alteration is actually resistant to the even third generation ALK inhibitor, that is lorlatinib, on which this patient had actually progressed, and that the combination of chemotherapy with lorlatinib could be an effective treatment of choice based on published literature and evidence. Furthermore, if this patient further progresses, then you can use a different category of drug called an NTRK blocker, a molecule called entrectinib, which has shown some benefit in this particular ALK mutation in other cancers. So that is the interpretation that we get. As a personalized therapy, let me share some of the scans of this patient with you. That's the brain mets, and the patient was given a combination of lorlatinib with chemotherapy, that is pemetrexed, followed by a radiotherapy to the brain mets, to which you can see that the brain mets actually responded completely. But after 4 months, this patient had again a relapse with metastasis in liver and bones. And then, as the initial report had suggested, the treatment was changed from lorlatinib plus chemotherapy to entrectinib. And you can see that the entire disease has disappeared. So just so that everybody, when we look at scans, you can see the patient is not here, but you can see that what actually happens through the treatment course. So if I can ask Dr. Narayan, you are part of a large cancer care ecosystem. So how significant do you feel that precision oncology is for cancer care in current times?
Thank you for the question. So I think when we think about cancer treatment in general, there are two things we have to consider. One is, what is the response rate to treatment, be it surgery, radiation, or systemic treatment. So how likely is the patient to respond? What proportion of patients will be cured, that is. And the other thing is, what are the treatment-related side effects, which are also relevant, when we're treating a patient for cancer. So when we look at the evolution of cancer treatment, we have to look at both of these things. So number one, most importantly, we know that patients are living longer and our cure rates have gone up. That can be through better surgeries, better radiation delivery, and through better systemic treatment. But also very, very important is that our treatment-related morbidity has come down. So when we look at patients and the way that they were treated for cancer, say 50 years ago or 100 years ago, unfortunately, even if we were able to cure a certain set of patients, their treatment-related side effects were terrible. So that means that even though we were able to eradicate the disease, the quality of life of these patients, the way that they were able to live their life, was impacted in a big way. So now the focus has to be obviously on increasing the cure rates, but when we look at things like targeted therapies, I think that was discussed in the previous panel, we're looking at how do we get the same cure rates or higher cure rates than the other comparable treatment, but also how do we reduce the treatment-related side effects. So I think for those in the audience who are not aware, the primary difference between chemotherapy and targeted therapy is chemotherapy affects all the cells in the body, right? And the principle is that the cancer cells are dividing faster and therefore they're preferentially killed off. But targeted therapy is acting very specifically on the cancer cells and spares many of the other cells. So precision oncology is very, very important, especially because as patients live longer, many of them survive for longer and then they have recurrences, just like you've shown in your slides quite well. So when we are able to get rid of the disease, unfortunately cancer is a different animal. It's a bit of a sophisticated disease. So the cancer also finds a way to kind of overcome our treatment, cheat our immune system and come back. So when we treat patients the second time and the third time around, it's very important that we are able to make sure that they have the ability to tolerate those treatments, because we've not made them so sick and so unwell with our treatments that we've exhausted all options. And also when we use newer treatments, we are trying to focus on the different ways in these that these cancers have evaded treatment. So it offers us a whole new way to treat these patients. We are now looking at different pathways. We are looking at completely different mechanics that these tumor cells evade the immune system, evade treatment. And the most important thing, I think, is that in a country like India, we are able to do this at a much lower price than abroad. And the reason for that is because we have a large number of patients. So I think it's really important that we look at this. So when you look at the evolution of medicine in general, you always think of how new things are more expensive. Immunotherapy is more expensive, unfortunately. Robotic surgery is more expensive. But the whole point is that when we do it at scale, we are able to make it cheaper and make it more accessible. So precision oncology is something that we all have to focus on, not only from a medical oncologist perspective. I happen to be a surgeon, so more effective surgeries, that are less problematic for the patient in terms of recovery, more specific radiation treatments that treat only the area involved You know, especially in the head and neck area, there are a lot of important blood vessels and nerves that we want to preserve. So I think it's what we should be focusing on. More and more effective, less toxic, better tolerated treatments.
Thank you. And if I can summarize, you do see that the role of precision oncology is set to increase as costs reduce, more effective treatment options come forth. And if I can come to Dr. Ravi Gaur, so what do you feel are the, and to give just a backdrop of, you know, your past work and what you continue to do is, and I've always seen you, I've known you for so many years, I've seen that you are extremely sensitive towards the fact that when a service or when a technology comes, how can it reach the population to its, you know, to various socioeconomic strata. So my question to you is that what do you feel are the major hurdles in incorporating this precision oncology and its technologies for community practice in India?
Well, good afternoon, everyone, and thank you, Chirantan, for making me sitting here and talking to all of you, and for the great initiative by ISW. You know, like we have, if you look at this World Cancer Day, this on 4th, the theme is United by Unique. That's the theme actually for this year. And the theme focuses on individual needs, you know, each patient, unique experience in cancer. And that's what we're talking about, the precision oncology kind of thing. It very well aligns with the theme. Now, you know, like one of the, not one challenge, there are multiple challenges. It's not like precision oncology. In fact, everything we started somewhere in the decade starting 2000, 2010, everything just kept, and it's caught up in last about 10 years, it's really caught up, and it's probably everybody looking forward to. But the implementation, I think, still like lags behind. And, you know, probably one of the statements I've heard from where I am an oncopathologist by profession. We have run oncology lab for many, many years. But when you go to remote place, like somebody talked about in remote Patna, when they say, okay, this is some kind of a target therapy, these kind of a testing mutation studies, वो सब दिल्ली में होता होगा, पटना में नहीं होता, वो आप लोग के लिए. That mindset, actually, this is a basic kind of a thing, because they feel like this is something what you're talking about out of the world. They're in a different world altogether. So biggest problem, like the couple of problems. First is a high cost and affordability. Now this is a new technology, but I'm seeing over last 10 years, the cost which was a test used to cost about ₹1 lakh, now almost come to like 25,000. Like BRCA is one of the cancer kind of a thing. There are many such tests now. The volume going up, scale going up, cost is coming down. But I think it has to be brought to the, you know, common man affordability. This is the one big challenge today. We need to bring it that. Second is like, we had heard ma'am is here and we talked about the government policy. I think insurance coverage is actually not being covered in majority of the insurance. They just, even they don't say it's part of protocol. The insurance coverage, reimbursement, even government reimbursement, you probably have to go to especially to the ESIS, EGHS and make the CMO understand, the ministry understand this test is important for me. So diagnostic is more important to drive a therapy afterwards. How do you understand a specific mutation or ALK mutation or lung mutation or whatever you have, EGFR? Unless you have that mutation to study, the therapy cannot be designed. So I think that reimbursement part, cost covering is very, very important. I think we heard Rajasthan government is, I remember we were part of the Rajasthan oncology awareness. We presented a report to the government and they were doing phenomenal work out there and they're actually working on it. But I think that needs to be strong session. Then, you know, like there are lack of advanced, you can say, diagnostic facility. We do have a facility like Delhi, Mumbai, rapidly increasing. Our scale of services are being, but still a lot of tests are being sent abroad for the testing. But I think that's something, because why? We have technology, we have skilled people. Probably we need to understand, generate more of the middle-level workers and awareness. When we have this, you know, the qualified people, the skilled people, understand that this is going to be future need. What the numbers are saying, the cancer is going to be like, you know, phenomenal number, mortality, morbidity is probably the #1 as of now when it comes to the cancer in India. Then the skilled force I already mentioned about it. Regulatory and ethical challenges. I think there is, we had discussed some time back, but we've been discussing, what are the standard regulation? Do we have a standard protocol for treatment? today there are multiple oncology diagnostic centers coming out with various kind of permutation and combination of therapy. I know we have clinicians sitting here, they'll also understand, because there will be some kind of standardization. If this is what is there, this is how algorithms will be driven, at least one protocol or two protocol can be driven. And after that, we leave it to the expert oncologists and people, let them derive, let them come out with a customized solution. But I think there's no definite protocol today. I think, somebody says I have to do 540 genes, somebody says I have 60 genes or 80 genes, all this kind of. It's a confusion as on the market. I think we need to clarify that. And this is probably the event like you are doing work. We are all working in that direction, but a lot need to be done at the central level. When it comes to the acceptance, probably still, I think I still remember 5 years back, one of my colleagues' mother had pancreatic carcinoma, Shyam Agrawal sitting here, he just left. He advised that time immunotherapy. Oh, no, immunotherapy, don't touch my immunity. As such, it is down, I'll die. They never went for CAR T therapies at that point of time. But today, I think that awareness has come. It's not like, killing your immunity, because it's something probably helping you out, immunotherapy is coming out. So that public awareness, I think people are well read also today. We have technology, campaign, net, everything is all out there. Then lastly, I think limited research and data. Probably we don't have indigenous data today. All the technology or things have been developed with the Western data. Do we have Indian? Because India has is a diverse country. I've come from a field of oncodiagnostic where east, west, north, south. Probably the genetic things, everything different. Environment is different. Eating habits are different. Everything is different out there. In fact, if you remember, we had the triple negative breast cancers. If you remember that. Because India was the one who said, we said like about 25%, no, it cannot happen. But we did a study across in 2008, 9, 10 with various important KOLs and we realized this is the data. And today accepted. The triple negative breast cancer also are there. And this is, I think, Indian data, I think we need to put funds into it, work around, and probably collaborate. I think collaboration between the research, academic, institution, policy maker, manufacturer, diagnostic provider, treatment. I think all have to come to one forum. This collaboration helped what we have seen in COVID. Right from end to end, everything was collaborated. Everything which is part of this chain, they can cure and be one of the COVID. And I'm sure together, if we can collaborate together, make a standard protocol, and variation, deviation will happen, but at least something, a collaboration will help, and that can lead to the community practice acceptance in India.
I think, thank you so much, very powerfully said, and I think what you said in the end, collaboration in this field is something which is, especially in an Indian cancer care ecosystem, where we know that we do not have sufficient funds to do cutting edge preliminary research or translational research. It is only through collaboration that we can really meaningfully expand this field. Thank you so much. Moving forward, Dr. Tejinder Kataria, if I could come to you, you're also from a large cancer care system. So the example that I gave actually had a lot of different things, and initially what was mentioned, the role of surgery and then radiation and then finding out iterations of medical treatment. So what do you think is the importance of this multidisciplinary kind of tumor board approach? Each of our hospitals nowadays has this tumor board, but how do you see that this is important for tertiary cancer care in India?
So thank you IHW and Dr. Bose for having me on the panel here. I've enjoyed the morning discussions and also these questions that are being put forth to us. The multidisciplinary tumor boards emerged in late 70s and early 80s, and they were being held at tertiary care centers because I was trained at PGI and we used to have 3 or 4 per week multidisciplinary cancer care clinics. We would have it with, for a lymphoma, for ENT, for a gynecological cancer, and head and neck cancer. So we used to have a very limited, kind of exposure to these departments if we didn't go to the tumor boards. And taking that forward to today, that is 40 years on, they have become almost a mandatory protocol for most of the tertiary cancer care centers to be able to offer the best treatment and the standardized treatment to a patient. Because the patient may be seen by a surgeon, a radiation oncologist, by a pathologist, a radiologist, or a medical oncologist. And then there is molecular plethora of tests that are being done, the genetic mutations that are being offered. Case in point that you have shown us, that along the journey of the patient, the mutations may occur. So you may give a standard treatment, but then there is either oligoprogression or multi-site progression, or the patient's mutation burden changes, or the genetic mutations that occur are not actionable or they are actionable. So all these things have to be collated together. So there is a big role for multidisciplinary tumor boards. And earlier it used to be only the clinicians and the pathologists and radiologists who would attend. But today it's very important that we have the geneticist and the molecular biologist also attend the program. If we don't have them on board, then it's better to engage with an organization where we have a person available by telemedicine to interpret these results. Because these tests, we are able to find the targetable mutation, but whether the targets that are available, they would respond to the drugs that are available or not, that is another question. So we may be able to precisely find out what's happening to the tumor, either by the retissue biopsy or by the molecular biology from the liquid biopsy, but whether the patient is going to respond to the drug or not, like in the case that you have shown. And secondly, we bring in radiation for, patients' unmasking of the immune system and assisting these targeted drugs to engage with the body's immune system. So that is what was expected in this patient, but it was an intracranial target. Maybe if it was an extracranial target, the patient would have responded to lorlatinib further on. We don't know. That is a moot point. And the challenge is that we have these targets, we have the precise knowledge, but in a study from France, Moscato study, it was seen that in breast cancer, 47% of the patients expressed some kind of genetic mutation. But when they were brought to these multidisciplinary boards, only 27% of the patients could benefit and were administered the new change in the drug. Because there's a cost to the new medicine, there's a cost to the response. And if the morbidity increases, these drugs are not without the morbidity, especially the immune agents that are being introduced. The TKIs are a different game. Their toxicity is less. But with the immunotherapy, we understand, even with a drug like Pembro, which has been there for 10 years, that the immune response that may come in may cause a patient to become more ill and go into the ICU rather than respond to the treatment, to the drug, to the disease site. So I think going forward, we have the challenge that how we integrate all the information, right from the patient's clinical presentation, to imaging, to histopathology, to immunohistochemistry, to molecular biology, and then thereafter the progression. And that has to be done across the table in the multidisciplinary tumor board or the molecular tumor boards as they are emerging now.
Thank you so much. I think that's, again, a very important point, and you, as a cancer care specialist, do agree to the significance of this. But also, I would like to highlight and share with the audience here that many times, oftentimes, the patient actually doesn't realize that so much is happening behind the scenes. We run a network of over 25 cancer centers across Western India, and now sort of, also envisaging into Northern India with Delhi NCR. We have multiple tumor boards every week, twice every week. And all patients don't know that their case is being discussed by a team of around 40 medical oncology and molecular oncology experts, and oftentimes invited surgeons and radiation oncologists. So that entire, I think, distillate of knowledge that goes into the patient care, the patient may not come to know, but benefits out of it. So, so I think, thank you for reiterating that. Coming to Dr. Sridhar, I think one of the very important questions, and we all are, I think, representing the molecular oncology laboratory science significantly here. So what do you feel are the challenges that, and this question is specifically for you, because standalone labs, which are so pivotal in today's times, we don't have many of these tests, as was mentioned earlier by Dr. Ravi Gaur, that many tests were historically being exported. We used to send out the samples. So as a standalone lab, what is that pivotal role that you see is there in precision oncology in current times?
Thanks, Dr. Chirantan Bose and my fellow panelists and organizers for putting this together. I've been listening to all the inputs, and some of the inputs that Dr. Ravi Gaur gave was very pertinent to this particular question that you're posing. But to add on to that, I'll add challenges as well as the advantages. I'll address the challenges first, then the advantages. So standalone labs are sort of, you can see them as center of excellence in a very focused area, okay, because that's how they evolve and have an expertise. But let me narrate you back the same case that Dr. Chirantan was presenting. Okay, probably the assay was done at a standalone lab, the treatment was done in a hospital, and the patient has the freedom because he's paying out of pocket to probably go to another hospital also, and maybe multiple clinicians. Remember the test that is done, the genetic test, okay, carries a lot of information. It's not about a single gene that you do a panel, okay? And there is a lot of information in there. Only a small subset, a very minuscule subset actually gets into the report. Rest of them remains in a database. Okay? So we have to connect with the primary data generator so that as the patient evolves through the journey, we are able to connect back to that original data. The germline data does not change barring a few cells in our body right from our birth to the death. The somatic mutations do change. So now you have to interpret these two both, because you saw how the somatic mutations kept on coming new. So there is going to be an interplay. So one of the challenges that individual labs need to address is going to be, how do we get together and collaborate with our service providers, which is the hospitals, as well as the patient, educate them that you have done this test, don't repeat it again and again, come back to that original test, maybe work together to see if you could mine the data. If there's a resistance mutations, probably it was there earlier on, somewhere in the germline. Now there are implications coming on. We need to go back to that database again. So that's one of the key challenges. Second challenge we actually face is that not all clinical information gets submitted in a single time point when the test is prescribed. It's an evolution of the patient journey. Okay? Now, every time there's a new symptom showing up, it's important to go back to the data. And usually that is not done. Okay, and no harm to anybody, no fault to anybody. The patient usually goes to the new hospital. Again, the test gets repeated. It's a financial burden, and we have seen that in multiple occasions. Patients carrying multiple tests. Why did you do this so many tests? You could have benefited from one of them if you went back to the same clinician or the same lab. So that collaboration, the synergy is beneficial for the patient as well as the network of stakeholders involved. That's the first challenge that we need to, and imbibing the clinical inputs right at day one. We don't get it. Many clinicians question, why do you need the clinical input? We asked for a test, please give us the test. If the clinical inputs come in, okay, we would know we could interpret it much better. Rather than putting it what we call as variants of unknown significance, maybe try and convert some of them into some kind of a significant correlation to that patient. Those are the kind of challenges that we face, but on the advantages side, okay, standalone labs like both Chirantan, Dr. Ravi Gaur rightly mentioned are centers of excellence. You can move very rapidly, unlike a large tertiary hospital where multiple forces can play in before you imbibe a new technology. You get to move rapidly. But in the rapidness also lies the fact that you can offer a very competitive test that was developed elsewhere in the world, or self-developed test can be validated and put forth. So those are kind of things that you could move very rapidly, work with hospitals on and out, work with government setups, work with private setups. All of these can be imbibed very quickly. I'll stop there. Thank you.
Thank you so much. I think very important concluding note on that there are gaps in information transfer, and those gaps can impact in larger ways than we anticipate. You know, like gap in transferring clinical information from the hospital to the lab, and even the lab with back-end so much of data in genetics that is being generated, but that may not be transcribed into a meaningful clinical interpretation. So I think that's food for thought, and of course with so much now effort and work and investment coming in AI and technology, we will soon see changes in that. Now, I think the second part of the discussion is more interesting, but we have less time, so we'll just quickly go through. And that is an innovative area that I intend to touch here is the point of cancer screening or early detection. So, you know, the single most frustrating question for a cancer patient for which the definitive answer is always a positive yes. What is that question? Could things be different if I were diagnosed earlier? The answer is always yes. And a positive yes, that yes, things could be positively different if you were diagnosed earlier. The single most frustrating question in an oncologist's mind, for which again the answer is always a positive yes, is could things be different for my patient if she was diagnosed earlier or he was diagnosed earlier? Always a positive yes. Early diagnosis is going to benefit. So I think there's a lot of work happening with that platform set. I would like to take a step back and talk about conventional cancer screening practices also before I hand over or go to my panelists. Are conventional cancer screening practices enough? Mammogram sensitivity is just between 70 to 95%. That is, you can miss as many as 30% patients harboring early stage breast cancers with mammogram. And again, we all know that there is a lot of skill set requirement, technology requirement, a village, a tier 2, tier 3 city mammo may be totally different from what happens at a premier center in Delhi, NCR or Mumbai. Specificity is also an issue. 10% may be false positive. So that is PSA for prostate specific antigen for prostate cancer sensitivity is less than 50%. So you really, you know, because it's the only technology, so we rely on that. Colonoscopy, although, you know, not that prevalent in India as a screening practice, but the sensitivity is as low as 75 to 90%, depending on what size of the growth are we talking about. And these are NIH data. Now, currently about 15 lakh individuals in India, new cases are detected every year. And there is a huge dismal scenario that most cases are not detected early but come to us at late stage. How are the statistics? 40% of breast cancers are detected in late. When I say late, you can, as a thumb rule, take it as stage 3 or stage 4, not stage 1 and stage 2. 70% of lung cancers are in late stage, 65% of colon cancers are in late stage, so as rectal. Cervical cancers 60% in late stage, and prostatic cancers about 35% in late stage. So we have not done a good work so far in early detections. Some of the new technologies which are making waves and which we would like to touch upon in today's discussion is liquid biopsy, where you can take a blood sample from an individual and you can pick up cancer elements from a blood sample. There are many elements you can pick up: cancer DNA, which is called ctDNA, circulating tumor cells, other nucleic acids like RNA, exosomes, etc. But ctDNA and CTC have come to the forefront now, and there are labs and companies which have incorporated this. So it is just that the tumor cells start breaking off very early in the disease and come into the bloodstream. Now we have the technology to pick up these 1 in a million cells relatively with high sensitivity and specificity. That is circulating tumor cell. And just to end the introductory information is that you can use these circulating elements all through the course of disease, from early detection to monitoring how the treatment response has been, whether these elements are going up or coming down or are stable. All those information can also be detected in an ongoing basis with a simple blood test or blood sample. So, sure. So quickly, we'll have maybe just a minute to each of you. Again, starting with Dr. Narayan, how do you see the potential of liquid biopsy in cancer screening? First, a quick yes and no, and then your comment on that.
I think it's there, little futuristic, probably like Hyperloop or any of the other early emerging technologies. I think it's very nice to think that we could, detect cancer with a single blood sample, as opposed to doing an invasive biopsy or a mammogram or an FNAC or a CT scan. But the thing is, we are not there yet for most cancers. And the reason is very simple. We don't understand what happens when these cancer cells break off. We don't understand what kind of cancer cells we are looking at. We don't understand what the implications are, as opposed to the existing gold standard. I think we need a lot more research, and I think a lot of that money needs to come from the government and from academia. The problem is a lot of the money that's going into emerging technologies is from industry, and therefore it's difficult to really do base level translational work.
Yeah, thank you. You see it as a potential technology, but then there are hurdles, and that's where we come to Dr. Ravi Gaur. What do you feel are the major hurdles in bringing technologies like liquid biopsy for community cancer care in India?
I think liquid biopsy, as what we're talking about, everybody talks about India now, is one test, one health. I think it's a very good initiative, but the challenge remains a lot. I don't think it's going to take a lot of time, to my mind. What I mentioned, because the technology is there, but the tumor heterogeneity, what kind of tumor is shedding, which tumor is shedding this ctDNA, which is not shedding, there's another issue. What technology and platform you're using to extract that kind of a thing, the cost, validation, the trials, and whether it's a part of protocol. I think these are, very, very important issues, because that's not going to be easy for that. So I don't foresee today, in immediate at least 5 years, independent, yes, there are for the lung cancer we have, brain something you have, but overall something, there's no actually screening test for the cancer. Cancer screening, when a patient comes to the doctor, can you screen me for cancer? What do? We have multiple things. And still we come out 80%, 20% is still. Now, will somebody survive knowing that that person has got 70% risk of cancer? He will die before that. So that's another issue. So I think it's going to be a challenge. But yes, we can't get away with this. What we need to do it, there are various biomarkers. Maybe you can use, instead of blood, we can use saliva and body fluids together. And all the AI biomarkers, liquid biopsy, genomic, put together an algorithm. Probably that will be a faster adoption and a screening. And lastly, most important part is the ecosystem. Now, why I'm saying this? Because somebody does if you're part of a health screen checkup or liquid biopsy. Now, if there is a false positive or a false positive report, what will happen? It goes back to your records. Now, anywhere you go, probably say, insurance guy sitting here, he says, no, 3 years back, your biopsy said you're likely to have breast cancer 70%. You're gone. Your insurance is fixed up. That's the problem. Because how do you make sure that the entire ecosystem works? Somebody at a higher risk of breast cancer should be given much more benefits, some kind of a benefits kind of a thing. So that so people don't hide it. They don't want to be. We should actually bring it and create an entire environment of everybody so that it's acceptable. Otherwise, it becomes a challenge today. But we can't avoid it. We should definitely have it.
Thank you. Thank you. Quickly moving to Dr. Tejinder Kataria, ma'am. How do you see, first of all, again, as your vote, do you see that this technology, liquid biopsy for early cancer detection, is a meaningful technology, yes or no? And then how do you see there's a gap between what Dr. Ravi Gaur also mentioned between technology and practice. Your quick comments on how that gap can be bridged.
So to your first question, yes, liquid biopsy has answers for early screening, but it's future, right? We still have to get there. Now coming to the second part of the question, that what is the gap and how do we bridge it? So whenever there's a new technology, how do we take it to practice? There are certain steps we take through. One is that we create interdisciplinary cross-sectional teams. We develop a standardized vocabulary. We train the trainers. And those trainers then go out from the technology perspective to the practitioner and train them. So all these standard operating procedures have to be laid down. And then we need the finance, then we need the regulatory approvals. If we have to take it to the last dispensary in the country to have a liquid biopsy. We have to have it validated over thousands and thousands of patients to say, yes, if this test is positive, A, B, C, the patient's probability of having cancer breast, cancer ovary, cancer lung, cancer pancreas is X percentage, Y percentage, and Z percentage, so that we don't fall through the trap of what Dr. Ravi Gaur elucidated. So I think the short answer is yes, it's required, but we need to be very cautious when we are taking these baby steps to take it from the labs through whatever platforms, whether it's AI platforms, whether it's human platforms, or whether it is to the remotest of the villages. We need to be very sure of what we are going to deliver and what we are asking.
Very, very critical, and I think that information gap is again what is being highlighted here, that science is there and there is a potential practice. How do you bridge that gap? Closing with Dr. Sridhar, what is the message that the industry should get when there are so many private companies that are pitching for liquid biopsy? What's the message for the industry?
So, just removing the myth around it, liquid biopsies have been around for quite some time, very popular. The famous test that we do for NIPT, non-invasive prenatal diagnosis, is a liquid biopsy test. The same principles applied here in cancer too. But if you see, why did that test take off so nicely in the country? Because there's a regulation around it, like Dr. Gaur mentioned. There is a practice and a SOP, and the protocol is laid down. So it becomes easy to implement for government, it's easy to imbibe for private players and provide a report. What is happening in the cancer situation is that it's an evolving field, so it's moving rapidly, too fast. So we need all of that to fall in place. But having said that, genomics tests like liquid biopsies are integral to cancer diagnostics. It will be, but it has to be affordable and accessible and comes with the regulatory mechanisms so that people can imbibe it, labs can provide it, and hospitals can prescribe it. I'll stop there.
I think that note of requirement for regulatory, requirement for consensus guidelines is, echoing through the panel, and I would thank all of you for, these valuable insights. And in the interest of time, I know that, please, sir. So I think, we are looking at a very positive future for precision oncology and its implications for cancer care across the country. And I thank the audience. Dr. Kaur, please,
I'll just take 1 minute. Great discussion. But I think, being on occasion of World Cancer Day, I have put 2 lines, not more than that. Because today, what we have is, you must have all read a book of cancer by Siddharth Mukherjee. Is it right? Cancer is emperor of all maladies. I think Raja of Raja nahi hai. That's one very, very sure. We are all trying to break it down. You please go out. But that's, I think, fight is on. But beyond the cancer, there's a promise of, beyond a battle of cancer, the promise of hope. I have just a few lines, a narrate before message to all. Cancer, because based on the theme, united, unique kind of a thing. Cancer is a shadow, cold and deep. Cancer is a shadow, cold and deep, stealing dreams, making hearts weep. Yet within each fighter, strong and true, burns a fire no fear can subdue. It's not just a war of blood and bone, but silent battles fought alone. The sleepless nights, the whispered prayers, the longing for someone who truly cares. Awareness is more than words we say. It's standing beside them, lighting the way. We need to be with them together. Not just in labs or therapy halls, but in the strength that never falls. We have to give them strength, and people have to come out of the strength. With diagnostics that see beyond, and technology that helps the fight go on. With diagnostics that see beyond, and the technology that helps the fight go on, hope grows stronger day by day. Together we fight, together we stay. Thank you so much.
Thank you so much, sir, for those words of wisdom. Thank you, panelists, for your unique contribution to the session. Thank you, Dr. Chirantan Bose, for moderating the session. And now I request Mr. Narayan to please felicitate our guests with a token of appreciation, starting with Dr. Tejinder Kataria, Chairperson, Radiation Oncology from Medanta Hospitals, Gurgaon. Thank you so much, ma'am. Thank you so much. Dr. Sridhar Sivabasu, Chief Diagnostics and Research Officer and Lab Director from Karkinos. Thank you so much, sir. Dr. Narayana Subramaniam, Director, Head and Neck Oncology and Director of Clinical Innovation from Sparsh Hospitals. Thank you so much, sir. Dr. Ravi Gaur, Founder Director from DRG Path Labs. Thank you so much, sir. Can we have a big round of applause, please? Thank you. And now Dr. Chirantan Bose from Mumbai Oncology Research Center. Thank you so much, sir. Now I request all the panelists to come together for a group photograph. Please come forward. Thank you. Thank you so much for such a wonderful session. Thank you. Thank you, Mr. Narayan. And now let's move ahead with our next segment. Now it's time for keynote introduction on global cancer control presented by Jinaventa Health Private Limited. Well, cancer remains one of the most pressing global health challenges requiring a unified effort in prevention, early detection, and advanced treatment strategies. This keynote will delve into the evolving landscape of global cancer control, exploring innovative policies, cutting-edge technologies, and collaborative frameworks that are shaping the future of oncology. With a focus on strengthening healthcare systems and ensuring equitable access to care, Jinaventa Health Private Limited will present key insights on driving impactful solutions to combat cancer worldwide. Now please, ladies and gentlemen, put your hands together for Dr. Shubhankar Sood, co-founder and Chief Operating Officer from Jinaventa Health Private Limited. Over to you, sir.
Fantastic. Can you hear me? All right. Thank you for staying back. I know I'm the only thing between you and lunch, so I'll keep it short and brief. Let's see if the slides comply.
Have the presentation on screen, please. It's there. Thank you.
All right. So first of all, I'd like to thank IHW Council for having us, Jinaventa Health and the German Cancer Research Center, present some of the insights into the research we do and also how we plan to bring such initiative to India. I think it's a perfect follow-up to the panel I had before with some of the thought leaders and the experts in India building a similar ecosystem. So that's essentially what I myself, Dr. Shubhankar, I'm a researcher into hemato-oncology. My lab focuses on big data and AI, and essentially what we're trying to do as a national practice in Germany is what we like to get to India and scale with it. So that's what I'm going to talk to you about how we envision such a solution to look like and how we want to build an ecosystem around it. Right, so starting and talking about insights and advancement, I thought it's only fair to give you a little journey of how Germany got to what it's doing in precision oncology today. So very, very briefly, we started off, this is even a decade and a half ago, so not a long time ago, in Germany, the standard healthcare practice was, very much resonating. Some of the terminologies we heard here in the first panel was again based on the three main pillars. Either it was chemotherapy, was radiation, or it was surgery. So this was independent of the type of cancer, the classification associated with it, and that was essentially the major kind of options the doctors really had, and this was a national practice. So what I wanted to share very quickly was, this did have an effect. So there's with the graph, you can clearly see there was difference in, there's some positive, but the point being in between 2013 and 2015, as an example, chemotherapy prescribed to, almost of the 100% of the cancer patients, only 30% of them actually had a positive response. So it was useful. So it's a huge basket of 70% which were not responders, or even more where the side effect was huge. This, at a social country where the healthcare is a national agenda, was also a huge financial burden where you provide quality of care but it doesn't really help the patients. So that was where we were about a decade and a half ago, and that's essentially where in Germany we started with a national, nationwide program for precision oncology, which here in the graph you can see the different centers. It's our center, the German Cancer Research Center, short form for the DKFZ, is the epicenter where we prescribe precision oncology therapies for the whole country, and we centralize it through that framework. What we learned essentially, when we talk about precision medicine, we learned that the mutations, the finding of the driver mutations, again resonating some of the aspects spoken earlier, was very important in classifying even what standard therapy was useful to. So the standard therapy at that point was still chemo, but we knew where the chemo was more efficient. The standard therapy could still be surgery, but we knew which patient it might not work that well. So that was a huge positive leap for healthcare, and that led to more efficient treatment matching, more better survival, and also reduced healthcare costs. I'm trying to show this with the survival plot here, where you see the difference was dramatic. So this is where our ecosystem came into play, but again, it wasn't without its own hurdles and learnings. I must say, I think some of the points we heard earlier, which is very much pertinent and useful to India, was exactly where Germany was at, where we had to learn what, the concept of precision oncology is wide. What amount of precision, what amount, of ecosystem collaboration do we need? And that's essentially what I'm trying to point out here, where different institutes, both our institutes were the epicenter, but we came up with the whole collaboration ecosystem with the diagnostic players, the healthcare, the pharma collaborating onto developing a pipeline of what we believe precision oncology could really do. So I'm going to go it's a complicated slide. I'm going to give you a touch upon the major aspects. We realized when we talk about precision, it's what amount of heterogeneity. Are we talking, between two different tumor cells? Are we talking across different tissues where a tumor could metastasize to? Or are we talking interpatient? All of these are different layers which we try to include in our pipeline. And I think another important point which the panel mentioned, what amount of sequencing? Do we do NGS sequencing for everybody? Do we take into account other layer of omics, and to what degree will this be merged? Especially for a healthcare system where the taxpayers' money is being used, this was very important consideration. I think that translates beautifully also to the Indian setting where affordability was a major factor. So that led to a comprehensive data set. So we had a lot of data from patients, be it from the omics, be it the standard care. What techniques do you use to really analyze and assess that? So that's where machine learning and AI came into place. I'll give you a couple of examples of how that really worked out, but I'd say maybe I'll ask Dr. Daniel, who's going to be presenting later today. He's the pioneer of some of the techniques. He's running the national pipeline. He's going to be telling you about some of the technologies they have developed, how they managed to scale it nationally, and what were the learnings in the process. So that I'll leave to him. But what I really want to point out very quickly is, great, we've done such over 20 years we've been working on this. What have we really achieved? What are the key learnings that we can now translate to a bigger country where the population is different and hence the healthcare needs are different? So very quickly, we've started the national pipeline in Germany. So this, again, is a national approach where different collaborators have one ecosystem to work on. This was fundamental, not just to know what therapy works fantastic, but also to know what doesn't work, so that the next center could prescribe less of those, or for the healthcare to know what further investment was needed. And then I think another important factor being most out of the 1,300 patients in the last year, 80% of them received personalized therapy recommendation through our pipeline. So that's another huge achievement for us to show that the doctors and the healthcare system is able to accept such a practice and was adding value. Further, I think it was also important to know that there was new clinical trials, again, which was Germany specific, because we had German data now to ask German questions about the population. This was not possible earlier, where we used an average for the globe. So this kind of a healthcare approach, we believe, could add tremendous value to the diversity of the population here. And so that's essentially also some of the key advantages of just having comprehensive care. In the true sense, it was comprehensive, not just doing more diagnosis, but efficient, smart diagnosis. Not all BRCA mutations need a whole NGS sequencing, but not all of them are using the same therapy either. So it had to be this balance of what amount and layer of information was needed. I think that's essentially what a program captures very well. Right, so I think this was just to get everybody on page of where we come from, what we've been doing in Germany, but it was very important now to both translate and titrate it for an Indian specific question where the demand is different, the challenge is different, and I think some of the words I mentioned here is also what resonates, what were some of the major topics we've discussed. So the question is, how do we get in our technology and scale with the ecosystem here to address some of these challenges? So yeah, I think this audience needs no introduction of how big of a burden cancer is to the Indian population. Just to put in some stats in there, it is definitely a huge burden on the healthcare system, but also a growing burden. But also I think what we have learned, with India also has a huge potential where the healthcare system is very open to accept novel technologies. There's rapid collaboration happening. There's a strong support from the government. And I think this kind of makes it a niche where such modern technologies could be adapted quicker. And I also can say that it could almost leapfrog into how it's done with the vaccine. This precision oncology could be one of those verticals, is at least what we envision. So this opportunity and this problem is what we plan to solve using some of the established pipelines. What the offer of Gina Vinta Health essentially is to build an ecosystem. So starting with this ecosystem, the first step is clinical solutions. The clinical practice available, the data, the diagnosis, the amount of diagnosis, the amount of therapy given over longitudinal through a cancer patient's whole lifetime is something we want to provide through a clinical solution platform, through an informatic platform, which essentially merges our German data set, which is about 2.4 million patients longitudinal. So I'm talking not just about cancer patients at time of diagnosis, but monitoring them about 20-25 years. So we can now start asking questions which previously were just not possible in an average-based scenario. And that's essentially what we want to do with the clinical solution platform. So again, sorry for the complicated slide, but I'm a scientist. I had to give you a little idea of what the intent really is. I think what we want to do with our platform essentially is redesign it particularly for India. So essentially we have the diagnostic infrastructure well established in India, merging different amount of diagnosis, not just genomics. You need to have pathology, you need to know the imaging portfolio, etc. All of those essentially merges onto our data sets where we go away from percentages and frequencies of what is good versus bad, and rather our AI model essentially maps it onto a longitudinal data point of patients. So essentially we map patient journeys, and that's essentially what we can do with our AI models, which is established and is practiced as a standard in Germany. So we've tweaked it and kind of titrated this for the Indian healthcare system, where we believe collaboration within the system to produce some of the data sets is possible. The healthcare system in India is already producing some of the biggest data sets in the world in sheer volume. Is the idea of can you combine it into a platform that makes it useful for the doctors now. That's what we want to do with our platform. We call it Gina Vinta One. We've essentially made it into a web-based interface where doctors could interact, get smarter diagnosis, find out which patient at what time point needs what more diagnosis. Not all patients need the same amount, even though the driver mutation is the same. Plus, very importantly, it gives you therapy recommendations certified through a molecular tumor board. Again, this could be available to patients anywhere there's a diagnostic report happening. Tier 1, Tier 2, Tier 3 cities. And that's essentially what we feel is very important to scale this throughout the country for the people who need it the most. So that's the Gina Vinta One platform. Again, I wanted to give you a quick example of how useful such a platform is. This is data set from 2021 of how a platform in Germany helped. What you see here in green is if a clinician follows recommendations from our pipeline, or if a clinician chooses to follow in blue only part of the recommendation, or if a clinician in red chooses to follow none. What you can clearly see is the value addition to the survival, both in terms of progress-free and overall survival. So definitely adds value to the quality of life of the patients in significant terms. I really also want to point out here, this is again ballparked, and the numbers are predicted based on the German standard of care already, which involves the diagnosis wasn't the variation, the only variation was interpretation. So we feel in India this difference would be even bigger. The value we can add to the patients instantly is huge. So that's essentially the promise of the Genavinta One platform, an informatic platform integrating the ecosystem here into meaningful diagnosis and a smarter interpretation of what therapy needs to be given for the patient. Right, so I think another question which is equally pressing, especially for us coming from a research institute, is about the future. When we talk about healthcare, we talk about AI, big data, new research happening. I think another major challenge we feel is representation. A representation of data sets we see here defines the future of what medicines will be produced, what medicines are going to go into clinical trials, what new therapies are going to come out, and that's where we feel India needs more representation. Let me explain that further. What I'm showing you here essentially is a graph from WHO of the total mortality. So this is total mortality rates across the world. What I've superimposed on them is the ratio, is the percentage in the last 5 years of how much the data sets of each of those countries and continents contributed to new clinical trials. You can see the difference is staggering. The disproportion between the countries affected versus the data sets used for new drugs is huge. This gap needs to be closed for the drugs to be truly global. So that's another problem we're trying to fight. And I think this difference is small now, but we see with the advent of AI and big data, this would become even more staggering, where data sets which are inequitable, so not correctly representing the global population, then also underrepresents and discriminates the data sets based on its ethnicity, based on the country, continent, and this is huge, especially for new decision and new clinical trials being done in this space. So that's another aspect we feel at Genavinta is very important to address and solve now, because that's where the new technologies are being applied on. So what we plan to do essentially is within this ecosystem of building a cancer precision genomic ecosystem in India, we also want to start a research and innovation based platform, essentially merging with our ecosystem in Germany. We already have the biggest platform in Europe in sheer number of data and the new technology. We feel this is almost underserviced to the continent, to the world, if you don't include the Indian data set. So we're planning to create in the next 5 years the biggest data set in the world, also the most diverse. Diversity here is a positive which needs to be accounted for in the healthcare realm. So that's essentially what we're trying to do with Genavinta research and innovation platform. It needs to be India specific. Some questions we asked and the panels addressed today were very India specific. You need the data sets to support, agree or disagree with those data sets, and I think that's something we want to provide that tool to be able to do that, but also very importantly to facilitate quicker translation of new therapies. We realized with COVID, having data sets to see if a vaccine matches a population was very important. How do we do that with the next line of precision medicine in oncology, the next titrated therapy? Do we wait for a data set to be created for each clinical trial? That's a long-term process, and we want to shorten that from our experience of doing similar processes in Germany. So that's the intent of Genavinta's research and innovation tool. Here's a quick example of how we envision such a platform to be. We call it Genavinta Lens. Essentially what you see here is how we merge and de-anonymize data sets onto clinically relevant modules. So it's not about collecting patient information, it's about how useful they are. So a model already segregates them into different aspects. You can see all the way from clinical to imaging, and these are then merged with existing technologies out there. Existing technologies which needs to be scaled is essentially what this platform does. So now you can talk about new technologies coming to people in years and not in decades, and that's essentially what Genavinta Lens is on a mission to do. Quick example. People always, tend to ask me, it's great you're starting a new, platform. There's multiple out there. How beneficial is such a new platform? So I think one quick example here, from our publication from our institute only a couple of years ago shows the power of such a platform, where we had MSI-based detection for immunotherapy was being done as a standard on genomics. This was standard practice in our hospital, is a standard practice globally. We realized using our platform, with no new input, the diagnostics data was the same, our AI model could now predict MSI instability on H&E sections. So it saved a huge cost, it saved a huge amount of effort from the doctors, but also helped the patients who didn't have to go through more biopsies. So this, for example, is technology which wasn't heard of before, where you need AI and such big data sets to come and scale. So that's, we feel even more important for a country like India, where cost, affordability, and accessibility are major drivers. So that's what we want to do with Gina Vinta Lens and scale for India. Right, so towards the tail end of my talk, I've spoken a lot about cancer. I see the conglomerate of people here specifically focusing on cancer, but I also want to touch upon very quickly on the future, where we feel genomics, as we've spoken now, we feel is adding value to these niche areas, be it cancer, but we very much know in Germany, and our research institute is one of many contributing to studies which show correlation across different entities. So it's not just your genomic data reflecting your cancer probability and prediction, but also your cardiovascular risk, your diabetes risk. So this is something we feel is very important for India, where these factors account for a huge proportion of what the population really suffers through. And essentially what we believe is just such a platform is not just for cancer care today, but is a very important investment for the cancer genomic future across the different entities tomorrow. So that's the paradigm we have in mind, and that's what we want to work towards in a collaborative fashion. Right, so that's more or less the intent. I've given you very a big picture of what the idea really is, and I'll quickly like to thank the people behind it with our team of professors. So you're going to hear Dr. Hubschmann later, who's going to tell you more about the technology, but also it's a science-led initiative with clinicians and researchers, and we feel that's how with newer technologies it needs to be. We need to have the input from the researchers to know what the next level of information needed really is, but also very importantly is the advisory board we have in India titrating what we need to do and at what point. And this is something which we feel is a global endeavor, where we have a lot of global collaborators, especially in the R&D space, helping us with technologies, and we want to do is scale it for a population where it's most needed, and the time is now, where we have the tools, we have the informatic capacity. India is really, has the expertise and the infrastructure in place, and we feel this is where we can add the most value to the people today. So with that, I'm at the end. I'm not going to take too much of your time, and I'd like to thank everybody for listening to me, and I think what we want to really do is collaborate with the ecosystem, learn on what works in India, what doesn't, and I think that's essentially why we are here today, and thank you so much, and that's my time.
Thank you so much, Dr. Shubhankar Sood, for keynote introduction on global cancer control. Now I request Mr. Kamal Narayan to please come on stage and felicitate our speaker and give away a token of appreciation. Thank you so much, sir.
Thank you so much.
Please put your hands together for Dr. Shubhankar Sood. Thank you so much. And now, ladies and gentlemen, thank you so much for your time and patience. Now let's move for networking lunch, and we will resume our sessions post the same. Thank you so much, and we'll see you shortly. Thank you so much. Thank you. Good afternoon, everyone. May I have your attention, please? Once again, I welcome you all to the post-lunch segment of today's event, which is 6th edition of Cancer Summit and Awards, an initiative by Integrated Health and Wellbeing Council and Rapid Global Cancer Alliance. And now we are kickstarting this segment with a keynote on the topic Decoding Cancer. And for this, I would like to invite on stage Dr. Rajiv Sharma, Vice President, Medical Affairs, Tata 1mg. And I request the team to kindly show the presentation as well. Thank you. Please, sir. Thank you. All yours.
Good afternoon, everyone. Welcome, and it's always a tough task to follow a session post-lunch. So please, feel free to take a little bit of stretch or yawn whenever you want. It's all allowed. So I would start with little request to all of you to, for the first time maybe, to look at cancer a little differently. We've always looked at cancer from also, healthcare and a doctor's point of view. I really today, would request all the doctors in the audience as well as everyone else to go back to your high school and think of mathematics and probability. I would say, we always look at cancer as a terminal disease, but today I want you to look at cancer as a reality of probabilities and not certainties. And what does that mean? We all know that there are multiple factors that could actually lead to cancer or could increase the risk of cancer, predispose you to cancer. And there is no real formula that can tell you that if these three things happen, then there is almost a certain chance of you getting cancer in your lifetime. But there is almost a certainty that all of us, with some varying probability, may have a chance to develop cancer. So just remember probability for the next 15 minutes and we'll close it like that. The good news is that probabilities, because they are mathematical, they have a chance to sway. We have a chance, we have ways to turn probability in our favor and win over cancer. How do we do that? Can we change the slide, please? Oh, okay. Okay. The moment we hear cancer, it's all about stigma. We are not looking at a disease. We are not looking at a condition. The moment we think of cancer, it's equal to death. And I think that's a narrative that we really need to change, because unless we change and remove stigma from the word cancer, we will not be able to take rational decisions. We will not be able to treat cancer in the way it should be. And there is science. That's the good part of it, that there is science available, there is technology, there is innovation, there is research that's happening today. And all of that will help us to remove stigma. I mean, the moment, all of us, including doctors and people who are not very aware of the disease and only know cancer, the moment they hear about, even today, predictive analytics or predictive diagnostics, or the fact that one should get some tests regularly done based on genomics and predictive omics, the first reaction is not to get the test done. For some weird reason, for this particular disease, we equate tests with the idea that we will find that test will give us the disease. That's not the case. It is not that you get your diagnostic test done, you will get cancer. It's not that. You're only going to find out that if there is a chance to develop cancer in the future with all the AI and genomics that we have today. Secondly, it will only help you prepare better, because there are enough instances and statistics that in Japan, the number of people that are identified or predisposed or identified to be predisposed to cancer in the first stage are too many as compared to India, where we find out mostly about cancer in the third or the fourth stage. Now what that does is, it definitely changes the outcome and the impact. We have to really move, like I said, from stigma to science, but the idea is to understand risk and probability. We all know, BRCA1, BRCA2 genes, as well as smoking, the kind of risk that, risk enhancement that happens with those kind of small parameters present in the body, and those increase the probability of you developing cancer. So it's, at the end of the day, it's nothing but a probability, and the faster we accept that cancer is also a sort of probability for the population, the faster we have that realization to accept this fact, I think it will really help us to change the narrative and the stigma around cancer that all of us have. Luckily, we have, sorry, I don't think it's changing. Luckily, we have the predictive power of AI, big data, and innovation. AI is driving, tremendous change in cancer prediction through genomics, through all the other rest of the predictive omics. There are enough case studies that, because of technology, because of big data, when you have some sort of idea, let's say cancer, breast cancer cases are much more in India, colon and GI cancers are more in UK. There have been multiple campaigns where, because of insights from those studies, there have been pink ribbon campaign in India, there have been other campaigns in the UK, and the results have been really nice. People with these kind of campaigns have seen incrementality of up to 27% in the UK and for around 40% in India, where they have seen increased identification of cancer because people have gone to get tested earlier, and that's all that makes the difference. We all know that, I think, but the idea is, if we can lead people to more awareness, if we can help them understand that it is again a reality of probability, it just takes out the scare and the fear out of people's mind. The good part, like I said, is shifting the odds and prevention as a strategy. There's nothing better than, prevention. It's an age-old saying, but 40% of cancers are actually preventable through lifestyle changes. HPV vaccine, smoking cessation, and balanced nutrition can totally sway the balance. I think what I would like to call out, and add just one point for regulators and authorities, that how can we look at government and NGOs and NPOs adding cancer prevention to the wellness centers in India. So that could be one way of really acting, rather than just saying that prevention is a good strategy in cancer. Last, what are we if not if there is no hope? So early signs, and when I say early, they've been 15 years old. Early advancing research is showing really positive momentum in the fight against cancer, and there are enough survivor stories that tell that if you identify cancer earlier, if you use all the right tools, if you have all the awareness and information about what to do, when to do, what are self-diagnosing symptom, signs that you can elicit, it is definitely possible to change the course of the condition or the disease cancer. Just to add, what we are doing, we at Tata 1mg actually are supporting the cause by running patient support programs as well as patient adherence programs, and we are serving more than 400,000 patients or 4 lakh patients by handling them, making sure they get the medicines for cancer at the right price. They get all kind of ancillary support and help from the from pharma industry as well as us. We are also making sure that there is adherence to treatment, because these are all long-term conditions. You need to keep at it. Even if there is remission, you still need to make sure there is no relapse. So we also support pharmacovigilance there, and have robust audits as well as counseling, navigation, physiotherapy, all kind of support to the people. And we, as 1mg, we are running and supporting most of the programs when it comes to cancer, but all the rest of the patient support programs in neurology and retinal disorders, cardiovascular disorders, respiratory disorders, so all of them we provide to the people in India. Just to maybe give you one snapshot, when we always think of Tata 1mg, we think of e-pharmacy, online pharmacy, and diagnostics, at home. But it's actually much more. What we're doing at Tata 1mg is not just, sorry, there's some lag. So what we're doing at Tata 1mg is not just pharmacy and diagnostics. Surprisingly, we actually started by providing information, and that's where the whole awareness piece for cancer comes in. We actually started providing and telling people what to do with what kind of medicine, what diagnostics test means, what the report is, what is the meaning of what parameter, how can you really interpret your markers. So all of that started first. E-commerce followed as e-pharmacy and diagnostics, and then we added consultations. We also are very big on, not many would know, but we are almost touching 100 retail stores in the country, and we power a lot of hospital pharmacies in the country and most of the Tata Memorial hospitals and centers, as well as Assam Cancer Care Foundation. And the last, on the bottom, what you see, specialty pharma, is what we just spoke about. We are supporting, running patient support programs, and they really are a blessing to the people who are low on money, as well as they have no idea what to do once they have, heard the word cancer. For the same, last year, a little more than a year back, we actually started Cancer Care Platform. And Cancer Care Platform motto is very simple. It's all about hope and care. And we actually provide end-to-end support to the consumer or user. If you can see, we provide second opinion to the patients, because that's one thing that many of the patients require. And it's not just medical opinion, but all the rest of the information also, which is, if I could find an oncologist near me or a cancer specialist near me, where could I buy cancer medicine at a good price? Not, one is availability problem, one is affordability. So both of them, how to address them. Get financial supports. Now, even if we are not directly supporting financially, but what we're doing is we are crowdsourcing all the crowdsourcing platforms that help you raise money for disease or some particular condition. So we do that. We provide a platform to all of them. We also have a wide array and almost a complete catalog of oncology diagnostics, either in-house, we have our own labs, or in partnership with the OnQuest, Care, and all the rest of the new age Datar like predictive omics as well. So yeah, and I think lastly, which is very important, is I touched upon, but the HPV infection or HPV vaccine that is being mandated now, which comes under adult immunization program, and that's something that we are really strongly focused, in a very focused manner, taking up with the government and with the people of India. And the idea is that if you can prevent even remotely in a minimal manner cancer, like cervical cancer, why not? We should. And especially after last year, when our Honorable Finance Minister Nirmala Sitharaman also in the budget mentioned and allotted funds for cervical cancer and HPV vaccine. We've really seen huge and immense pickup from people on this, and it's really nice to see users proactively choosing to prevent diseases rather than waiting for them to happen. Last but last but not the least, I think all of this digitization, technology, innovation, AI, all of this is nothing if not filled with empathy. And I think together, I would request at least all of us who are here to make sure that we all advocate awareness, prevention, and innovation in our immediate society and people. And it's very important to make sure that people understand that cancer is almost a chronic disease now. There are treatments available. One can really deal with cancer mentally, physically, financially, if there are right metrics, right parameters that are identified. If you know you are predisposed, if you have genetic predisposition, if you can identify all of those parameters, there is a high chance that you will end up in the chronic disease category. I would leave with one thought. The future of cancer isn't about waiting. It's about acting. It's about shifting probabilities in our favor and together. Thanks.
Thank you so much, Dr. Rajiv Sharma, for those encouraging words and for delivering that keynote address titled Decoding Cancer. Now I request Mr. Kamal Narayan to kindly come on stage and felicitate the speaker with a token of appreciation. So, please put your hands together for Dr. Rajiv Sharma. Thank you so much. And in a short while from now, we'll start with another session. And I request the team to kindly set the stage for the same. So the next session is all about innovation in oncology research and development. And this session is sponsored by OncoStem Diagnostics. Advancements in oncology research and development are revolutionizing cancer diagnosis, treatment, and patient care, driving a shift towards precision medicine. This session will explore cutting-edge innovations, including predictive biomarkers, AI-driven analysis, and personalized treatment strategies. Experts will also highlight the importance of strengthening research ecosystems in India, fostering innovation, and accelerating homegrown solutions to enhance cancer care and patient outcomes. And now I'm going to introduce the experts for this particular session, and I'm going to invite them to the stage in a while. Thank you so much for your patience. And now for the session on innovation in oncology research and development, sponsored by OncoStem Diagnostics, I would like to call on stage Dr. Manjari Bakre, founder and CEO, OncoStem Diagnostics Private Limited. Ladies and gentlemen, please put your hands together for Dr. Manjari Bakre. A very warm welcome, ma'am. We also have with us Mr. Praveen A., Oncology Business Head, AstraZeneca. So please come on stage. Thank you so much, and a very warm welcome to you. Last but not the least, I would like to invite Dr. Urvashi Prasad, former director from VC Office Niti Ayog. A very warm welcome to you, ma'am. Please come on stage. Let's wait for the expert, and meanwhile, let me introduce you all to the moderator of this particular segment, Dr. Indu Bansal. Dr. Indu Bansal Agrawal is a distinguished radiation oncologist with over 25 years of experience, currently serving as Group Director and Head Radiation Oncology in Paris Healthcare. She completed a prestigious fellowship at MD Anderson Cancer Center, Houston. Dr. Agrawal has co-authored multiple book chapters and published numerous articles in both national and international journals. Ladies and gentlemen, please put your hands together for our moderator, Dr. Indu Bansal. A very warm welcome to you, ma'am. And now, let me once again welcome Dr. Urvashi Prasad, former director, VC Office, Niti Ayog. A very warm welcome to you, ma'am. And now I hand over the entire thing to Dr. Indu Bansal. Over to you, ma'am. Thank you so much.
Hello. Good afternoon, ladies and gentlemen. And it gives me an immense pleasure to be on this platform amongst all the distinguished luminaries here. And thank you, IHW Council, for having me here. So over the next maybe 30-35 minutes, we will be discussing about the innovations in oncology research and development. And after that beautiful keynote address by Dr. Rajiv, I think he has set the platform. And we know that cancer treatment needs a lot of empathy apart from the good treatment. And we all know that the cancer patients' numbers are increasing every day. So in 2020, about 20 million new cancer cases were there, which are now expected to rise to 35 million by 2050, which means that there is going to be a 77% increase, which is actually a little bit frightening. So we need to come up with new drugs, we need to innovate more so that we can not just extend the life of patients, but give them a meaningful life, okay? So, and we now know that, in fact, yesterday only I was reading something very interesting. There has been a Korean study where what they are doing is that they are converting the cancer cells into normal cells. Normally what we do is our innovations are focused on killing the cancer cells. But a Korean study has come up where they are reversing the cancer cells into normal cells, and by developing a digital twin gene network which is involved in the normal cell defenses, and they identify the key molecular switches, and so the cells are not destroyed, but the cancer cells are converted into normal cells, which was really something very fascinating. So with that background, let's move to my esteemed panelist here. So we have Dr. Manjari, who is the CEO of OncoStem. And I would say that she wears many hats. She is not just an entrepreneur, but she is a doer. She is the first one to bring her own startup, and I think it's the only one in Asia. So the future of oncology is now shifting towards innovation, digitization, personalization, prevention, and of course, so we have to focus on that. So from you, I would like to understand that you have a product by the name of Can Assist. So we all know that cancer is an individual disease. No two people with breast cancer will behave the same, and we cannot treat them the same way. And cancer treatment is a very costly treatment. So many patients, they don't take treatments just for the fear of getting chemotherapy. So your product, Can Assist, it helps us in identifying the risk of developing cancer in those patients. And if we can predict that which patient is at risk, we offer chemotherapy only to those patients, and the rest of the patients, they can be kept under observation or given hormone treatment if they are ERPR positive. So now I just want you to understand, tell us that why did you think of bringing this product into the market, and how do you think that these innovations are going to help us in future, and what are your future products in pipeline?
Thanks, thanks Dr. Bansal, and thanks IHW for having me here. It's always a pleasure. Thank you all for attending this session. So yeah, I mean, to your point, I think India traditionally, I mean, we have been doing mostly generics business, but we are now developing into getting into other cell therapy. We are getting into monoclonals, etc. So we are going into the thing. And one thing we have to realize is we can't always look to the West for new innovations. We need to build them ourselves. We need to really make them work, build it for our patients, build them on samples of our patients which are most suitable for, because there are differences. And so that's why we need to really build, for example, even the Canis breast test. The test that competes with our test in the US is called Oncotype DX. It's world over known that that test was developed in the US, and it was developed on US patients, Caucasian patients, who are primarily postmenopausal at disease, and they are screen detected, mammography detected, tiny tumors. So the biology of the patient at postmenopausal disease with small tumor is different than what happens in India, largely in Asia and including Middle East, is, you know, premenopausal disease and a 2-centimeter tumor, T1 tumor. So that's so underlying tumor biology is different. And so we should really develop our own diagnostics, prognostics, drugs, because the underlying biology of our patients is different, and we need to ensure that that is well represented. And secondly, even if the clinical trials, we need to do this, repeat them here and ensure. And this is also, I mean, the larger point I'm trying to make it here is, you know, we need to become Atmanirbhar. We need to rely on our own, this thing, make them economical for us. For example, Oncotype DX costs $4,000, no matter where it is, where the patient is, whether US or here, whereas our test is a fraction of that cost. So that is really the importance, and we have enough and more patient database, different kinds of patients, the amount of each, even if it is a rare tumor with that's our strong point. We have the greatest scientists, we have the greatest infrastructure to do science, innovate new products, new tests, and we have the huge patient base. So we have everything that is required to develop something like this, and why not use it? So that is why I decided, because when I incorporated my company, even my investors said, Manjari, do this in the US. It is hard to do it in India. I said, there is already a test in the US. Why would I do this again in the US? But who needs it are our patients. And that was really the reason why I incorporated the company here. I worked with 15 hospitals across India to develop this test, validated it in global studies in US, Germany, Italy, France, Austria, Netherlands, and now it's been in clinical use. So so my takeaway here is like we really need to develop tests like these for our patients, which will be developed, validated on our patients, and in the end will be cost effective for us. So make use of all of these facilities that we have.
I think a very valuable point that has been brought is that in India we need to become Atmanirbhar. Yes. And I was reading about her, and I really liked one point that she mentioned, that we need painkillers, we don't need vitamins. Yes. I think so that was something I really found interesting. And as she rightly said, that India is a very huge market. And if we talk about clinical trials, then I think India has a number of advantages. Number one, the population is so much, so we have a huge number of patients for any disease for which we want to conduct trials. The drugs are much cheaper. Number two, that we have a lot of ethnicity is different. So we get diverse group of patients on which we can conduct those tests. But there are still few things that I see that, and we all can speak English language. Yes. So in certain countries, even that is a problem. Language is a barrier. You can't talk to patients. So here at least we know English language. And the cost of clinical trials is 40 to 70% less. So I want to go ahead to Mr. Praveen, who is the oncology business head from AstraZeneca. And as an oncologist, I think we can't survive without your products. So we have been using them for so long. So my question to you is that we all know that a number of clinical trials should be done. But actually, if you see, only 10% clinical trials are being done in India. And the barriers which I see is that doctors they spend 70 to 80% of their time looking after the patients, and they get only 10% of the time for research, and we don't get any protected time for research. Although if we see the emerging markets, then the number of clinical trials are going up. We are seeing more and more clinical trials happening in India. The trials which are being conducted, only 30% are sponsored by government. Even lesser than that, majority are they are sponsored by companies like AstraZeneca or other big business groups. And so the problem is that one more barrier that I really want you to focus on and address is that most of the trials which are being conducted, they are being done by medical oncologists. So the information or knowledge about conducting clinical trials, that is with medical oncologists. Any radiation oncologist here, I can see Dr. Kanika, I think she will agree with me, that most of the clinical trials, they don't reach a radiation oncologist, or very few of them reach them. And only 14% of doctors, I did some research, only 14% of doctors, they are aware about clinical trials. And if we talk to the patients, then a general patient doesn't know anything about clinical trial until and unless they are told by some doctor that we have a clinical trial running on this, so would you like to be a part of it? So many times when patients come to me or to other doctors like me, then we are not able to impart a good information to them or educate them about clinical trials. So if, I mean, even being in the few of the topmost doctors, we are not educated about clinical trials, I don't see why patients would be willing to enroll themselves for clinical trials. So what is your say on that?
So first of all, it's great to be here. Thank you, Dr. Bansal and IHW for having this. And actually, a lot has already been said in the morning sessions, which I think is very relevant. So maybe I'll take a step back and walk through sort of our thinking at AstraZeneca, right? So one of the things that I remember once speaking with an oncologist who was very experienced in the US, and he said, you know, when I was training, people, the question was not what to treat a cancer patient with. The question was why even bother? Because we had so few options. And the half-life of knowledge was 20 years. So nothing changed in cancer for 20 years. But now the half-life is not even 2 years. Yeah. So the first thing that's great is that the technology is advancing rapidly. And at AstraZeneca, our commitment is to really push the boundaries of science to do that. Like, that's what we do, right? And one of the things that's been great as part of that, and if you think about the conversation that happened in the morning as well, right? Ultimately, a lot of the new technologies that are coming up, it's, you know, it's all focused on either killing cancer cells or getting your immune system to kill them. And that is true, as you can see. So the thing that around, you know, for example, in terms of killing cancer cells, so there's a lot of precision medicine that is clearly at play in the context of, you know, antibody drug conjugates, and what is close to your heart in the context of radiotherapy, right, radio conjugates that are now coming up. And as I was sharing with you offline, AstraZeneca, of course, to your point about radiation therapy and our commitment to having those clinical trials, of course, has been at the forefront with the Pacific trial that you're very well aware of. So one of the things we are clearly focused on is broadening the engagement across multiple stakeholders, so starting with radiation oncologists, surgical oncologists, medical oncologists. Now, the question that you brought up in terms of availability of clinical trials and awareness around clinical trials, I would say that's a work in progress across the world, actually. So I spent my entire career in the US for about 20 years, and the same question would come up in the US, because the trials would happen in the Northeast or the West, where all the big academic centers are, but you go to Alabama or, you know, Arkansas, really nobody actually knows much about the clinical trials. So I think this element of equity and awareness is actually a universal thing. Now in India, of course, also it is very relevant in terms of what we need to do. Now, one of the things that, you know, we are committed to doing is actually bringing almost all of our phase 3 trials to India. And in fact, we are doing quite a bit of that now, both because to all the points you mentioned, there's a lot of, first, great physicians like yourself, and the community is amazing. 2, you've got very diverse patient population. And 3, it is very relevant because you've got a lot of patients here, right? So I think, again, nothing in cancer is a simple solution, so I don't have a simple answer to your question. But what I do say is that definitely things are moving in the right direction. And as a company that is focused in oncology, we are very much committed to being part of that.
Thank you. I think it's very heartening to know that many clinical trials are now coming to India. And as a radiation oncologist, radioconjugates, and there would be a lot of work which will be done as partners in healthcare delivery. So now I will move on to Dr. Urvashi Prasad, who is the former director, VC Office, Niti Aayog. So we are so privileged to have you here, ma'am. And I think we all know that in India, being a diverse country, we see a lot of variation in the patient population that comes to us. So unfortunately, most of the patients, they reach to us when third stage or fourth stage. And if we talk about Papampare district or things, I mean northeast side, where the maximum number of cancer patients are there, unfortunately, they have the least facilities to treat patients. No clinical trials happen there. There are no big hospitals which are there to look after the cancer patients. So can we do something to bridge this gap, so that we may talk about big things, about conducting clinical trials, about bringing good molecules, like good products like CanAssist. But if we are not able to provide basic health care to a person who needs, so I think none of the patients should lose their life because of the unfortunate place they are staying in. So that is really, bad. So, and we need more startups like CanAssist and others. So how can you help us in bridging this gap so that maybe CanAssist reaches more people, maybe it's incorporated into Ayushman Bharat schemes or clinical trials, patients even from the low socioeconomic background, they're able to be enrolled in those trials. So what is any policies being done from government side to do this?
Yeah, thank you for the question. In fact, I had suggested to IHW to have this conversation around innovation because I think, we are very, very far behind, when it comes to that. You listed all the advantages we have, and despite those, I think the situation is not even nearly as good or positive as it should be. And I'll humanize this a bit because talking in generics or jargon doesn't bring out the reality of cancer. So apart from my policy and public health hats, I also wear a patient hat. I'm myself somebody living with ALK positive lung cancer, which is a very, very challenging and still fairly poorly understood condition. Now, if I see in India for a poor patient, firstly, getting a diagnosis of this would be a nightmare because you not only need to do a biopsy, you then need to do a molecular testing. How many people in the country would really have awareness or access to that, right? So that's the very first thing, and that's why when we say this is a rare disease or, we have so many cases of cancer, I think we're underestimating it by several multiples, because we're not even diagnosing. And cancer is not a notifiable disease in the country, and I've been really advocating for this. If you don't measure something, you're never going to solve it. And by just trying to hide behind your numbers and say, no, it's fine, it's under control, doesn't really help. So, firstly, the diagnosis would be an absolute nightmare because it was for me. And, imagine somebody like me who has access to actually the best of hospitals, doctors, but initially I was told she probably has a GI tract cancer, she has 6 months to live. So, but if it's happening with me, then it can surely happen with 99% of India's population. So that's the diagnosis part. Now we come to the treatment part, right? So ALK has a very standard treatment pretty much all over the world, which are these TKIs, these inhibitors, ALK inhibitors. Now in India, the cost of some of the best inhibitors is actually prohibitive for the majority of patients. And Ayushman Bharat doesn't cover those. They cover the age-old chemotherapies. They don't even cover crizotinib, which is very first ALK inhibitor, whereas in the rest of the world now we move to lorlatinib being the first line actually of treatment. I'm on lorlatinib, and I know what a huge burden it is, even though I do have access to private health insurance, which again, a lot of people don't. And it's anywhere between 1.5 to 2.5 lakh rupees a month. And how many people in the country can afford that? So I have ALK patients coming to me every day, you know, desperate, because they just don't know what to do. And then we have to give them creative solutions that, okay, if your cancer is not spread to the brain, just try to start on a lesser TKI and then raise money and then move to lorlatinib. Now, is that fair? You know, the point you were making, that is a life in the US more valuable than a life in India? I don't think so. You know, and just because you're born into a certain socioeconomic or financial condition, but like I said, even if you're in a good condition, it's very expensive. It's prohibitively expensive. So I think that we have miles to go in terms of having more innovative clinical trials in India. And in my case, there is a smaller company which is doing some very innovative work. They are in a phase 2 trial. But they will also not bring their trial to India. They have brought it to Singapore. They'll probably bring it to China, but they will not come to India. And this is a big problem, right? Because we have patients here who are literally dying, who perhaps if they could be in those trials, because we are not allowed to enroll in trials in the US or Europe. Singapore is not possible for every patient to just go and, you know, start enrolling there. So one is those trials, you know, and I know from the policy side, yes, we've had many challenges. We had some mishaps happen in certain clinical trials many years back. And after that, the regulations were taken to another extreme. Now we're trying to pull it back a little bit, but I think there's still a lot more to be done. So we have to work with the companies, not just the big pharma, but also the smaller companies who are often doing a lot of innovative work. To say that what will allow you to come to India, you know, despite all the advantages you mentioned, why are you not coming here?
So I think there was this, there was new drugs in clinical trial rules, which was implemented in 2019. And it was supposed that it would change the India's regulatory atmosphere. And there would be, I mean, there would be more transparency, there would be more ethical clinical trials.
I think we are still not there.
We are still not there.
We are still struggling with the regulatory side of things. And then the other part, quickly, I'll finish, is on the indigenous research, you know, which we also need to find a way to boost. We cannot have patients waiting here for drugs to come off patent or, you know, become affordable. I mean, their lives will be gone by then. You know, we can't sit and wait here. So if you're talking about somebody's life being at stake, then all this becomes very, very urgent. And I think the government, of course, has the biggest role in this to play. And I wish there were more people like me in government who could actually care about these issues. But I think we don't have enough right now, but hopefully we'll get there.
So I think, as very rightly said, doctors, they also need to become entrepreneurs. So we need more of doctorpreneurs who can understand the landscape, and we need to have more people from academia, government, policymakers, and pharma industry, of course. They all of us need to join hands together if we want to do something really for the cancer patients. Now, coming to Mr. Praveen. So when we talk about clinical trials, we have been talking a lot about it today actually. So a lot of cost is being covered by the clinical trials, that's true. But apart from that, still there are a lot of out-of-pocket expenses, like many tests are not covered, the travel is not covered. So one of my patients, she's a lung cancer patient, she travels all the way to Bangalore to get a drug which is on clinical trial, but the airfare is not covered. The side effects that she develops when she comes back home, they are not covered. So if we see the Indian market, then I think only 30% patients, they have insurance cover. Very few patients, they are covered under healthcare schemes like Ayushman Bharat, PMJ schemes. But still many patients, even if they get the medicines like Haryana, even if they are Haryana government empaneled or they are on any government panel, then the timeline when they apply for reimbursement and by the time they get the money back, that's also quite long. So either they don't get any reimbursement or it's partially reimbursed. So it leads to a lot of front load on the patients, and 78% healthcare expenditure is being done by patients for cancer treatment in India, which is quite huge. So my question to you is that you also have immunotherapy products, immunotherapy drugs, which are damn costly. Every patient can't afford, so they are usually being used by panel patients like ECHS or government schemes. But in India, if we talk about immunotherapy, only 2.6% patients, they get immunotherapy for head and neck cancer. So my concern, or I mean, I'm raising this question to everyone in the audience. So should a molecule be priced on the amount of innovation or the research that has gone into it? I mean, should we move from a volume-based model to a value-based model? Should there be P model, like pay for performance and things like that, so that if a molecule is giving good number of results, it's really extending lives, then the price should be more for those products. But for the products which are not bringing much, not prolonging the life or giving quality of life, the cost should come down. I mean, can some pharma company do that? Difficult proposition, but yes.
No, it is, look, first of all, it's great to see this panel, and I think, again, it's great to hear from you, Dr. Prasad, in terms of, just your own personal experience, and I think it's very real. So, look, healthcare is incredibly complex, to say the obvious, right? And it is incredibly complex in terms of the dynamic, which is our aspiration is to make it available to everybody that needs it. And frankly, none of the countries in the world have cracked it. And I'll give you a great example. So we've got a drug, called osimertinib, many people know, and it's quite life-changing. And once we heard this story that in the US, osimertinib was available to the patient literally the week after the results were presented at the trial, and then you add them in the guidelines. In the UK, which is a developed market, it wasn't available for 2 years later, right? So I think everybody's trying to figure out this balance of how do you make innovation accessible. So first, let me acknowledge that it is an incredibly complicated issue that I don't personally have, and I don't think anybody does, a clear solution. Now, having said that, the focus for, at least, and I can only speak for our company, is to actually bring value by innovation, right? So we, like the DNA of our organization is science. It's all about, pushing the boundaries to bring new science. That is where we bring value. That is why gefitinib, the first, TKI that works for EGFR, was invented. Tamoxifen was invented by AstraZeneca, many, many years ago. And now, of course, new ADCs. Now, the next challenge, so one of the things that, for example, that we are working here in India is that we want to bring innovation to India as rapidly as possible. Because historically, if you see, you would have a drug that would be launched in the US, and it wouldn't be available in India for 4 or 5 years later. And we don't think that's right. Now, so our first step is to bring innovation as rapidly as possible. And that's what, for example, if you look at some of the ADCs we've been able to do, bring it within a year to India. The next step, of course, is that how do you make that innovation accessible to as many people as possible? Now, first, you need to actually have, because we invest primarily in groundbreaking innovation. So we are not really interested in incremental sort of updates that you're talking about, and that is our sort of focus. But when you do have that groundbreaking innovation, what we are also equally focused on is how rapidly can we make that available. So how do you translate science to medicine as quickly as possible, which is where the clinical trials come in. Yeah. And then how do you translate that medicine to clinical impact for a lot of patients, which is where the access challenge comes in. So we are working on it, I would say. It is definitely a work in progress, and frankly, I anticipate it will be a work in progress for many, many years. But what I'm heartened to see is that there is certainly, improvement year on year, which is what we are working on. And I also have to applaud the government. Like you can see even today, there was a focus on cancer. I think last year too, there was a lot of focus. So I think everybody is honed in on how do you make this better. We are working on the solutions. And I think what we can do on our part is actually bring true innovation rather than incremental sort of update that doesn't bring the value in terms of the impact. So that's our focus.
So I think your company is doing a great job, and you have so many products in the market which we oncologists use, and they are definitely groundbreaking research molecules. So we are thankful to you for that. Coming back to ma'am, so as I said, you are an entrepreneur and you have that spirit in you, to bring innovation. But I think majority of us doctors, we don't have that innovation spirit within us. We are focused mainly into treating patients, giving them the best, giving them the best outcomes. But if you see Toyota company, for that matter, I mean, in most of the Japanese companies, there is a culture of innovation. Tata Group, Toyota, they have a culture of innovation. But unfortunately, none of the hospitals settings we see any, innovation pipelines or any credit being given for you for bringing something innovative. So I think all of us, we need to develop that culture of innovation. We need to think into it that how can we bring really some change. And sometimes it's not necessary to have there could be just a disruptive technology, like we all know that it could either replace something which is already existing, or it might tell us some ways of doing something differently. So what would you like to tell the audience about how should we all learn to be innovative the way you went ahead and did it?
So yeah, I think the biggest is, have the curiosity that, in your daily, so many doctors, when I ask them point blank, okay, how would you like to improve any of your processes? So then they think, and then they come back and say that, look, I'm having this issue in diagnosing blood cancers. Somebody did mention that to me. So it doesn't have to be a big thing. But it's like daily they have having this issue, or in treating a patient of certain cancer. I know that I see this, every patient of this cancer comes back to my clinic in 6 months. So first line therapy is decided, but still this happens. So could you help me? So these are the things, they don't have to be like really big questions, but they need to be a question that you lose sleep. You worry about that patient, you worry about that diagnosis, you worry about that, maybe it's this thing on the X-ray film that, is it really from a dense breast? Is it because I'm missing it from dense breast? Is it a real lesion? So it could be anything, and then we can always, and I think what we need to have, as I agree with you, clinicians in India are super busy. So if every hospital can dedicate maybe few hours to them in a day, maybe last 1 hour of the day, or maybe 1 day a week, or maybe 1 day in 2 weeks, where you can think and then come up with some projects which can be internally funded. They don't need, see, I have built this company for a fraction of literally, under $10 million US, whereas the competing product was built at $600 million. So we can really innovate, we can do a lot of great, that's exactly how DeepSeek was invented also, if it's the latest, that market disruptor. Because they did not have money to buy GPUs, simple as that. So, necessity is mother of innovation. So if you have really genuinely, if you think something, and you should talk to the hospital director and say, look, we all need some time to think. And then some small internal grant to really, push that idea forward. Maybe every incoming patient, I was just talking to Dr. Chirantan also in the morning about something that he is observing. And if every doctor thinks like that, becomes a go-getter, I think we can do it. It doesn't have to be really a big thing. You don't need a big company or anything. Just real intense curiosity and ability to devote time to really pursue that curiosity is all you need, frankly. Yeah.
It's easier said than done, actually, because you are more worried about let the patient's heart keep on beating rather than, focusing on anything else. So something which is very surprising, although so many things have happened in the onco atmosphere, and we have such good molecules. But if we talk about the diagnosis of cancer, or screening of cancer at an earlier stage, that doesn't happen. Even I don't think that there are any universal markers or any such test available even in US market, where with a simple blood test you can pick up and tell whether the patient is at risk of cancer. So there are few tests like Pantum, or there are some other tests which just indicate that you might have cancer, but from where that cancer started, when will it spread, will it cause symptoms. Like if we talk about BRCA testing also, it just tells you that you are at risk of breast cancer. It doesn't tell that if the cancer will come, at what age will it come, in which breast it will come, in which quadrant of the breast it will come. And we just tell the patient, because you are BRCA positive, better go and get your breast removed. Or because you're BRCA positive, then oophorectomy should be done. Yeah. So, talking to Mr. Praveen, I'm putting all the tough questions to him, I'm sorry. So, why do you think nobody is focusing on preventive aspect? I mean, the focus is more on treatment aspects, but I mean, what do you think are the barriers to that in your mind?
Yeah, I mean, again, yes, you are right. You're giving me all the tough and very complex questions without any simple answers for sure. So look, I think a couple of thoughts on this more broadly. Let's actually start with even where we can, we don't detect early, right? So whether it's lung cancer, breast cancer, in fact, you know, the 3 cancer types in India that have screening guidelines, the screening rate is less than 1% for a lot of them, right? And by the way, it is not just in India. So the lung cancer screening rate in the US is less than 5%, though they've had guidelines for well over 7-8 years, and it is completely reimbursed. So there's really no real reason why they shouldn't be screened, right? So now, especially for some tumors, there is an element of shame. I think that was brought up earlier, and in fact, you know, one of the things that we talk about is like, how do you reframe the shame, right? It is not, you know, something that a person should feel guilty about, but it's going to take a while for that to play out. And the other thing that becomes very relevant actually in a market like India is that we have to think holistically about the full loop, because even where we can screen, I think it isn't enough, because the worst thing that you could actually do to somebody is screen them for a cancer and then they have no access to medication. Then what have you done? All you've done is increase their anxiety levels, right? So one of the things that we have to think really hard about is that not only the early diagnosis and detection, but also the full loop, right? Like once you've screened somebody, do they have access to the diagnostics so they know what is the right, you know, type of cancer, and then do they actually have treatment to do that? In fact, we are working on a couple of pilots in India to actually just enable that. So with the government of Goa and the government of Karnataka, we are actually running pilots on screening, but with the understanding that there is a lot of commitment that once somebody is screened, that they are actually followed up with the right diagnosis and access to the treatment. And one of the things that is helping in the context of those pilots is actually leveraging AI that was brought up earlier, where you can actually take x-rays that are already available for a lot of folks for other reasons, and then apply an algorithm from one of the companies that a startup from India again, to the point that has developed a pretty exciting algorithm to then identify potential high-risk nodules that you can then follow up for a CT scan or a biopsy, right? So I would say that I don't know if I've answered your question, but I guess the key points in the context of screening is that it is a universal challenge. There is certainly an element of shame that will take a while for us to reframe that it isn't about the shame. But importantly, where we do have guidelines and can act upon, it isn't enough to just screen. It is really, really important that you think about the full loop of screening followed by diagnosis and treatment. And otherwise, doing screening is actually counterproductive, I would say, almost.
I think that's a very valuable point raised, because in India, I think the adoption for cancer screening is only 1 to 2%. So if we talk about cervical cancer, from the time the cancer develops to the time a patient actually develops symptoms of cancer, it's around 10 years. Similarly, for colorectal cancers, from the time that an adenoma converts into a full-blown cancer, it's around 10 years. But even then, we don't get any screenings for 2 reasons mainly. Agar cancer nikal gaya to. So that is one fear, that if I'm diagnosed with cancer, and second thing is, what will others say? So like for certain cancers, which like lung cancer is something which is associated with smoking. But if we talk about female cancers, then sometimes females don't even go to the doctor, that they are so much afraid of showing a breast lump, telling about a breast lump to their family members, or going even to a doctor and telling them that they have vaginal bleeding and symptoms like that. So I think it's the lack of knowledge, and we need a lot of hand-holding, which is not currently happening. So from that side, I think Niti Aayog people, they can help us, in spreading more. There should be involvement in every step, right from educating the school children about the side effects of tobacco smoking, alcohol consumption, and unhealthy sexual practices, screening them early, giving them the right treatment, And how can we ensure that the right oncological drug reaches the right patient and it gives the actual right outcomes to the patient, and the money that is being spent on innovation and drug discovery is not being wasted on a wrong patient? So can we do something on that?
On what specifically?
How can we ensure that the right treatment is reaching to the right patient? And how can we, impart more education to the general public and to the non-onco doctors as well? Because normally there is a lot of gap between when the patient presents to a non-onco doctor and by the time patient reaches to the right doctor. So in UK and other places, there is this 2-week referral policy. Within 2 weeks, the patient should reach the right doctor. But it doesn't happen here. So any thoughts on that?
Yeah, so I think there's supply and demand side issues on that. I think on the supply side, theoretically, as part of Ayushman Bharat, the primary health centers that we have are supposed to screen for 3 types of cancers at least. But again, even where screening is happening, like Mr. Praveen said, the referral and follow-up is not happening as systematically. And even the screenings are a little ad hoc and sporadic, across many of these centers. And it's not something which is, happening in a constant loop, which is what is really required. So that is one challenge. So in theory, we are supposed to have it for those 3. Now, for lung cancer, we don't have anything systematically, and that's a big problem because actually, we are now getting a much better grip on breast cancer, even on cervical cancer, but it's lung, where we still have very high, mortality, of course, morbidity, but also mortality because people are coming in at very late stages. And a lot of these people are non-smokers like myself. Because frankly, in Delhi's air today, like I saw in a nice infographic, that every child is born a chain smoker here. So I don't think any of us are non-smokers anymore. You just need to step out into the haze to see that. So we need a systematic screening program for lung cancer as well. It's not good enough to say it's only for smokers. It's no longer just a smoker's disease. And a lot of the non-smokers get it at much younger ages. When we are at our productive most, when we're at the, most important stages of our careers, everything. So if you're talking of Viksit Bharat and workforce and all these big things, it's not going to happen, if you keep achieving outcomes like this. So I think that's on the supply side. On the demand side, certainly, awareness is an issue, but I think more than awareness, the point you made, that there is a genuine apprehension, and I think people are not wrong in that also, because we don't do a good job of access, right? So people do feel that if I have to get this treatment, I'll lose my wages, I'll just go into extreme poverty, so it's better for me to just keep ignoring and hopefully it'll go away, right? So it's often not a case that they don't want to get better, it's just that they want to avoid it, and financial toxicity has a big reason to play. So now, what we need to do, and I've again been advocating a lot for this, we need to have case studies that we put before people that, look, this is somebody who came to us at stage 4 and they had to, spend much more, it was much more difficult, much more painful for them. But if you get screened, and if you could come to us at, stage 1 to, even 3 in many cases, we could fully cure you perhaps, and it might not even be that expensive or difficult for you. So I think we need to make this something which is visible for people. It's not yet visible. We talk a lot in statistics, but because I'm trained in public health, I know statistics don't bring it alive for you. Like you're saying, from the time you're screened, you might not get cervical cancer for like many years, right? So you don't really care about it. It's not something happening to you today. But if we can humanize these stories and say that, look, so many people came to us at stage 4, and this is what happened versus people who came to us at stage 1, then I think it might be easier for people to say that, okay, let me go forward for screening or let me go forward for early detection as opposed to just trying to ignore and wait. So I think it has to be addressed from both the supply and the demand side. And you're very right that we have to train everybody in the health system to at least be aware of the basics. because a patient will not straight away land up to an oncologist. It will be rare. Mostly it will be a health worker or it will be somebody else at the primary health center or at the district hospital. So they should be able to pick up at least the basics and say, okay, I think I need to refer this person further. So that is a huge HR effort that certainly we need to undertake.
So as you rightly said, I think Mr. Praveen also pointed that out, that we need to work on the whole loop, right from education to cancer screening to increasing the accessibility, to increase to lower the drug cost, and of course have more innovation products in pipeline so that we can, and aftercare of cancer patients is also very important because otherwise they feel abandoned. So holding their hand right from cancer diagnosis till and also to manage the late side effects, that's also very, very important. Because we have seen that the global spending on cancer medicines has actually increased from $223 billion in 2023, and it is expected to be $409 billion in 2028. So that's why I'm bringing this out, that we need to really focus on early detection, screening and prevention apart from innovation. Of course, that's very, very important. So I feel that the present challenges in cancer care oncology, there is a need for global efforts and collaboration of research across cancer care continuum, from the prevention and early diagnosis to treatment to survivorship and supportive care, along with the continued need for basic and translational research as well. And we need to further understand the cancer biology and tumor microenvironment to help us to identify the effective targets. We need to understand why is a drug resistance being developed and what can we do to avoid that, what we can do to reduce the cancer toxicities, treatment toxicities, and facilitate personalized medicine. And we need to have effective preventive and screening strategies, and of course address the inequity gap which is there in India, and address the physical and mental well-being of the patients as well. So then all these innovations, drug discovery, drug development, all of us have to, join hands. I would like all my worthy panelists to give their one note or message that they would like to give the audience, because I think we are just finishing up.
From which perspective? Patients, doctors?
From innovation and drug discovery perspective.
India really needs to innovate and develop new technologies, tests, devices which will work for us in the end. And we don't have to look to the West for new discoveries. We can make them cost effectively right here.
Yeah, I think, so I just would like to end on a note of hope. Actually, I think there's tremendous advancement in the science of understanding and treating cancer, which has been great. And I think the future is really partnering across stakeholders to really translate that science into impact for patients.
Thank you.
Yeah, I would just say we need to have patients at the heart of this all. That's why we have the healthcare sector. We need to have more patients in the innovation process. We need to have more patient involvement in designing trials, and of course, conducting, we need more diversity. So I think making everything for the patient and keeping the patient at the heart of it, I think, for me, that's the most important thing.
So I think very well pertinent points made. So I know we are talking about cancer, 4th Feb is the World Cancer Day, but as Mr. Praveen also said, we are here, we still should not lose hope. Because if we detect cancer early, we have now means to detect cancer in a pre-cancerous stage. And even if a patient is diagnosed in stage 1, then they need only one treatment, maybe surgery or radiation or chemotherapy, and then they are cured for life. So the treatment is for few months and they don't need any treatment. But if you see about diabetes, hypertension, cardiac diseases, then the treatment is lifelong. So I think all of us need to be more aware. We need to be more aware of cancer rather than be more afraid of cancer. So we should go for checkups, take the right treatment at the right time, go for the best treatments that are available, go to the right place, and not be afraid कि अगर निकल गया तो क्या होगा. So we need to educate ourselves, and I think anyone in the audience, all of you, if every one of you just decides to go for checkups and impart this knowledge to your family members or your friends, we can save so many more lives. That's what I would like to say here. And I would like to thank ISW again for having me here, for the wonderful audience, and my august panelists from whom I have learned a lot today. Thank you so much for imparting all the knowledge.
Thank you. Thank you so much, Dr. Indu. Thank you so much, panelists, for sharing those insights on innovation in onco research and development, session sponsored by OncoSTEM Diagnostics. That was indeed informative and an eye-opening discussion, I must say. Now I request Mr. Kamal Narayan to please come on stage and felicitate all our speakers with a token of appreciation. Thank you, sir. Let's start with Dr. Manjari Bakre, founder and CEO, OncoSTEM Diagnostics Private Limited. Mr. Praveen. Put your hands together, ladies and gentlemen. Thank you so much, ma'am. For Mr. Praveen A., Oncology Business Head, AstraZeneca. Thank you so much, sir. Thank you once again. And Dr. Urvashi Prasad, former Director, VC Office, Niti Aayog. Thank you so much, ma'am. A big round of applause, please. Thank you so much. And last but not the least, our moderator, Dr. Indu Bansal. Thank you so much, ma'am. Please put your hands together for Dr. Indu Bansal. Thank you so much. And now I request all the panelists to come forward for a group photo. Thank you so much. That was for the session Innovation in Onco Research and Development. Thank you, Mr. Narayan. And now, in a short while from now, we'll start with another session that is revolutionizing cancer care through digital health, bridging gaps in accessibility, affordability, and support. If I elaborate on the session, then I must say that digital health is transforming cancer care by enhancing accessibility, affordability, and patient support through telemedicine, AI-driven diagnostics, and remote monitoring. This session will explore how technology is bridging gaps in early detection, personalized treatment, and survivorship care. Experts will discuss the role of digital innovation in making cancer care more inclusive and efficient across diverse healthcare settings. Now I would like to invite on stage our panelists for this session. Let's start with Dr. Swati Mishra, Director Clinical Health and Content Medical Affairs from Tata 1mg. A very warm welcome to you, ma'am. We also have with us Dr. Manu Prasad, Senior Consultant and Head Department Medical Oncology, Hospital, Aster, MIMS, Kannur. A very warm welcome to you, sir. Mr. Kabir Mahajan, COO, Mahajan Imaging and Labs. A very warm welcome to you, sir. Please join us on the stage. Dr. Kanika Sood, Director and Clinical Lead, Radiation Oncology from Kamal Narayan Super Speciality Hospital. A very warm welcome to you, ma'am. And last but not the least, Dr. Sanjay Maheshwari, Cancer Surgeon, Urologist, and Medical Director, MP Birla Group of Hospitals. Ladies and gentlemen, please put your hands together for our panelists. Now, I would like to invite on stage our moderator, Dr. Piyush Jain, Director of Business Development and Strategy from Tata 1mg. Welcome, sir. Now, I hand over the stage to you, sir. Over to you. Thank you.
Thank you so much, ISW Council, for organizing this session on very important topic of digitalizing oncology care with the overall revolutionizing oncology care with the digital health innovation, etc. I think a lot has already been said and the stage is very set for me. While Dr. Rajiv already spoke about it is more about probabilities and not certainties and how we can bring in prevention, predictive analytics, but into the cancer care. And of course, when we speak about cancer care, it comes about accessibility, affordability, information asymmetry, which exists in overall market and the patients overall. And when we see patients in terms of treatment, there is a lot of information asymmetry that exists into the market, right? I will take example when I was, speaking with one of the patients. They were diagnosed as having intracranial space occupying lesion. And then one of the physicians essentially told them that, you just need to get an MRI. On the MRI, it was getting diagnosed as a tubercular meningioma, right? The surgeon simply started and asked the patient, it's just very well known to me and just happened 2 weeks ago. The surgeon essentially started the patient on surgery, did the removal of intracranial space occupying lesion, and later on it was diagnosed as having a metastatic stage 4 lung cancer. Just if the patient would have known that a PET scan could have been done earlier, a predictive diagnostic could have been done earlier, the outcome might have been a little different for some of those patients, etc. While radiotherapy would still be needed. So hence I cannot emphasize enough on importance of predictive diagnostic, etc. So starting with this particular topic, Kabir would start with you. So there is a lot of digital innovation, etc., which are happening in the field of diagnostic, etc., artificial intelligence, etc., is coming in. Would you like to speak a little bit about how artificial intelligence is helping in the field of predictive analytics, as well as in the field of overall diagnostic?
So thank you for having me. Thank you, Dr. Piyush, for this question. So AI, it is the buzzword, and since the last many years, we've been seeing how more algorithms are coming in. Most of the algorithms in today's day and age are still for radiology, and that just shows the amount of investment that has gone in globally. So someday or the other, there will be widespread usage. But even now, we see it being used mostly in at a public health level, where there are brilliant use cases, especially for screening. So I know that there is a lot of work happening for TB screening, where essentially about most X-rays acquired at a screening level for tuberculosis would be without any abnormality. So what they are doing is actually going around village to village in mobile vans and screening, doing a screening X-ray, and only and using artificial intelligence to actually detect whether there is an abnormality or not. And only the abnormal scans, as said by the AI, are sent to a radiologist. So this is very good use of using a resource which is hugely not available. There is a huge acute shortage of radiologists, not just in India, but in the UK, US, everywhere. So I think examples such as these are also applicable for breast cancer screening, where if at a large level we can go around with mobile mammography vans, do screening, and use artificial intelligence to at least do first level of filtering, it can provide huge advantages and promote screening and at the same time be very cost efficient, because at that scale you can have bargaining power with the AI vendor and with the other agencies involved to screen at a mass level. And these are very real examples. This is already happening. In fact, WHO has mandated and given approval for AI to be used at least for TB, and very soon there are talks and plenty of examples globally at least where they are using AI for lung cancer screening, and again very real examples of AI, like you said. Essentially lung cancer screening would involve a CT scan which does have radiation in it, but now there are technologies which reduce the radiation dose dramatically, which results in loss of image quality, but that image quality is enhanced using artificial intelligence, and then you use a second algorithm to detect any abnormalities. So there are plenty of examples in this space specific to cancer and also other NCDs that we have, and early detection eventually results also in huge savings, not only for the patient but for the governments and other payers.
Thanks, Kabir. So Dr. Manu, while we are speaking about artificial intelligence and diagnostic, etc., one of the use cases essentially becomes wherein artificial intelligence can screen in the images of CT scan, etc., give predictive analytics around the same, that there is a predictive chances of having a cancer, or similar, there are other AI algorithms as well, basis certain hereditary parameters, basis certain other parameters, etc. A patient might be having at more risk of developing a cancer. For example, we spoke about having smoking, having BRCA, etc., etc. How do you see those things coming up in the clinical care and enhancing information to the patient about the same?
As Dr. Kabir has rightly pointed out, so a lot of development is happening in the field of AI in the cancer detection and screening. So especially the review of images, and also AI is being used mainly to analyze the genomic profile and also in the drug discovery part. So here, I mean, at this point, it is very difficult to say that through AI we can formulate a conclusive answer to this question, because there are a lot of challenges which we have discussed. So, but that part is evolving, and we need more data on that aspect. But with the focus on imaging, genomic profile, and application of AI and machine learning, we'll be definitely able to reach a stage where we can help patients. But at the same time, there's a lot of ethical issues in how we bring this into the practice and make an impact onto the patient care.
Perfect. Coming to you, Dr. Swati, being a digital health professional, while a lot is being said with respect to use of artificial intelligence in the space of cancer, right? But there is a lot already been said in the previous panel about information asymmetry that exists in the mind of patients. Also awareness with respect to prevention of cancer or early diagnosis of cancer, maybe just because of just by breast examination, finding a lump in the breast, etc. How do you see this information asymmetry existing in India, and how we can solve some of these problems by digital platforms such as Tata 1mg?
I'm glad that you brought it up, a very important point, and Dr. Indu spoke about it. Dr. Rajiv also touched based upon that. I'd just like to share a very quick story in here. So 5 weeks back, we were in a cancer care workshop with a behavioral research company, organization, And it was beautifully conducted. We were trying to understand the unmet needs of what lies for people who are touched by cancer and their caregivers. And one day it went fine. The other day the researcher asked us, the entire team, that what do you remember, what was something that you share ahead? And there was one of our colleague who heads the design at Tata 1mg. I'm putting it in her own words, that I felt very overwhelmed by the kind of information that you shared. I wanted to share it ahead. I called my wife and I shared that, today I attended a really interesting workshop wherein I got a glimpse of how people's lives are touched by cancer. And all she said was, she didn't ask anything. She said, "Mujhe mat batao, I don't want to know any further." So, with this you see that people just want to avoid information because of that fear this word cancer evokes in their mind. So information, there are these two interesting spectrums. There is information asymmetry, but on the other hand, there is this willful ignorance, or there is this avoidance coping. People feel if I don't hear about it, it won't come to me. So these are the biggest barrier, willful ignorance combined with information asymmetry that we are dealing with in the current scenario. But the good part is, with digital players into the market, like Tata 1mg, Dr. Rajiv earlier shared, is an integrated healthcare platform. Our capacities expand beyond geographical boundaries and demographic limitations. Just to share some perspective, Tata 1mg as a platform, we have over 40 million monthly active users who use this platform for their healthcare needs. And another data point suggests that in the overall average monthly basis, more than a little over 2 million internet searches happen around cancer, its treatment and cost. So people are looking for the right information. So we had this vision that, maybe navigating through the entire cancer care journey is unfortunately tough. But can we make the access to the right resources, right experts, a little easy for people out there? And with that in mind, we came with a dedicated cancer care platform, the Tata 1mg Cancer Care Platform as we see it today, wherein we have built a comprehensive coverage of multiple resources, tools, support system. You can access the right expert depending on the kind of treatment you're looking for. Financial counseling, for example, what statewide government schemes are available at your disposal. And other than that, the screening test, like Mr. Kabir mentioned, we have listed 500 plus tests, screening, predictive, diagnostic, prognostic, that people can get access to, and we facilitate it. But of course, this is just the beginning. And with the right ecosystem support, we have places to go. But the entire digital ecosystem, with more than 650 million in India having access to smartphone, which is nearly 46% of the Indian population, we can make a world of difference, especially in terms of bridging the gap between information and how you access cancer care.
Perfect. Very rightly said that overall accessibility to right information, accessibility to right treatment, accessibility to authentic medicine, accessibility to second consult around and knowing whom to consult, when to consult, becomes very, very important apart from the affordability piece of it. And of course, figuring out the clinical part and figuring out the right physician also becomes very, very important. And therefore, I come to Dr. Sanjay. So, Dr. Sanjay, while a lot is being told about digital practices that are helping the patients in terms of solving the problem of information asymmetry, use of artificial intelligence, etc., can you share some insights about how digital part is solving the problem more from the doctor side of it, and also what hospitals are doing for solving the part of maybe a lot of information that patient have to carry along, a lot of patient record that the patient have to carry along, how that part can be solved and is being solved currently?
Good afternoon to good evening side we are running. For me, it's always like as a cancer surgeon and director of MP Birla Group of Hospitals, which are basically, I am working in a rural healthcare model for last 42 years. तो मेरी प्रॉब्लम कुछ अलग है.
Sure.
लेकिन मैं समझता हूँ कि बुंदेलखंड और विंध्य प्रदेश में जहाँ पे मैं हूँ, तो एक बहुत बढ़िया अस्पताल है. हम 400 बेड के अस्पताल हैं, लिनेक है हमारे पास, सब है, हमने इस्टेब्लिश किया. लेकिन जहाँ तक डिजिटलाइजेशन, कैरिंग द डेटा, एनालाइजिंग द डेटा, और जैसा कि एस्टीम पैनल ने भी बताया, देखिए ये जो गैप है, ये बहुत बड़ा गैप है.
राइट.
शहरों में और छोटे गांव में उसकी कीमत जो है वो बहुत कठिन है और जटिल है समझना. क्योंकि आदमी के पास, आई एंटर्ड इनटू गिनीज रिकॉर्ड्स बाय रिमूविंग ए 66 kg ट्यूमर विच आई विल बी शेयरिंग इन द इवनिंग. मुझे ऐसा लगता है कि जो गैप है, जो ताइवान में मैं जब गया तो एक इको पैटर्न 30 साल से वहाँ पे डेवलप हुआ है. 30 साल लग गए उनको. वो पैटर्न डेवलप करने के लिए सभी को ब्रिज करना पड़ेगा. गैप, पेशेंट की फाइल थैले के रूप में बढ़ती है और फिर वो उसको कंबल में बांध के लाता है. ये मेरा एक्सपीरियंस है, आपको बता रहा हूँ. वो इसलिए होता है कि वो हमारे यहाँ से नागपुर जाएगा, नागपुर से हैदराबाद जाएगा, तो ब्रिजिंग, व्हाट आर वी ट्राइंग टू ब्रिज, मेरे को ये नहीं समझ में आता. क्योंकि उसमें प्रॉब्लम सिर्फ एक आती है कि हम समानता जब चाहते हैं और ब्रिज करना चाहते हैं, तो उस ब्रिज में हमें टेक्नोलॉजी को गांव तक लाना पड़ेगा. पिछले 3 कॉन्फ्रेंसेस में सिर्फ मैं यही रिक्वेस्ट करता हूं सभी से, आप सभी लोगों से, कि आप आइए, गांव में आइए. जब तक आप गांव में नहीं आएंगे, ये ब्रिज गैप ही नहीं होगा, कभी नहीं होगा. आप 50 साल लगा दो, 100 साल लगा दो, हम आज़ादी के कोई से अमृत या जो भी काल में होंगे, वी हैव टू अंडरस्टैंड दैट गरीब जो है वो नहीं आ पा रहा है शहर में. आज 27 से 28 करोड़ लोग स्नान कर सकते हैं क्योंकि वो रिलीजन है, लेकिन हेल्थ के पास, उसके पास पैसा नहीं है.
राइट.
तो अगर उसको, हमको जब वो 66 kg का ट्यूमर निकाला, तो मैंने उसको पूछा, उस लेडी को जिसका नाम सुगिया था, तो उसके शरीर पे ढकने के लिए कपड़ा नहीं था. मैं कोई कहानी नहीं सुना. बेसिकली आई जस्ट वांट टू, बिकॉज मुझे ऐसा लगा कि सुबह से मैं सुन रहा हूँ तो मैं कुछ अपनी भी बताऊँ. गांव की बात है इसलिए बता रहा हूँ. और ट्रेनिंग मेरी स्लो एंड मेमोरियल में हुई थी. मैं मणिपाल का 76 बैच का हूँ. तो जीवन में सफ़ेद बाल जो हुए वो मैंने देखा, इस गरीबी को बहुत करीबी से देखा, और अभी योगी जी के साथ मैं बहुत करीबी से काम कर रहा हूँ. तो मुझे ऐसा लगता है कि आप लोग शहर को छोड़ के थोड़ी सी गांव की ओर आइए. थोड़ा सा कम महंगा करिए इलाज, बहुत महंगा है. मैं विपल पैनक्रियाटिक ऑपरेशन 3000 रुपये में करता हूँ, लंग सर्जरी 5000 में करता हूँ. मैं आपको बता रहा हूँ, मैं आपको इसलिए बोल रहा हूँ कि हम डॉक्टर्स लोगों ने बहुत इलाज महंगा करते हैं, बहुत इलाज. ब्रिज नहीं हो पा रहा है, इट इज़ वेरी डिफ़िकल्ट. लेकिन हाँ, ये एक जो सोल्यूशन है, ये जो है, ये करेगा. ये कैसे करेगा वो बताता हूँ. 2002 में हम लोगों ने 4 ISD लाइन ली थी. डॉक्टर कबीर, आई एम जस्ट ट्राइंग टू शेयर विथ यू. पहली टेलीमेडिसिन सेंटर इस कंट्री की मैंने चालू करी थी सतना में. और कोएक्सियल लाइन डाली, खम्भों पे चढ़े. किशोर रेड्डी बोल के एक लड़का था अपोलो हैदराबाद में, तो उसको मैंने बुलाया था. मैंने कहा यार तू करके बता यार कुछ. और 4 ISDN लाइन में 64 kbps डेटा से जब पहली बार इस कंट्री में हमने चालू किया, तो मुझे खुशी हुई कि अपोलो चेन्नई के डॉक्टर्स लोगों ने टेलीकार्डियोलॉजी की पहली कॉन्फ्रेंस मेरे साथ करी थी 2002 में. तब गैप मैं फिल करना चाहता था, लेकिन जो है वो हालत है. तो अब ये समझना है कि हम कैसे उस गरीब तक 140 में सिर्फ 2 करोड़ ही अमीर हैं। 138 आर पुअरेस्ट ऑफ पुअर, जो गंगा जी में स्नान करने के लिए इसलिए जा रहे हैं कि पाप भी धुलें और बीमारी भी दूर हो जाए। रियली ये बात है। तो आप समझिए, इन कॉन्फ्रेंसेस में एक मैसेज मैं हमेशा देता हूँ कि आप अगर इलाज करना चाहते हैं किसी भी बीमारी का, तो उसके रूट पर पहुँचे। रूट की बात सुबह चल रही थी, तो मेरा कहना है रूट पे पहुँचने का सिर्फ एक ही सिंपल तरीका है, गांव में आइए, उसके मॉडल बनाइए आप। उसकी MRI, जैसे हमारे यहाँ MRI मशीन है, तो डॉक्टर कबीर वी चार्ज अबाउट 2300 रुपीज़, क्योंकि मैं प्राइवेट ऑर्गेनाइजेशन में हूँ, तो अभी बहुत सारे मल्टीनेशनल वाले हमारे यहाँ घुस गए, तो ROI तो हमको डर भी लगने लगता है डॉक्टर्स को। और टारगेट्स, हमारे यहाँ नहीं आई है वो बीमारी, लेकिन ये बीमारी फैल गई। इट इज़ लाइक कैंसर। So please, thank you.
Sure. Thank you so much for sharing your insights. And of course, digital and digitization, artificial intelligence, as I was speaking to Kabir as well, that is going to not only improve the accessibility, will also improve the affordability and reduce the cost of overall these diagnostic, etc. And as you very rightly mentioned, maybe the cost of treatment, etc. that needs to be reduced. That can be reduced, one, by early diagnosis that we are already talking about over here. And if that information spread in various nook and corner of the country, that can definitely help in that particular cause. And thank you so much, Dr. Sanjay, for helping the cause and serving the poor and serving the rest of the country, which you are doing currently. Moving on to Dr. Kanika, so from the radiation oncology, what role do you think the digital play in personalizing the overall radiotherapy plans for the patient, and how overall digitization can help in improvement in care of the patients in general for oncology?
So before I answer your question, I was prompted to say something when, Swati mentioned that story about the husband not able to convince his wife to hear about cancer. So I think as an oncology community, firstly, we really need to, mitigate this word of talking about the big C word. Because we have glorified it, or maybe we have made the word ourselves so scary that the community doesn't want to talk about it. And that fear itself is forbidding for the patients to come for screening. So I think we should make our efforts to make people understand that it is also a disease like many other diseases. So I think that will help us to bring in more and more patients to reach to us for screening, which elementally everybody is saying from the morning remains to be the elemental corner for success for reducing the burden. Coming to my field of radiation oncology, I think amongst all the verticals of oncology, this is one field which has undergone a lot of transformation by virtue of digitalization coming in. And I think most people who are seeing patients being treated on linear accelerators would know what I mean by the transformation. So it is getting more and more personalized, and with the AI also stepping in, and we have been using it for the past decade or so, we are able to do a lot of automated things. So our segmentations, when we are doing radiation plannings, they are becoming automated, and that is reducing our the turnaround time. It is helping us to make our departments more efficient. However, as any AI-based systems, it has to be verified by a human. You cannot rely totally on these automated tools to plan your patients. But it has given us a lot of further improvisation ability, and we are real-time monitoring the patients, because now these algorithms are giving us information when the patient is on the treatment couch that the tumor is shrinking, so we can adapt our treatment. By real-time digital fusion of images, we can change our radiation plans. More so, we are able to even, escalate dose to a pinpoint tumor relative to the rest of the body because of these algorithms, which are purely digital. However, they come with a cost, and Sir has been, highlighting this factor hugely, that it does come with a cost. So there is something to be done about it. It hasn't happened with Make in India, unfortunately. Although Make in India, I hugely respect our Honorable Prime Minister's motive, but we really need to do something about how this technology comes to us, because patients pay higher because the installations cost higher. We pay a lot of custom duties to bring in these systems to our units. Another place where, as an oncologist, I see that difference of digitalization, I think the digital health records. Even I had a patient walk in, patient's wife walk in with a suitcase. And I asked her, you are coming directly from the railway station or the airport? She says, no, he's a glioma patient. Initially he was a low-grade glioma, now he's a high-grade glioma. I have all the MRIs of the last 15 years with you. You might be asking for any one of them. I didn't know which one to carry. So I think digital health records, which we have adopted in our hospitals. Patient has his own app. All the imaging, all the tests which are done with us are in a timeline available with the patient in a record form. It is accessible to me in my phone as an app and in our EMR system. So that again reduces a lot of time in your clinic. When you're sitting with the patients, you are not fumbling through papers, looking out for scratches of information to define your plan of care. Here you are getting all the access point at one point and you're able to define things better. You are getting the consult notes of all the colleagues who have seen the patient, because otherwise treatment in cancer care becomes fragmented, because there are not only me as a radiation oncologist who's part of the team, there will be my medical oncology colleague, the surgical colleague, molecular oncology colleague. So that is how digitalization has improved the cancer care treatment, at least in the radiation aspect.
Thanks, Dr. Kanika. And I definitely know so many different patients carrying these suitcases filled with all these different reports, MRI reports, these test reports, etc. In fact, one of my aunts, when she suffered from a blood cancer, there was this huge suitcase, and my cousin, knowing that I'm a doctor, simply just asked me, can I just prepare a simple Excel with overall all the history of the patient captured over there? That becomes very easy to carry. So as a solution, what we also are working on, creating a sort of a digital health repository for the patient that gives more or less a graphical representation of overall different diagnostic that the patient might be suffering from, and the patient might be having abnormalities in that, making it easier not only to share with clinician, but also making it easier for patient to understand by themselves what is happening with them and at what point what treatment might be needed. All those information in symmetry as well, we are trying to solve at Tata 1mg as well. So maybe shifting gear from the information asymmetry part and the artificial intelligence part to maybe a little bit more about affordability, right? So Dr. Manu, a lot is known about how difficult a cancer patient journey can be in terms of affordability. Most of the cancer treatment, as we already know, some of these targeted therapies, etc., can be multiple lakhs, and the cost of cancer treatment can range up to a few lakhs to $1 million as well, or maybe a little bit more. One of the studies that we did at Tata 1mg essentially says that on an average, a cancer patient usually spend a little more than at least 3 lakh rupees an annum, if not more, on the healthcare expenditure. That is mostly not affordable by the lower part of the country, and I know patients who are spending like 50 lakh rupees, etc., etc. How do you see maybe some of the digitization in the technology, early diagnosis, and rest of the things are helping in the cause of affordability as well?
Yes, Dr. Piyush, as you rightly pointed out, this financial part of cancer treatment is really important. We generally call it as financial toxicity. So that is one of the most important parameters, no doubt in that. And digital health initiatives can help in some way at least. So I'm a medical oncologist, so my patients, unlike radiation and surgery, there is more scope for remote activities like telemedicine in medical oncology. So we used to do it during the COVID era. Like you see so many patients through the online platform, make prescription, deliver the drugs also, which will definitely help the patient in many ways. The travel cost will be cut down, waiting times will be cut down, and caregivers' work will continue so that they will not lose the wages for that day. So such an initiative will definitely help us to bring down the cost. So, but in oncology, unlike other specialty, there are a lot of challenges in implementing it for all the patients. One is it is basically a multidisciplinary approach. So even if I see a patient, if I need others' support, I'll have to bring the patient to the hospital. And also, it is not just the clinician who sees the patient. There will be a lot of team of other supportive staff, like my psycho-oncologist will be assessing the patient's distress, geriatrician will be assessing geriatric assessment. So these all these things incorporated into the available online platforms may not be easy. But definitely we should look at developing some web-based applications to capture these data also, so that the complete care will not be compromised. So that is one thing. And another thing is like telemedicine, I said, not only the financial toxicity, now there is a concept called as time toxicity. Like especially in advanced malignancy patient, though we are improving the survival, most of the time is spent in the hospitals and during the travel. So that is also an endpoint that we have identified of late. So that also we'll be able to bring down by using telemedicine platforms. But unfortunately, after COVID, especially in oncology, in my experience, the use of such platforms have come down. One is that those things were not streamlined, apart from the challenges that I've mentioned. There's no definite framework to guide these practices, because in oncology there's a lot of medical legal issues also, how to take an informed consenting process through the online. Those things, those guidelines on that aspect were lacking. That might be a reason why in oncology the telemedicine concepts has not come significantly. And another thing is, even now my patients, majority of patients, if I give chemotherapy, they can have low counts, blood counts can go down. We generally ask them to do the blood test and send it to us. But if you see low counts, we'll be in a state of emergency. We'll have to bring the patient to the hospital. They may be traveling for 3 or 4 hours, but patient will be stable. Only on assessing you'll be able to know that patient is doing well, no need to intervene. But if you have something to monitor them remotely, like cost-effective application to monitor the vitals, we can tell them that it's okay. Currently you're stable, no need to come all the way to the hospital. So to have telemedicine effective in oncology setting, we should have some other supportive measures and apps, so that we can continue this care without compromising the quality of care. So that is one thing. And other thing is like this financial toxicity part. Certain things we as a clinician we cannot help. Like we have novel molecules which are very expensive. So only thing we can do is to discuss with the patient's risk and benefit, and based on the cost-benefit ratio, order these medications. But other aspects, we can try to reduce the cost of treatment by reducing the hospital visits, reducing the time in the hospital. All those measures can be done to reduce the cost of treatment. And another thing is information regarding the availability of services. So I work in a corporate. There may be patients who cannot afford treatment in a corporate, but unaware of similar treatment being offered in government institutions. Or it can happen vice versa also. So information regarding the centers which provide care, information regarding the financial aspects of treatment are still not available to the patient easily.
Absolutely. It was very recently the same patient that I'm talking about needed the radiation for the treatment, and they belonged from Mathura, just have a general store, and they were told that it's going to cost approximately 2 lakh just to get the radiation part of it. Then they got to know, if you have Ayushman Bharat, probably your radiation at one of the medical colleges can get for free of the cost. So this is also about knowing about some of the states and government scheme, etc. So coming to you, Dr. Swati, for that, how can digital pharmacy or the digital player like Tata 1mg can help patients solving the part with respect to state government and other government schemes, etc., and solving other problem with respect to affordability?
It's something worth discussing, and Dr. Manu Prasad brought some really prominent concerns and prominent questions which are very applicable to the industry we work with, a digital player. And we have many hats to wear, many problems to solve, many real problems to be solved actually. If I talk particularly about one of the most important service lines at Tata 1mg, e-pharmacy, for which India knows us, is that from procurement to supply chain management, from logistics to last mile delivery of medicines until patients actually receive it, the deployment of digital infra remains at the core of it to improve efficiency, and that also gives us scalability. And I feel both ecstatic and humble to share this today, that in the current ongoing year, we have served over 1 lakh cancer patients. So there is some real problem that we are solving. And I'm coming to the accessibility part directly. Improving access to medications is something wherein digital players like Tata 1mg have a huge potential, and they have displayed that huge potential. For example, संजय सर ने बात करी कि रूरल एरियाज़ और रिमोट एरियाज़ में गांव के लोगों तक आप वो चीज़ें कैसे पहुंचा सकते हैं. तो रूरल एरियाज़ में भी पीपल कैन एक्सेस द इंफॉर्मेशन and they can also access the medicines because many specialty medications might not be available locally. And then people can explore the availability of the medications, compare their cost, which then help them make an informed decision. Apart from that, one important aspect is cold chain logistics, wherein how to supply temperature sensitive medicines like immunotherapies. Currently, with the digital infra in place, we have real-time monitoring of temperature-sensitive medicines, wherein both the doctors, the healthcare provider, and the patients can get real-time access to how their medicines are transported and their efficiency is maintained. Coming to adherence part, we have some beautifully designed and some very useful digital products which enable a patient to have automatic e-refills, prescription reminders, and e-prescription upload, which supports telemedicine or tele-oncology practices, which then foster a better patient adherence outcome. And last but not the least, the talk of the town, how to tackle counterfeit medications. Verified platforms with their licensed vendors and trackable supply chain. You know, they reduce the chances of fake or substandard medicine, and hence the access to authentic medication is immensely improved. If I talk about affordability, that is another super crucial aspect to be talked in here. So yeah, that's a huge burden for someone dealing with cancer, and financial and emotional burden is what weighs a person down. Especially talking of the digital infra that we have put in place that are fully compliant proof. Today, we are working with top pharmaceutical companies which provide them a platform to extend valuable value-added services to the patients who are in need. Currently, we are the market leader with over 90 patient assistance programs running, which extend multiple services like making the medicines available at a subsidized cost, or be it financial counseling, getting them access to state and government schemes, even nutritional counseling, financial counseling, emotional counseling. All of these aspects are well covered. And then of course, if you don't have to travel to multiple resources to get access to what you really need, you know, your travel cost is optimized. And today we are extending beyond medications and e-diagnostics. We have ambulance at home, as an emergency service, vaccination at home, and physiotherapy at home. So the entire spectrum of patient assistance at home is being solved by the sheer convenience that it brings.
Sure. I mean, definitely providing these value-added services to the patient at home, as Dr. Manu Prasad also said, not only provide convenience to the patient, reduce the mental burden of disease that the patient goes through, but also reduces overall treatment cost for these patients, because many of these services are being provided because many of the cancer patients, as we all know, would be having a risk of suffering from infection just because of reduction in their blood counts, etc. And not being allowing, or maybe not asking them to travel to certain places and providing certain services at home can provide them a good benefit overall. So maybe shifting gears from overall part of accessibility and affordability to more toward the policy and the how can government policy improve overall and accelerate the implementation of digitization and bring more and more information to the patient. So definitely understand in the previous panel when Urvashi told about that a lot is being said about it, and of course the government is doing its work, but it's more toward both from the government as well as from the private player that more information needs to be passed on to these particular patients. But Dr. Kanika, what do you think from the policy perspective? What are certain things that can be done to accelerate the overall policy changes in India?
Right, so I think you heard from sir, you have to think of the last woman standing or the last man standing, that is our rural population, because we know there's a lot of polarization. On an average, if you see, a cancer patient in our country travels around 5 hours to reach to the cancer care institution. So firstly, we need to bring the cancer care closer to him. So how can we do that? Government itself is thinking of building medical colleges per district and bringing oncology in almost every medical college. It's a long shot. So as of now, I think hub and spoke is what most of us look at as a viable solution, and their digitalization can help. So you can upskill the doctors who are sitting at remote centers. At least they can do surveillance. During the survivorship, they can do follow-ups. And with the reach of telemedicine, they can come in contact with the primary caregiver and bridge that gap of follow-up at least. So the patient has to come to us less. The other thing, I think, where digitalization again helps is patient education. So when patients come to us, as clinicians, we are busy telling them about the therapy part, and there is a lot required from the counseling aspect in terms of toxicity management, what to watch out for. So therein, you can build in certain digital education tools. I remember doing one of the projects for my IIM course last year, where we created small QR codes. When you scan that, you know everything about that particular side effect, your ongoing treatment, what to encounter during treatment. So a lot of questions are addressed, and patients are aware that these are the likelihood things for which we need to reach out to the doctor. So I think education, I think, is the biggest tool which the mobile can give us. If people can scroll through Instas for hours together, if you are giving them good resources when they're ongoing treatment, they will be really serving as a very good repository for our patients. So I think therein some role of this comes, and private private partnership would have to pitch in, because public hospitals are already under pressure with a lot of other eminent issues. They cannot devote their entire time. So I think some partnership projects need to be built in to bring this accessibility to the grassroots level.
Thank you, Dr. Kanika. So, Dr. Sanjay, as you have served at the grassroots, what do you think can be some of the policy changes that can be implemented by bringing in digitization and bringing in better care to the patient at the grassroots?
हमेशा मुझे लास्ट में बोला जाता है कि 2 बॉल रह गई हैं और 50 रन बनाने. तो मेरे को हमेशा यही लगता है कि कैसे इसको पॉलिसी में, हम तो कुछ कर नहीं सकते पॉलिसी का ज़्यादा, सरकार को आधार जैसे बनाया वैसे ही कुछ हर बीमारी का कैंसर आधार बना दे. कैंसर, रेस्पिरेटरी डिसीज़ का, कैंसर, डायबिटीज़ का आधार बनाए. क्या होता है इसमें कि एक्सचेंज ऑफ डेटा, जो अपन जिस बात को बोल रहे हैं, हम लोगों ने 2007 में स्किल डेवलपमेंट प्रोग्राम फॉर अंडर प्रिविलेज्ड चाइल्ड लेबर का किया. 7,800 बच्चों को अभी तक मैं ट्रेन कर चुका हूँ. जो पन्नी गोबर कचरा जमा करते थे उनको हमने फ्रंट ऑफिसेज में, एक्सरे टेक्नीशियंस. तो जब ये जैसे डॉक्टर कनिका बता रही थी, एजुकेशन विल रिमेन द की थिंग. जब गांव की वो छोटी सी लड़की घर में जाके बोलती है कि पापा आपको खांसी में खून आ रहा है, तो आप जाके डॉक्टर को दिखाइए, मेरे को डॉक्टर महेश्वरी ने ये बोला है कि ये लंग कैंसर हो सकता है. ट्यूबरक्लोसिस तो कॉमन नहीं है. तो जब हम बच्चों को पढ़ाएंगे, और दूसरी चीज़, मेरे जो भी डॉक्टर कलीग्स हैं, मेरा ये कहना है कि आप जिस भी अस्पताल में काम करते हैं, डॉक्टर कबीर इज़ रनिंग ए वेरी ह्यूज, आई नो हिज डैड वेल. सो व्हाट आई वाज ट्राइंग टू से कि आप लोग एजुकेट करिए. 10-10 बच्चों को एक महीने में लीजिए, जो गरीब बच्चा है, ताकि वो आपके MRI और एक्सरे देख के अपने गांव जब जाएगा नोएडा के पास, तो वहाँ के एक्सरे देखेगा तो वो बोलेगा कि आप डॉक्टर से मिल लीजिए जल्दी. यू सी व्हाट इज़ हैपनिंग इज़ दिस गैप बिटवीन दिस कंट्री सो वास्ट ना. तो अभी एक बार हम रिलीजन में तो हमने एक पब्लिसिटी की कि ये 140 साल में पहली बार कुंभ आ रहा है, तो 70 करोड़ पहुंच गए उधर. उसी तरह से हमको डिजीज़ को भी टैकल करना पड़ेगा. उसको जल्दी पकड़ेंगे तो जल्दी रिजल्ट आएंगे. आप कितना ही करो गरीब मरीज को, वो नहीं जाएगा जब तक उसका बच्चा नहीं बोलेगा. मेरा ये मानना है. तो एक तो ये चीज़ हुई, एजुकेशन हुई, स्किल डेवलपमेंट, छोटे छोटे प्रोग्राम्स सब डॉक्टर्स लोग लें अपने क्लिनिक में. 5-5, 6-6 अंडर प्रिविलेज गांव के बच्चों को पढ़ाएं, सिखाएं कि ये ब्लड इस तरह से लिया जाता है, ये दवाई जो देते हैं. देखिए आज वेस्टर्न वर्ल्ड में क्या हो रहा है, मतलब आई जस्ट टेक फ्यू मिनट्स, कि एक को कीमोथेरेपी दे रहा है, तो पिताजी बच्चे को जब कीमोथेरेपी लिम्फोमा के लिए लग रही है, तो वो अपने भी बाल शेव कर लेता है. उसको आपको मेंटल सपोर्ट देना है। सोसाइटी को आप जब तक मेंटल सपोर्ट या एजुकेट नहीं करेंगे तो ये सिस्टम में बहुत ज़्यादा, मतलब मैं तो कुछ कर ही नहीं सकता, पॉलिसी तो बड़े बड़े 7 स्टार्स में बनती है बेसिकली। गांव में कोई नहीं आके पूछ रहा कि भाई आपको क्या ज़रूरत है, पानी नहीं मिल रहा तो अब कैंसर तो बहुत दूर की बात है। ये जो झाग का पानी जो पी रहे हैं आप लोग दिल्ली वाले, तो ये बहुत टाइम लगेगा इसको। मतलब ये मेरा दिल की बात बता रहा हूँ मैं आपको, कैंसर तो बहुत दूर की बात है। पॉल्यूशन इज सो हाई, कोई बोल रहा था कि स्मोकर नॉन स्मोकर में दिल्ली में कोई फ़र्क नहीं है, राइट? वी आर, मतलब तो आपको पॉलिसी में एजुकेशन करना पड़ेगा अंडर प्रिविलेज बच्चों को, बाकी तो सब अपन पढ़ ही रहे हैं बड़ी बड़ी जगहों पे। वो बच्चा जब समझेगा बीमारियों के बारे में तो घर में, गांव में, आसपास के लोग, पहली चीज़। दूसरी चीज़, डेटा डिजिटलाइजेशन के लिए कुछ आधार का जैसा सिस्टम बना, सारी दुनिया में या सारे भारत में कहीं पे भी जाते हैं आधार दिखाया, आप एयरपोर्ट पे चले जाइए, कहीं पे भी चले, उसी तरह से एक कैंसर का डाटा जब एंट्री हो जाएगी उस मरीज की, वो कहीं पे भी जाए, उसकी बार बार जांचें क्यों होती हैं? मेरे यहाँ से सतना से सीटी स्कैन करा के जाता है, जबलपुर में 2 सीटी स्कैन, नागपुर में 3 सीटी स्कैन, दिल्ली में 5 सीटी स्कैन। मतलब कबीर मस्ट बी क्वाइट काइंड ऑफ, ही विल एग्री विथ मी कि झोला लेके आते हैं एमआरआई के, झोले भर भर के। बोले कि लास्ट में महाजन साहब के पास जाएंगे तब हो जाएगा हमारा बराबर वाला, क्योंकि इनके पास 3 टेस्ला है, मेरे पास 1.5 टेस्ला का है। सो सी व्हाट आई एम ट्राइंग टू से कि रिपीट ना हो चीज़ें। तीसरी चीज़ जो मुझे लगती है कि हर कॉरपोरेट को, चाहे वो टाटा हो, चाहे बिरला हो, चाहे महाजन हो, चाहे और भी कोई हो, पारस वाले, स्पर्श वाले, सभी लोग आए इसमें, तो इन लोगों को कुछ रियली में जो इन्वर्टेड कोमा में CSR है, उस CSR के उस पोर्शन को हटा के रियल में कम्युनिटी अवेयरनेस के अच्छे प्रोग्राम करना चाहिए, विच टाटाज हैव बीन डूइंग फॉर सो मेनी ईयर्स। मतलब वो तो अभी नाम आया है CSR का, बिरलाज एंड टाटाज ने तो बहुत लंबे समय से, मतलब 8-8 जनरेशन से काम किया है, तो वो काम करना चाहिए। और तीसरी चीज़, हमारे यहाँ जो जनप्रतिनिधि सो कॉल्ड, अच्छे वाले ख़राब वाले जो भी हैं, उनको हम समझाएं बीमारियों के बारे में, उनको लड्डुओं से ना तौल के उनको बताएं कि ये मरीज, जो 7 मरीज खड़े हुए हैं साहब, इनको ये प्रॉब्लम, पैसा देने से नहीं हो रहा है कि राहत, मुख्यमंत्री राहत कोष से इनको 1 लाख रुपए, वो 1 लाख तो बेचारा वो यहाँ से बम्बई जाता ख़त्म हो जाता है। और छोटे छोटे सेंटर्स को सरकार, कोई कॉरपोरेट अडेप्ट करे, उनको रिवाइव करे और वहाँ पे हमारे बच्चे जाएं। मैं तो मतलब मैं इसलिए आपको बोल रहा हूँ कि मैंने ये देखा है, महसूस किया है, इसलिए आपके साथ ये शेयर कर रहा हूँ, क्योंकि इस फोरम पे नॉर्मली लोग बाग शर्माते हैं कुछ बातें करने के लिए, लेकिन मैं इसी तरह का बनाऊँ तो बोल भी देता हूँ। तो मेरा ये मानना है कि अपन सब लोग इस कॉन्फ्रेंस की कैरी होम मैसेज क्या होना चाहिए कि हम जाके सिखाएं, हम अपने फादर को सिखाएं, मदर को सिखाएं, क्योंकि वो गांव की लोगों के साथ बैठती है, कम्युनिटी होती है वहाँ पे। शहरों में तो कम्युनिटी रही नहीं है, शहरों में तो यू नो इट, तो वो मैं बोल नहीं रहा हूँ। लेकिन अब ये जो करना है आप लोगों को इस फोरम से, जो भी डॉक्टर्स लोग, पॉलिसी मेकर्स, आप बड़े बड़े कॉरपोरेट से आते हैं, तो आप लोग इस चीज़ को विशेष ध्यान दीजिए। केरला में बहुत अच्छी कम्युनिटी सर्विस होती है, आई नो, आई एम फ्रॉम साउथ, सो आई नो इट। आंध्रा में बहुत कम्युनिटी सर्विसेज बहुत अच्छी, राजस्थान की जो बात कर रहे थे बहुत अच्छी, गांव वाले बैठते हैं, डिस्कस करते हैं कि भाई तेरे को ऐसा प्रॉब्लम, तो ये करना चाहिए, क्योंकि ये जीवन का मेरा एसेंस है, मैं आपके साथ शेयर कर रहा हूँ। और मैंने कुछ गलत किसी के लिए बोला हो तो मैं क्षमा मांगता हूँ। मेरी आदत है कि कुछ सीख के जाएं तो अच्छा है।
So very nicely said, Dr. Sanjay, and I totally agree. So very nicely said, Dr. Sanjay, and I totally agree that everyone, not only physician, also the patient should be educated before they become the patients, be it living in the rural part of the country or the urban part of the country, because knowing and knowledge is power. And of course, removing the stigma, as Dr. Rajiv also said, that it's not a stigma, it's about knowing it early can be cured early. Knowing that particular part is a power in itself. So being cognizant, while do have a lot of things, and I can discuss a lot of things, but being cognizant of the overall time, I will just have a last word from everyone. If there would be one thing that we would like to implement and want to change in terms of the digital cancer part, what that would be, starting with you, Dr. Swati.
There are many, in fact, but I really appreciate the way Dr. Manu Prasad, Dr. Kanika pointed out the problems in the digital data management as well as the telemedicine practice guidelines that are very thoughtfully curated, but still they don't provide coverage to anti-cancer drugs. So one thought and one scope, could there be specific guidelines around tele-oncology network and services, wherein there could be real on-ground laws and rules defining what is the eligibility criteria for a virtual versus an in-person oncology services. Also, important aspect, if in terms of equitable access and reimbursement, if insurance policies can also cover virtual cancer care services, that would be a game-changing thing, in my opinion, the way people see telemedicine and teleconsultation practices, especially how multidisciplinary teleoncology can then be brought and made more accessible to remote and rural areas. Yeah.
Sure. Dr. Manu?
Yeah, so with digital health in respect to our topic, like to reduce the gaps, so I think the most important thing is to make use of all the digital health platforms and facilities to make the cancer care decentralized, whether it is in private or in government. There are a lot of services which can be done at the periphery. We should have a strict framework for and defines which things can be done at the periphery and which things should be done at the major center. So we can definitely make use of all the digital health platforms and applications and everything to make sure that cancer care is decentralized so that accessibility will be better.
Sure. Kabir?
So I think the most important one or two things could be that there should be more incentive from the government to start early stage drug discovery and clinical trials and research within the country, because unfortunately or fortunately we have such a diverse set of patients, as was discussed in the previous panel. So what might be a rare disease in the West might not be as rare, and there are enough and more examples to show that high quality research and trials, early stage trials, can be done in the country, and that will translate into affordable drugs for the masses. So I think there needs to be some push from the government to incentivize more early stage trials and research, and the other could be some kind of investments and funding to pilot some of the digital initiatives that we are all talking about. It does cost a lot of money to implement, and any AI algorithm on its own to even experiment with some of the digital initiatives. The government does that with the ABHA ID, which Sir was mentioning about creating a digital ecosystem. So the government has done that with the ABHA ID, where in fact they do incentivize some 20 rupees for every new ABHA ID that is created, and then automatically the reports and the records go on to that. So some more real world schemes to incentivize the use of new age technologies would be great.
Right, I think apart from that, when we talk of digitalization, we are just talking of the deep-pocketed, high-heeled Indians. We are not talking of people who don't know how to use these apps. So we need to have more intuitive, more user-friendly apps which help these patients navigate through cancer from A to Z. They should not be working in silos. One app is for medicine, one app is for to reach out to the doctor, one app is for booking appointments, one app is to accessing reports. So it has to be more intuitive, user-friendly to patients who are not much educated as well. Because many a times there are these elderly patients who don't have youngsters helping them guide through the smartphones. They have phones. So to navigate through cancers, the digital technology has to be user-friendly. And adoption is again another thing. Even clinicians find it very difficult to adopt, going from the typical pen paper system to the digital system. So adopting into the public sector is going to be a Herculean task.
Sure. Dr. Sanjay.
मैं काफ़ी बोल चुका हूँ, बस यही है कि एक डॉक्टर को इंजीनियर भी बनाना चाहिए. ये मेरा मानना है कि 4 साल का कोर्स हमने इलिनॉय में चालू किया है. 4 साल का पहली इंजीनियरिंग का कोर्स करे, उसके बाद फिर 5 साल डॉक्टर बनने में लगाए, ताकि वो इन्वेंटर बने. अभी सिर्फ वो पेन पे, जैसा कनिका बता रही है, वो पेन पे ही लिखता रहता है, जीवन भर लिखता रहता है और खुश रहता है. क्योंकि टाटा मेमोरियल में 1996 में जब UICC दिल्ली में हो रहा था, तो हमको डेटा पूरा डिजिटलाइज करना था. तो श्याम, हु इज़ हेड ऑफ रेडिएशन ऑन्कोलॉजी दैट टाइम, तो श्याम इज़ माय कलीग. तो श्याम बोला कि डॉक्टर महेश्वरी अपन कैसे करेंगे, ये तो कुछ लिखा ही नहीं है ढंग से. मतलब पहले तो बड़े बड़े सर्जन थे ना, डिसूजा साहब, ये वो सब, तो सब बड़े बड़े साहब थे, लिखते ही नहीं थे कुछ. हम भी कुछ नहीं लिखते थे. फिर हमारे को बताया कि आप लिखोगे नहीं तो NABH भी नहीं होगा. तो सरकार ने बड़े अच्छे नियम बना दिए हैं कि आपको लिखना पड़ेगा. जब आप लिखोगे, आप डॉक्यूमेंट करोगे, तभी आज से 524 साल पहले तुलसीकृत रामायण बनी. अगर वो लिखते ही नहीं तो अपन भी भजन करते रहते ऐसे. तो लिखना ज़रूरी है डॉक्टर्स को, उसके लिए सपोर्ट ज़रूरी है, और उसका इंजीनियर बनना ज़रूरी है. वो नहीं तो वो एंटरप्रेन्योरशिप आएगी नहीं, ना वो रिसर्च करेगा. वो बस डेटा अपने साथ लेके मर जाते हैं बहुत सारे डॉक्टर्स लोग. तो उनको सिखाना पड़ेगा आप लोगों को.
Sure. So in nutshell, what we essentially are saying is that overall accessibility to easy information, that is not only easy to understand by clinician, but easy to understand by patients as well. Accessibility to medicine, accessibility to second consult, accessibility to affordable medicine by the patient, and accessibility to information around various government schemes, etc., remains at the core of making it easier for a patient to navigate the treatment or having this particular dreaded disease. Of course, there are certain policy changes which are required from the government to make changes in the teleconsultation guidelines, etc., to make teleconsultation easily accessible for treatment of cancer, etc., will be going a long way in treating and making the disease condition easier to navigate by the cancer patients, etc. Of course, usage of technology in the hospitals in terms of EMR, etc., also have a big role to play overall in improving the management of a cancer patient, given the overall record, etc., that a cancer patient and a physician needs to see through in overall predictive analytics, etc. Having said that, would like to thank the esteemed panel today for a very delightful conversation, and a very, very thank you everyone once again for the conversation that we had today. Thank you everyone. Have a very nice good evening.
Thank you so much, all the panelists. It was indeed a delightful conversation with some interesting anecdotes, very engaging, and of course, very informative. Now, I would like to invite on stage Dr. Rajiv Sharma, Vice President, Medical Affairs, Tata 1MG, to felicitate the speakers with a token of thanks. Thank you, sir. Starting with Dr. Sanjay Maheshwari, Cancer Surgeon, Urologist, and Medical Director, MP Birla Group of Hospitals. Thank you so much, sir. A big round of applause for Dr. Sanjay Maheshwari. Dr. Kanika Sood, Director and Clinical Lead, Radiation Oncology, Kamal Narayan Super Speciality Hospital. Thank you so much, ma'am. Mr. Kabir Mahajan, COO, Mahajan Imaging and Labs. Thank you so much, sir. Dr. Manu Prasad, Senior Consultant and Head Department Medical Oncology, Hospital Aster, MIMS Kannur. Thank you so much, sir. Dr. Swati Mishra, Director, Clinical Health and Content, Medical Affairs, Tata 1 MG. Thank you so much, ma'am. And last but not the least, our moderator, Dr. Piyush Jain, Director, Business Development and Strategy, Tata 1 MG. Thank you so much, sir, for moderating the session. Please put your hands together for this wonderful session. Thank you so much. Session on revolutionizing cancer care through digital health, bridging gaps in accessibility, affordability, and support. And now I request all the panelists to come forward for a group photograph, please. So please, thank you. Thank you so much. Moving on, it's time for our next session titled Collaborative Approach to Comprehensive Cancer Care. Effective cancer care requires a multidisciplinary and collaborative approach, bringing together clinicians, researchers, policymakers, and industry leaders. This session will explore how partnerships across healthcare, technology, and public health can enhance prevention, early detection, and personalized treatment. Experts will discuss innovative models that integrate medical expertise, patient support, and policy initiatives to improve cancer outcomes. For the discussion, I would like to invite on stage Dr. Ankita Jain, Medical Director, Oncology, Field of Medical Excellence, Pfizer. A big round of applause for Dr. Ankita Jain. A very warm welcome to you, ma'am. Dr. Vineet Talwar, Director, Department of Medical Oncology at RGCIRC. A very warm welcome to you, sir. Put your hands together for Dr. Vineet Talwar. Dr. Jyoti Vadva from Paras Healthcare, HOD Medical Oncology. A very warm welcome to you, ma'am. Please put your hands together for Dr. Jyoti Vadva. And last but not the least, our moderator for the session, Dr. Karan Thakur, Group Lead, Sustainability and ESG and Vice President, Public Affairs, Apollo Hospitals. A very warm welcome to you, sir. Well, about the moderator, well, Dr. Thakur is a seasoned healthcare administrator with expertise in health policy, hospital operations, and healthcare sustainability. He's a respected columnist, podcaster, and the recipient of numerous accolades, including the Young Leader Award by Apollo Hospitals and recognitions as one of the 40 under 40 in healthcare by Asia 1. So please put your hands together for Dr. Karan Thakur.
Thank you, ma'am. And that 40 under 40 was many years ago now, so I think it's dated. But anyway, thank you.
The journey has just begun.
Thank you for having me.
Over to you, sir.
Thank you. Thank you, ladies and gentlemen, for being here today. And for this session, I'd like to thank the IHW Council for having me over for this wonderful panel that we have today, experts in the room. And you would have all heard that this morning when the Union Finance budget was put across to the country, healthcare really stood out. And it is out of all the diseases that were really highlighted, cancer care was really one of those which stood out, with the government now promising to set up daycare cancer centers in all districts, beginning with 200 this year, and also looking at reducing duties for drugs for oncology and other rare diseases, and also for the bulk drugs that go in to make them. So really cancer care has been a focus of our country and also policy making and of hospitals and of people who run the divisions within those hospitals. And this session is important because we're looking at two aspects. We're looking at collaboration and we are really looking at comprehensive care. So while we know that a lot of collaboration takes place, it is not comprehensive, and where there is comprehensive care, it tends not to be collaborative in its approach. So before we begin, I think we have an excellent panel here practitioners and people who make this possible to get medicines, drugs, and access to technology. The first question would be to each of the panelists here on when we talk about collaborative cancer care, what comes to your mind? What is it that you think of when we say collaborative comprehensive cancer care? So Dr. Ankita, if I could ask you first to take a stab at that. To your mind, what would a good collaborative comprehensive care look like for cancer?
Thanks, Karan, and thanks to IHW Council for this opportunity and bringing so many like-minded people at one platform. Again, this session, so important. Two things which stand out as comprehensive and collaborative. And at the end of the day, I think what everyone is working towards is patients, right? So patient is in the center of whatever each of the stakeholders is doing. And for me, exactly that is what collaboration would be. All the stakeholders, including hospitals, physicians, pharmaceutical industry, government stakeholders, patient advocacy groups, everyone coming together, keeping the patient at the center of whatever we do.
Right, so that's the stakeholder approach where you look at patients at the center, but then all other stakeholders being important. Dr. Alvar, how do you look at comprehensive collaborative care? What comes to your mind, sir?
So first, you have to see the problem at large. So if you talk of statistics, which has been released by the Government of India, you have 16 lakh new patients of cancer who are enrolling every year. So this is the incidence. And, once you have a cancer patient in the family, it hits like a bolt from the blue for the whole family. It is not like, a bypass surgery or something which is a one-time affair. So this is a continuum. So again, going to the stats, about 6 crore people, they are going into the below poverty line because of this problem. And not only it causes financial stress to the family, but also to the national exchequer. So the discussion which is going on, this is a very, very important discussion. Once you have the figures in front of you, then probably you can formulate a policy. And as you rightly said, the government is looking forward to it, and they have said that in this year, 200 daycare centers, and they envisage one daycare center in each and every district. So if you have a problem at hand, you have to see how much is the quantum of the problem. Second, do you have the brick and mortar for it? So this is the brick and mortar for it. And after that, you have the verticals like the awareness, the health education, and if the patient has been diagnosed with cancer, what are the treatment paradigms which are there? Now, treatment paradigms does not only include the medical treatment. It includes the nutritional aspects, the psychosocial aspects which have to be, imbibed at the inception of treatment. And once you go through the treatment, even after the treatment is over, you have to look for the rehabilitation. So it's a big gamut, and I must confess at this point of time it's in a disarray, So it has to be organized, because the problem which you are looking as far as India is concerned, an India-centric problem, it is humongous, because the population, we are now at the tops. We are the most populous country in the world. So I guess one has to network according to the resources which are available and try to sift out how you have to go through it.
Right. So that was very useful. Thank you, Dr. Talwar. So you spoke about stakeholders. We moved on to also the components, whether it's infrastructure and other components that make good care, whether it's nutrition or other aspects of policy. Dr. Jyoti, when we talk about collaborative care, comprehensive care, what comes to your mind, or what are those, the key building blocks of making a successful program when we talk about collaboration?
Right. So I think the first and foremost thing to remember here, and which is a fact, is that cancer treatment is a team effort. So we must never forget this. And it is a team effort, and it should always be a team effort. Now this team it happens to be a large team. And as Dr. Vineet rightly pointed out, it's not just the medical oncologist or surgical oncologist or radiation oncologist who would be involved in this treatment or this team, but various other stakeholders, starting from radiologist, pathologist, psychological counselor, a nutritionist, rehabilitation expert, everybody. And along this way, we have to take into this journey along with the patient and the treating team mate. We also have to take along with us the various patient support groups, the advocacy groups. And the effort has to be in collaboration at an individual hospital level, I think at state level, at national level, and then international level. So collaboration would mean at each of these steps, there has to be a unity in thought and unity in action. And only then can we get the best possible outcomes for cancer patient.
Right, so you raised that important point. I just want to ask a follow-up question to you, actually, Dr. Jyoti. So when you talk about this interdisciplinary collaboration, what are the current gaps that you see both within your practice or, when you address others or hear from them? What are the current gaps that you see in this interdisciplinary collaboration that you talk about within hospitals?
So I'm fortunate that I'm practicing at a place where we have so-called tumor boards. We hold tumor boards involving each of these stakeholders almost for all the patients suffering from cancer. However, I'm also acutely aware that this process is not in place at each and every cancer center. We even hold, tumor boards at national level now that we are practicing in the era of precision oncology. So each one of us alone is not enough aware of all the advances, and since we have molecular oncology come into being, so we also hold national tumor boards, but there is acute shortage of, both in terms of resources, the manpower, the expertise at each and every level. So I think we need to build on this much more, take into consideration, the power that telemedicine offers, the power that AI now offers. So it has to be built up quite a lot. So it's just a beginning, I think.
Right, so that was very useful. Dr. Vineet, if I could just ask you about the two aspects, briefly touched upon by Dr. Jyoti also. One was, we prioritize a lot on medical professionals, but you also laid emphasis on others. How important are allied healthcare or people, who support cancer therapies in this journey of collaboration? And a word on how important the community engagement is. She mentioned patient support groups. When you look at collaboration, how important is that for successful outcomes?
So first, when you talk of the hospital per se, it is not just, as I am a medical oncologist, just giving chemotherapy and calling it a day. From the inception, as I mentioned, the dietitian has to come, the Department of Dietetics, because most of these patients are malnutrition. They need to have a thorough knowledge as to what they should eat qualitatively and quantitatively, because nowadays we have, information bombardment from WhatsApp, from Google. So they turn in as half-baked cakes and they are, shuddering at thoughts, somebody puts some information inside and they are not able to, sift out what is the actual truth and what is the false. So nutrition is there. All of them are scared as to what is going to be the outcome, how you're going through the motions of it. So you need a clinical psychologist who again has to be from the inception and has to comfort the patient, because see, till the time you are not relaxed, you will be refractory to whatever the doctor says. You won't be able to imbibe. After that, of course, if we have some patient assistant plans, that would be a big help, which we try to tell them wherever and whenever is possible, because again, India, finances play the most important role. You know, the finances is the biggest prognostic indicator, not the treatment paradigms and the other things. And of course, health education is always there. You know, as the previous panel, the children, they are the ones who teach the adults as to what, you know, is the latest and how you have to go through it. So I think all of these form a big conundrum which has to be there. One more thing I would like to say is that we keep on talking about policies, we keep on talking about all the issues we are facing. One thing we don't, you know, bring it into the light is some authority or some nodal person should be there to do the surveillance, to do the auditing. You know, we have very good laws in the country, but implementation of the laws, whether it is done or not, whether it is audited, whether it is cost benefit, that if you start from the micro level in the hospital, probably you can build it up to the national level. So all these points are there.
Right, right. Thank you. Thank you for that. Dr. Ankita, I'd just like to draw you into this conversation. So you've heard about collaboration, the types of collaboration, the needs, the critical components, some of the gaps that currently exist. And obviously all of this is not possible without, you know, organizations like yours, both on you know, drugs, innovations, technologies, but we'll get to that in the second round. What role do you see, you know, as a professional yourself or your organization to make this collaboration happen? What is the lens that you put on it, both globally and also for local needs of India and sub-regionally?
Sure, thanks Karan for that question, and in fact a good question to answer, because more often than not pharma is just seen as coming in when the treatment comes in, right? But that's not the case. If you see across pharmaceutical organizations, they are actually part of the entire journey of a cancer patient, so to say. So right from, and before that as well, so right from the health literacy to support in screening, diagnosis, education of patients and caregivers, and then working hand in hand with the treating physicians on ensuring that the appropriate treatment and appropriate safe use of the drugs happen, and then post that also on the follow-up and the palliative care and the adherence to the treatment. So in the entire journey, pharma is actually part of this entire continuum of care. Apart from that, as we were discussing on the holistic and the comprehensive care of cancer patients, which includes the psychosocial support, the emotional support, and the other aspects, the nutritional support. Most of the pharmaceutical organizations are now going beyond the pill value that they bring, right? So just not only the treatment, but also the platforms where the patients get all these support as well. Like my organization, we do collaborate with organizations which actually help in improving the quality of life of patients with so many other these initiatives. We also collaborate with physicians, institutes on evidence generation, right, which becomes another important aspect of evidence-based treatment and decision-making based on the data that we have in hand, which eventually helps in improving the patient outcomes. So I would say there are so many aspects where actually pharma collaborates with various stakeholders, the physicians, the institutes, the hospitals, government bodies, patient advocacy groups, and I think again coming back to that comprehensive and collaborative care where everyone comes together to the ultimate objective of improving patient outcomes.
Right, so it's very useful to note the entire spectrum of involvement that is there, and as you said, it's not just, you know, at the time of the pill as it were, but it is much prior and much after. Now, talking about innovations and technologies, I mean, when you're looking at newer innovations to bring in, both in terms of, you know, the pill as it were, the treatment, and others that are in the pipeline, how important is collaboration to make that happen, and how do you approach it?
Yeah, definitely. I mean, again, collaboration there at every step is important, and also bringing it newer technologies at every step is so important. So if I divide the innovation into two parts, one is definitely starting from the drug discovery, using the AI technology, the generative AI now, it has been like embraced by most of the global MNCs to ensure that we are accelerating the drug discovery and then moving from there to cloud computing and automation to optimize every aspect of drug development and manufacturing as well. So collaboration and each and every step is very important. Coming back to India, again, to accelerate the access to these innovative treatments to our patients, collaboration with Board of Health becomes important because, again, participation in the clinical trials and then getting those approvals within the timelines so that the patients get access early. Also working on the early access for those treatments to the patients, and then bringing those drugs at the right price to the patients as well, right? So at every step of this, again, the collaboration with various stakeholders becomes so much more important.
Right. So useful to understand that aspect as well. Dr. Jyoti, if I'd like to, I'd like to bring you into this discussion on, you touched upon this, on innovations and technologies that are coming in. How can technology help in collaboration, improving collaboration? We've seen that in telehealth, but are there other aspects that innovations and technologies can play a role in enhancing or fostering collaboration for cancer care?
Yeah, definitely. So as Ankita rightly mentioned, that technology in drug development, technology also to be used more efficiently in drug delivery. So we have to, the basic aim is to improve cancer care, isn't it? So for doing that, we have to not only come out with newer, more precise, better, not only more effective, but less toxic cancer treatments. In addition, we have to ensure that it reaches more and more patients. So we have to make it accessible to many more patients. We have to make it affordable so that many more patients could benefit out of it. And telemedicine obviously would continue to play an important role. So the delivery would come later, but at least getting that expert opinion to begin with for the right, for getting onto the right treatment path could happen with just telemedicine. So there are various ways and various stages wherein technology could help us deliver better patient care.
Right. Dr. Vineet, what about the low information patient who's seeking more and more information now online through social media and other aspects like you alluded to, like Google, and with ChatGPT, you spoke about half-baked ideas and notions. With ChatGPT and others, we don't know whether we've created an entire bakery of half-baked cookies. So, I mean, how do you look at using the tool of social media and others for collaboration or better awareness? Where does that technology play a role? So many patients would come to you with saying that they've read something or they've been told about something because they've read it on social media or popular media. How can that actually be used as a tool for collaboration?
So, see, sitting in forums, we talk about everything which is high-tech. But if you go to the grassroots, you find that in the hinterland, there are areas where you don't even have internet. So, taking a cue from that, COVID was the most harrowing experience which the world had. But for India, the offshoot was that it was a boon in the sense that the digital technology grew up by leaps and bounds. Not only it grew up by leaps and bounds, but the penetration which was there into the rural areas, that was humongous. So people had to adopt to this digital platform. Otherwise, they wouldn't have been abreast because they were just sitting in their homes. So I personally feel now since we have that connectivity forum, we can use it effectively. Initially, you have to take baby steps. You can't, Rome wasn't built in a day. So initially, we can just keep on disseminating knowledge through these, whatever channels we have created, whether it is mobile or whether it is internet or whichever way, because now it is much, much more than what it was pre-COVID. And then I feel you take it from there, and there can be ideas which can come up, and
right.
So it's going to be a continuum. It can't be a one-stop shop.
Right. Dr. Ankita, where do you see technology playing a role, or how does Pfizer use technology for awareness creation and making a patient more aware of both what is possible and sometimes what is not possible?
Yeah, no, absolutely. And as Dr. Vineet also said, post-COVID, the use of technology has increased multifold, and especially as you are asking question around education, the education of both as we collaborate for physician education and as well as for patient education. So India has a huge geography, right? You cannot reach every stakeholder physically. But with the use of technology, the reach can become multifold. So, and especially for our patients, while, as Dr. Vineet said, the internet may be a concern for some of the stakeholders, some of the patients at the grassroots level, but the number of the population that has now access to internet and mobile is increasing tremendously, right? So it becomes one of the key mode to reach out to huge number of patients and population rather for education around, again, right from the cancer awareness to also handhold them as they get diagnosed with cancer. I think that becomes a lot more important. Yeah.
Right. So we've spoken about what collaboration means, what it could look like, what are the gaps currently that we are seeing in those various components of a good collaborative environment, as it were. We've also spoken about technology and innovations and what part it plays in collaboration. And just to round up this discussion in the last 10 odd minutes that we have, it'll be interesting to hear from our experts on how they see policy, or the policy environment help in fostering collaboration. So what is it that, public policy could do? What is it that hospitals or individual stakeholders could do? I leave an open field, but what are some of the things, the changes that you would like at a policy macro level that can help foster collaboration? Dr. Jyoti, would you like to take a stab at it?
So there are some good things which I think are already in place, something like National Cancer Grid. So this network of various cancer centers with the basic mandate to come out with common guidelines for common cancers, to improve awareness, to work towards prevention of cancer, to also work towards collaborative research. I think it's a great initiative. It has been in place theoretically for more than 10 years now. But we have to involve more and more cancer centers into it. We have to come out with better research, with better collaboration. And this National Cancer Grid, fortunately, also takes into account the various patient support groups, various NGOs also with them. So that's a good thing in place already. And we need to use the already in place or inbuilt systems, I think, more efficiently. And as we learned in today's budget itself, there is a proposal to come out with many more chemotherapy daycare centers at district levels. The thought is great, but we have to then see the execution part of that, so that the good aim or the idea is great, but the execution also has to be seen through. That's there. Then we also have to take into account. We have to work at both extremes, I think, at the grassroots levels. Grassroots level, not only in terms of treatment, we know prevention is better than cure. And this applies more so to cancer. So we have to work towards increasing the cancer awareness in the general public. So we have to work towards that, towards primary prevention. And the other extreme is international collaboration. We have various societies, the American Society of Clinical Oncology, and so many, the Indian and the international societies, European Society. We have to work then together to ultimately improve, reduce the global cancer burden and improve the global cancer care. So I think that's what comes to my mind immediately.
And any country or health system that you've looked at and felt that that's a good model of collaboration for cancer care?
So India, I think, is good, but we, get bogged down by the numbers. The sheer burden in terms of number is so huge that we are not able to, work efficiently. But however, we know we do, as medical oncologists, we do go and learn from each other, from West, and various other simpler centers also. But within our country itself, I would say that there are various model systems in place for comprehensive cancer care, and we can first try to imitate them and bring, more people, get them, be of use to them before we start looking outward. So within India, I think we have a lot of power and underutilized strength. So I think let's look and work towards that first.
That's great. Great point there, ma'am. Dr. Vineet, what are some of those policy changes, interventions that would be helpful?
So one would be at the macro level and one would be at the micro level. At the macro level, the burning question is that in India, cancer is not a notifiable disease. So that is the most important thing, because if you don't know how many people are dying, how will you formulate a policy? Second is that you go from Rajasthan to Nagaland, or you go from Kashmir to Chennai, there is a sea of a change. When I say change, it is a societal change, it is a change in the thought process, a change in the food process, the change in the dress process. So when you formulate decisions, decisions should be decentralized and they should take, into account the sensitivities of that particular area. You can't sit in Delhi and formulate for the whole country, not knowing. So another example I'll give you, 5 kilometers in Delhi and 5 kilometers in Assam. There's a sea of difference, 5 kilometers in Delhi you go flat, 5 kilometers Assam is up down. You'll run out of breath after half a kilometer. So these nuances have to be factored inside. Now this is the macro level. Micro level, you have educated the kids that burning crackers is the biggest, drawback which one can have. And now you see how many crackers are burnt. It is a fraction of what it was. So the kid is the one who has to be taught at the school that these things may cause cancer. It may not be the conventional TB or infection. You have to go one step ahead. They will teach the other people around in the house and it will make a huge difference. So it has to be both at the micro and the macro level.
Do you think we're on the right track though, in terms of awareness and other things like you spoke about? The cracker example is one, but do you think on cancer care also we're on the right track, generally speaking?
See, as Jyoti said, we are facing 150 crores. So you have to go, Rome wasn't built in a day, you have to go slowly. So we are on track. Like today's budget, as I said, the brick and mortar, 200 daycare centers in the districts. It's not a small job, 200. Now, they felt that one cannot just stop there. They have to have doctors. So this year, they are going to have 10,000 more seats for the doctors. And they're going to envisage about 5 times more till about 2028, if I'm not wrong. That came in the budget today only. So the government is also trying, but cancer has to be notifiable. And of course, you have to allocate budget for everything, but if you see the proportion of budget which has been allocated for health vis-a-vis the other, policies and programs, it is quite less. And even if you compare it with abroad, there it is about 2x or 3x of what it is being allocated in India. So I think a thought process should be towards the finances also. If you have the money, you can, propagate. If you don't have the money, then you are tied down.
Right. Excellent points there. Dr. Ankita, final word on this aspect of policy.
Yeah, quickly. So, I mean, my first comment was on the cancer being the notifiable disease. If we can have one comprehensive cancer registry across India, that would help solve a lot of problem, give answers to a lot of questions, basis which a lot of policies actually can be made, and it can also help in improving the patient outcomes with treatment decisions. The second bit, as we were speaking on innovation, of course, we have moved a long way from the ban on the clinical trials to now India being one of the most important geography for conduct of global clinical trials, right? So, I mean, really compliments on the new rules that have come up, and we need to continue to improvise on all the challenges that we face and come up with newer policies around how we can make India again as a hub of doing more and more global clinical trials, and of course our indigenous clinical trials as well, ultimately in the benefit of the patients, right? And the last bit on access, a lot is being done. The spend from the government speaks volume about the efforts being made, a lot on the prevention and screening as well. However, we should not forget that in India, majority of our cancer patients, they come up in the advanced and metastatic stage, right? But they're not at deathbed. So now the treatments that we have, they actually are prolonging the survival so long. So while it is great that at least they have now access to the basic cancer care, it would be good to see how the innovative medicines can also reach to some of these patients who are in need of those drugs, right? So a platform where the policymakers, the payers, the physicians, and of course some of the other stakeholders like industry can come together and think in the benefit of patients in a very trustworthy and a transparent environment is definitely would be useful.
Thank you for that. Dr. Jyoti, Dr. Vineet, Dr. Ankita, my compliments for covering such a wide array of topics and subjects on this very wide subject of collaboration for comprehensive cancer care. Thank you for sharing your insights and also very useful inputs, which are take-home messages on both on policy, infrastructure, stakeholder management, and what solutioning could look like. Ladies and gentlemen, a big round of applause for this fantastic group here. It's been my pleasure to have conducted this session. I'll hand it back to you. Thank you.
Thank you so much, and thank you all the panelists for your unique contribution to the session and for that wonderful discussion. And it was a session on collaborative approach to comprehensive cancer care. Now I request Mr. Kamal Narayan to please come on stage and felicitate the speakers. Ladies and gentlemen, put your hand together for this wonderful session. Now, starting with Dr. Jyoti Vadva from Paras Healthcare HOD Medical Oncology. Thank you so much, ma'am. Dr. Vineet Talwar, Director, Department of Medical Oncology at RGCIRC. Thank you so much, sir. Dr. Ankita Jain, Medical Director, Oncology, Field of Medical Excellence, Pfizer.
Along with some trophies as well.
Thank you so much, ma'am. And last but not the least, our moderator, Dr. Karan Thakur, Group Lead Sustainability and ESG and Vice President Public Affairs, Apollo Hospitals. Thank you so much, sir. And now I request everybody to please come forward for the group photograph. Thank you so much once again for the wonderful session on collaborative approach to comprehensive cancer care. Now, ladies and gentlemen, we are going to take a tea break. Yes, it's a networking and tea and snacks break, but we will meet very shortly here, so please enjoy. Thank you so much. Thank you.
Hello. Hello.
Hello.
Hello, hello.
Audio is fine from my side.
डेस्कटॉप के अगले वाले पे
इसके नीचे ही है
लास्ट हाँ
Am I audible, sir? Daniel,
Yeah. Mic testing 1, 2, 3. Am I audible? Yes. Okay. Thank you so much, Mr. Daniel. We'll start in a while. Thank you.
Hi, can you hear me on Zoom?
Good evening, Mr. Daniel.
Hello.
Yeah, hi. Can you speak a few lines for the audio test?
Yes, so it's a great pleasure to be invited to the meeting. Thank you very much.
Yeah, is it fine? Okay, thank you so much.
From my
sir.
side, yes, so I can perfectly hear you.
Yeah, from our end also it's fine, sir. Thank you so much. We'll connect with you in a
Okay,
while.
perfect.
Yes, thank you.
Thank you.
Thank you.
Can you see my slides? With screen share? I cannot hear you currently, I'm sorry.
May I have your attention, please? Good evening, ladies and gentlemen. Welcome to the last segment of today's event, that is 6th edition of Cancer Summit and Awards, an initiative by Integrated Health and Wellbeing Council and Rapid Global Cancer Alliance. It's now time for the last session of the event. It's going to be a virtual session on global best practices in cancer control. I invite Dr. Daniel, Head of Group at German Cancer Research Center and Heidelberg Institute for Stem Cell Technology and Experimental Medicine, to address the topic that is global best practices in cancer control. Good evening, Dr. Daniel.
Hello. Thank you very much for having me.
Thank you, sir. All yours.
Yes, thank you very much for the kind introduction. Ladies and gentlemen, dear IHW Council, it is a great pleasure and an honor to speak here. I deeply thank the organizers for the opportunity to present you our work in precision oncology and the resulting inference on global best practices in cancer treatment and control. Let's first dive into precision oncology. Unlike classical concepts of oncology, which stratified cancer entities by tissue or organ of origin, for example, saying this is a pancreatic cancer and that is a colon cancer, precision oncology aims at stratifying patients according to alterations of cellular pathway in order to infer which patient will respond to which drug. So, for example, making the distinction between likely responders to MAP kinase inhibitors versus responders to chemotherapy. Precision oncology requires molecular profiling, the scope of which is very broad. Profiling DNA is performed by sequencing technologies, which enable the detection of mutations. At one end of the spectrum, there are technologies to study individual mutations or hotspots or panels, which would focus on as many as maybe several hundred genes. And on the other hand of the spectrum, there are genome-wide technologies like whole exome sequencing or whole genome sequencing, which enable to characterize and sequence all genes at the same time. And a human has 20,000 genes. The exome focusing on the coding regions and the genome additionally including non-coding regions of the genome. At the German Cancer Research Center, DKFZ, we have implemented a strategy for precision oncology. So the infrastructure of the German Cancer Research Center allows us to run several precision oncology programs which use broad molecular profiling, so whole genome sequencing, whole transcriptome sequencing, epigenetic analyses like methylation analysis in specific patient populations, which are described down here, to guide clinical management and develop new concepts for molecularly informed clinical trials. And in the following, I will present more detail about one of these programs, the MASTER program. MASTER is an acronym for Molecularly Aided Stratification for Tumor Eradication Research. It's an activity of the German Cancer Research Center and several research and care consortia at national scale. Our network comprises more than 150 partners all across the country and represents the entire spectrum of cancer care. The program focuses on patients with rare cancers or rare subtypes of common cancers who are candidates for systemic, that means drug treatment. And it implements a molecular tumor board, which is really the mode of action of precision oncology, where interdisciplinarily evidence-based individualized treatment recommendations are issued for the patients. So precision oncology programs require a multidisciplinary workflow comprising, in the first place, a patient registration and enrollment, then pre-analytics of tissue and blood samples, including the extraction of DNA and RNA, molecular profiling, which means sequencing, but also epigenetic profiling or the analysis of the proteome, for example, by mass spectrometry, bioinformatic analyses, and this is really a very important part in the whole process chain. So bioinformatic analysis of the obtained data layers, clinical curation, and interpretation of the data, including the identification of so-called targetable, that is treatable lesions or mutations, then an interdisciplinary molecular tumor board, as I said before, then a finalization of treatment recommendation and feedback to primary caregivers, the implementation of the treatment, and a follow-up which provides very, very important data on survival and, for example, patient-reported outcomes. So the layers of patient characterization in the master program currently include genome, transcriptome, methylome, which is an epigenetic data layer, and proteome of each tumor, as well as sequencing of relevant germline alterations. And if we sequence the germline and the tumor, we can make the distinction between the somatic mutations, which occur only in the cancer, and the germline mutations, which every individual, not only patients, has from birth in all cells of his or her body. So using the standardized multi-component workflow, we have analyzed more than 5,200 patients in this precision oncology setting. And according to the inclusion criteria, the spectrum of entities displayed here does not match prevalence in general population, but is enriched for the rare and the difficult to treat cancers, like, for example, sarcomas. In the process of moving precision oncology from a research setting to standard of care, we have implemented a structure called the Interdisciplinary Laboratory for Precision Medicine, ILP, which performs molecular diagnostics conform with national German and international European regulatory context and legislation. So the cases for ILP need not all enter the process chain at the beginning. There are alternative entry routes, for example, for cases who have had their pre-analytics and even sequencing performed in another laboratory. The ILP thus offers molecular diagnostics for all tumor types. And the question is, what is the benefit from molecular profiling and precision oncology? There are three main benefits for patients. The first one is individualized treatment recommendations, which when implemented lead to survival benefit. So when using broad molecular profiling with whole genome sequencing in patients who have exhausted standard lines of treatment and thus are a particularly difficult to treat situation, like in the master program, we can still identify targetable lesions in 85% of cases in this last line setting. The second large benefit is actually germline findings. So these encode tumor predisposition, and finding them has potential consequences for prevention in the whole family of the index patient and goes beyond the patient himself. And this is actually in 10% of the cases, and that is much more frequent than had been anticipated before the start of the omics or genomics era. The third large benefit which patients can draw from molecular profiling is diagnostic re-evaluation. So that would mean that molecular data falsifies the morphology-based assessment of the underlying tumor type. So for example, if you sequence a metastasis from the liver, you may initially have said that this might come from a pancreatic carcinoma, but molecular data would tell you that instead it comes from, for example, a smooth muscle sarcoma of one of the blood vessels. So this has a very strong consequence on the availability of approved treatment for the different entities, and this happens in 3% of cases. How to assess actually survival? So classical measures of survival in clinical trials, like progression-free survival, are not or less applicable to the situation which we have in precision oncology, because we have a registry trial with a very heterogeneous population, and it's unlike an interventional clinical trials. And for this situation, a new measure to assess survival had first to be developed, and this is the PFS ratio. So the PFS ratio is defined by the progression-free survival, PFS, achieved after molecular profiling, here in the sketch called PFS2, divided by the last PFS obtained before molecular characterization. So it's this ratio PFS2 divided by PFS1. And an intervention in precision oncology is considered a success if the PFS ratio exceeds 1.3. So if the added progression-free survival from molecular profiling is 30% longer than what the patient had achieved before the molecular characterization. And you can see that the PFS ratio values of the patients in the master program are spread across a range. And generally, the benchmark for precision oncology programs, so a whole program, is considered a success if at least 30% of the patients meet this criteria of PFS greater than 1.3. And in the master program, we reach approximately 40%. And obviously, this is not identical for all, and it has different distributions across the different entities in our basket situation. But of note, those entities which are particularly difficult to treat in the classical oncology setting, like carcinoma of unknown primary, have a particularly high benefit with, for example, a PFS ratio of 3.6. Still, I would like to note that even though we find targetable lesions in 85% of cases, the treatment is currently implemented in only 40% of cases, and this is a tragedy. There are different possible reasons for that. So, for example, a patient dies before the results from molecular profiling come in, or a drug is not available or not approved in the respective country, or a clinical trial may have closed an arm or stopped recruiting, or simply an insurance is not willing to pay for a drug. And this calls upon action in public health and in healthcare organization. So there is a lot of potential to sort of transform these 85% of treatment recommendations into a higher implementation rate. So we may ask the question, which omics layer contributes how much information to all this added benefit for the patients? And to determine this, we have asked which molecular tumor board recommendation would not have been identified with a smaller technology, notably the TrueSight Oncology 500 DNA and RNA panel. And so here in this bar plot, you see that 100% represents the number of recommendations found by precision oncology. And the red part is that what would have been found with the smaller technology. And that means that, for example, in 58% of the cases with diagnostic re-evaluation, none of the biomarkers prompting diagnostic re-evaluation would have been found with the smaller technology. And in the treatment recommendations, in 45% of the cases, none of the biomarkers supported by supporting treatment recommendations would have been identified with the smaller technology. So there is a substantial benefit from going to broad molecular profiling, including whole genome sequencing. So this whole setting with the amount of information gained can inform, for example, drug repurposing. So there is a treatment strategy directed against ERBB2, which has been described long time ago in breast cancer. And because breast cancer is a frequent cancer, a very rich repertoire of treatment has been developed, including, for example, trastuzumab deruxtecan. So that is an antibody-drug conjugate with a highly toxic compound linked to an antibody, and the antibody is specific for only the tumor cells. And this works well in breast cancer, but because of our molecular profiling efforts, we can see that this constellation of ERBB2, so the target being present also in another cancer entity, in desmoplastic small round cell tumors, we can repurpose the drug to a new indication. And here is an example showing the PET scans of a patient with a very strong tumor load initially under treatment with trastuzumab deruxtecan decreases and reaches remission. I would like to stress that also there are implications for immunotherapy from molecular profiling, because if we do RNA sequencing and have gene expression data available, we can assess the expression of the targets of immunotherapy. And this can lead to very precise indications for CAR T cells, bispecific antibodies, TCR T cells, or antibody-drug conjugates, as I have shown on the previous slide. We can furthermore use the information for HLA genotyping, which is also a major determinant of response to the various immunotherapies. And by doing so, not only for individual patients, but by aggregating this information group-wise, we have very precious information for pharma companies who are actively inquiring us to help them, for example, on lead target prioritization. So beyond the molecular profiling itself, we also develop technology for the whole process chain. So remember this slide where I introduced the interdisciplinary laboratory for precision medicine. In addition, based on our expertise in bioinformatics, medical informatics, pattern recognition, machine learning, artificial intelligence, and biomarker development, we have developed a visualization and decision support system, which is the knowledge connector. And the knowledge connector ingests the results from molecular profiling, so the omics data. In addition, it ingests clinical data from, for example, patient records, and it ingests world knowledge, which would be publications in PubMed or evidence databases like OncoKB, and processes all this bunch of information, brings it together with the individual molecular makeup of the cancer of a given patient, and leads to a decision support system, which helps the preparation of a case by a molecular oncologist, which aids the interactive discussion in the molecular tumor board, and most importantly, performs the patient drug match. And if a clinical trial is available, it would also perform the patient trial match. And finally, using all this functionality, it also helps in automatic report generation. So it's important to note that all this functionality together is much more than just issuing a static report. So it's an interactive functionality for really helping and speeding up the process of the molecular doctors, of the clinicians. This is a screenshot of the Knowledge Connector. So it's an app which runs in a browser. And there are several visualization and decision support systems out there. Still, there are a few unique features of our system here. So, for example, it has been from the very beginning on developed together with the molecular oncologists who have a navigation bar. And this follows exactly the line of reasoning of a molecular oncologist when he deals with a cancer patient. Furthermore, the whole system can display, process, and assess biomarkers beyond single gene level. So there are certain features which you cannot map to a given individual gene, but which are representative of the whole cancer. And this is actually a unique feature of our system, that it can display this. So beyond the different aspects shown before, we also have the unique opportunity to work with HiStem, the Heidelberg Institute for Stem Cell Technology and Experimental Medicine, and which provides additional resources for translation and reverse translation. And HiStem actually explores the genomic and molecular foundations of cancer to advance innovative personalized diagnostics and treatments. And it is sort of a circle, right? So you have observations from precision oncology programs, from real patients. You go to the lab, you do confirmative wet lab studies, and bring back these insights to treatment and to the patients. So coming back to the initial diagram about precision oncology, we may say it's there, and it is currently moving from a research context to being deployed in general healthcare. And that is, I think, a very good point in time to ask about a global perspective. And I will do my very best to provide you such a global perspective. So we are in a situation where for the analytical technologies, there is a substantial decrease in cost and increasing maturity. We are in a situation where we have strongly increasing numbers of cancer patients. At the same time, we have increasing amount of evidence and knowledge and an increasing number of biomarkers. So in general, increasing world knowledge. We have an increasing number of available drugs, and in particular of targeted therapies. And conceptually, we can make the move from a last line setting to an early line setting for precision oncology. And all this actually necessitates, but also facilitates scale effects. And the scale effects will sort of lead the step from national implementations into a global perspective. And when having the global perspective, I think the best place on earth to implement and to do that is India, with the biggest population on earth, with a cultural setting, with a large talent pool and a strong innovation culture. And in order to do this transition, we have founded Genavinter Health, which has a value proposition to actually deliver all these patient benefits to the Indian population and to the public and to leverage the scale effects. And it will all start by what we call Genavinter One. It's a clinical solution platform, re-implementing the different aspects I have shown you before. And exceeding that, it will then go via a phase of research and innovation to generate additional IP and also education and training. This is the team behind Genavinter, and you may have seen Shubhankar present in another session of today's meeting. Having said that, I am at the end of my talk. I acknowledge a lot of people, either colleagues in one of my research groups or mentors, colleagues internationally and nationally, and you for your attention. Thank you very much.
Thank you so much, Dr. Daniel, for addressing the virtual session on global best practices in cancer control. Thank you so much for your time and contribution to the session.
Yeah, it's my pleasure. Thank you so much for having me.
Thank you. And now, ladies and gentlemen, it's time for the special segment of the event. Yes, it's time for the award ceremony. Well, we all have come here to honor the courage, resilience, and determination of individuals and organizations making a difference in the fight against cancer. As we gather here, we represent a collective commitment to conquering cancer and improving the lives of those affected by it. Over the past years, we have seen tremendous progress in cancer research, but we know there is still a long way to go and much more work to be done. This summit and award ceremony is a celebration of hope, innovation, and collaboration. Before I invite two distinguished personalities on stage for giving away the awards, it's important for me to thank our jury members. Ms. Sajaya Krishnan, former Health Secretary, Government of India. Dr. Hema Divakar, MD Divakar Specialty Hospital, CEO Artist for Her. Dr. Harsh Mahajan, Founder and Chief Radiologist from Mahajan Imaging. Mrs. Jyotsna Goval, Chairperson, Indian Cancer Society, Delhi Branch, and Professor Maqsood Siddiqui, PhD, Chairman, Cancer Foundation of India, CFI. And now, to give away the awards, I would like to call on stage Mr. Kamal Narayan. So please come on the stage, along with, of course, another distinguished personality, Mrs. Jyotsna Goval, Chairperson of Indian Cancer Society. I request both of you to kindly come on stage and felicitate the winners. Ladies and gentlemen, put your hands together for Mr. Kamal Narayan and Mrs. Jyotsna Goval. It is our honor to welcome Mrs. Jyotsna Goval, a pioneering leader in the fight against cancer. As the chairperson of the Indian Cancer Society, Mrs. Goval has been instrumental in driving cancer awareness, education, and advocacy across India. With her tireless efforts and unwavering commitment, Mrs. Goval has made a significant impact on the lives of countless cancer patients, families, and caregivers. Her leadership has inspired a nationwide movement to combat cancer and promote healthy living. Please join me in welcoming once again Mrs. Jyotsna Goval, a true champion in the fight against cancer. A very warm welcome to you, ma'am. And now let's move on to the awards. And here comes the first award of the day, Cancer Awareness Champion Award, and it goes to Professor Dr. Meenu Walia. Ma'am, may I request you to kindly come on stage and accept the award, recognized for her outstanding contributions to cancer awareness and patient education, inspiring communities to take proactive health measures. Dr. Meenu Walia. Put your hands together once again, ladies and gentlemen. Congratulations. In surgical oncology goes to Dr. Umang Mittal, acknowledged for his excellence in surgical oncology, delivering high-impact interventions for cancer patients. Congratulations, sir. To Dr. Chirantan Bose. Organizational awards, Leadership in Cancer Diagnostic. This award goes to for molecular imaging and therapy, honored for its contributions in advancing molecular imaging. Diagnostics goes to Life Cell Diagnostics, recognized for pioneering advancements in cancer diagnostics, enhancing early detection. Award goes to NOAA Design Build, awarded for their exceptional contributions to healthcare infrastructure, supporting advanced cancer treatment facilities. Excellence in Cancer Care in India Award goes to Tata 1MG, honored for its outstanding role in revolutionizing cancer care accessibility and in Precision Oncology AI-Driven Prognostic Solution Award goes to OncoStem Diagnostics Private Limited, recognized for groundbreaking AI-driven prognostic solutions that enhance personalized cancer treatment. Limited and UE Life Sciences, recognized for their pioneering initiatives in cancer screening and early detection, improving survival. Excellence in Multidisciplinary Care Award goes to Aster MIMS, awarded for its integrated approach to cancer care, ensuring comprehensive treatment across specialties. Congratulations. Best Oncology Hospital of the Year award goes to Apollo Cancer Center, Tanampet, honored as a premier institution in oncology delivering world-class cancer care and innovation. Congratulations. Outstanding Patient Experience Award goes to Apollo Cancer Center, Tanampet, recognized for setting new benchmarks in patient experience, offering compassionate and comprehensive cancer care. Congratulations. Let's move on to individual award categories. Head and Neck Oncologist of the Year award goes to Dr. Narayana Subramaniam, honored for his excellence in head and neck oncology, advancing Transformation Award goes to Dr. Shashi Balyan, driving transformative cancer care solution and enhancing healthcare delivery. Emerging Oncologist of the Year award goes to Dr. Ankur Varshne, celebrated for his exceptional contribution. Care Excellence Award goes to Dr. Ajay Gogia, recognized for his expertise and dedication in breast cancer care, ensuring the best clinical outcomes Cancer Care Leadership Award Medical Oncology goes to Dr. Priya Tiwari, honored for her leadership in medical oncology, pioneering advancements in cancer treatment. Congratulations. Cervical Cancer Innovator Award goes to Dr. Sumit Goyal, awarded for his innovative approach to cervical cancer prevention, diagnosis and treatment. Congratulations. Excellence in Cancer Prevention Initiatives Award goes to Dr. Abdullah KP, recognized for his efforts in promoting cancer prevention through early detection and public health advocacy. Congratulations. Cancer Care Leadership Award Medical Oncology goes to Dr. Jyoti Vadva, honored for her leadership and contributions in advancing medical oncology and patient-centered care. Advocate of the Year Award goes to Dr. Mohit Agarwal, recognized for his dedication to supporting and advocating for cancer survivors, ensuring holistic care and rehabilitation. Next award goes to Dr. Kanika Sood for excellence in precision medicine oncology. Dr. Kanika Sood. Beacon of Hope Award for Exemplary Cancer Care Service in Rural India goes to Dr. Sanjay Maheshwari. Patient-Centric Innovator Award goes to Dr. Manish Singhal, awarded for his groundbreaking initiatives in patient-centric cancer care, improving access and treatment outcomes. Congratulations. Dr. P.K. Julka, honored for his lifetime contributions to the field of oncology, shaping the future of cancer care and research.
Thank you very much for this award honor, and I must tell you, my journey in oncology started from 1970s, and when I started doing oncology 1975, I was in University of Pittsburgh in US when I went into NSABP trials in breast cancer. So then I came back to India because I was in MD Anderson in 86 and then in 96, and in the meanwhile I was in AIMS for a long time, more than 3 decades, as a professor of oncology and as a dean of AIMS, New Delhi. Now the thing is that, you know, when we started oncology, I never dreamt of being an oncologist, but interest developed, and the passion for oncology is making me work still today. And today only I saw 35-40 patients, and chemotherapy, molecular therapy, all this excluding the radiation oncology part, which we have separate, and immunotherapy, all these new therapies, targeted therapies, you know, and genomic precision medicine, which I started about 80s. And I delivered a lecture on immunotherapy in cancer in 1982. And that was the first lecture when immunotherapy was not born, because it was only T cell and B cell. And now we have, you know, done so much in immunotherapy. I think that speaks aloud this thing, that where we are heading for. Thank you very much.
Thank you, Dr. Julka, and we at IHW Council are really honored to have you honor for your wonderful work and the lifetime of, passionate, compassionate, empathic, and much needed work which you have been doing in the area of cancer care. So big round of applause by all of you for Dr. Julka. And thank you so much, Jyotsna ma'am, for being the part of the jury. सर से या मैम से? अच्छा अच्छा. So Dr. Masri, please come. No, this is very important. We must hear the perspective of a student for his teacher, and both of them being awarded at the same platform. Dr. Masri.
बंधुओं, सबसे अच्छा अवार्ड तो सभी को अच्छे लगते हैं, और किसी भी उम्र में मिले, 70 में मिले, 80 में मिले, 60 में मिले, लेकिन जीवन का सबसे बड़ा जो पल है एक स्टूडेंट मेरे लिए कि जब मेरा टीचर को और मुझे दोनों को साथ में मिले। तो मैं ऐसे टीचर को भगवान से प्रार्थना करता हूँ कि लंबी आयु दे, और हजारों हजार स्टूडेंट्स इनके द्वारा निकले और करोड़ों से करोड़ों पेशेंट ट्रीट हुए। तो आपको सबकी दुआ लगेगी सर। मैडम से बात हो रही थी तो मैडम से मैंने पूछा आपकी उम्र क्या है, तो बोली दिखने में मैं 25 की दिखती हूँ, वैसे हूँ 80 की। तो मैंने इसीलिए इनके पैर छुए कि जीवन में जो सुखी रहता है मन से, उसकी उम्र नहीं बढ़ती। एजलेस ब्यूटीज़ में 2 लोगों को मैंने जीवन में सबसे अच्छा माना, एक थी गायत्री देवी और दूसरी मैडम गोयल। तो इनके लिए ढेर सारी शुभकामनाएं। इसी तरह से खुशनुमा माहौल में यंग बनी रहें, हम सब लोगों को प्रेरणा दें। और मैं भी 65 का हो गया हूँ तो बूढ़ा नहीं हूँ, ये बताने के लिए मैं आया हूँ। आप सभी लोगों को, IHW को, कमल की टीम को इस सम्मान के लिए, मैं छोटे से गांव का हूँ इसलिए इस सम्मान के लिए मैं इस बड़े शहर में, राजधानी में भारत की, जो आप लोगों ने दिया, मैं पूरे MP बिरला ग्रुप के सभी मेरे 800 कर्मचारियों के द्वारा और सतना जैसी छोटी जगह के सभी लोगों के द्वारा, विंध्य प्रदेश के, बुंदेलखंड के और करीब करीब 4 करोड़ की पॉपुलेशन को हम कैंसर केयर दे रहे हैं पिछले कई सालों से। तो मुझे ऐसा लगता है कि कमल और उनकी टीम, पूरी टीम ने बहुत अच्छा जो एक प्लेटफॉर्म दिया सभी लोगों को, हम लोगों को, और हमारा सम्मान किया। सर का सम्मान तो होना ही था, ये तो छोटा सम्मान है, आप और बड़े सम्मान के हकदार हैं, ये मेरा मानना है। कई बार सम्मान छोटा होता है और कई बार जो बड़ा सम्मान है, जो शायद भारत रत्न होता है, वो डॉक्टर्स को भी मिलना चाहिए, क्योंकि देश की असली सेवा अगर कोई कर रहा है तो मेडिकल प्रोफेशन वाले करते हैं, जो अपना दर्द भूलकर उसके कैंसर को ठीक करने, उसकी दवाइयों में लग के पूरी रात भर सोचते रहते कि क्या करूं। 1980 में या 1970 में कोई अगर लेक्चर देता बाहर पिट्सबर्ग में जाके और वहाँ से सीख के आता है और एक छोटे से शहर में आके बसता है, तो ये बहुत बड़ा परिश्रम है। आपके साथ आपके पूरे परिवार को, आपकी बीवी का भी उतना ही अधिकार है। तो आप 80 के और आपकी बीवी 70 की, तो कुल मिला के 140 साल का एक्सपीरियंस आप दे रहे हैं शहर को। तो ये मैं हमेशा बोलता हूँ सब लोगों को कि आपका जो बेटर हाफ है, आपके जो बच्चे हैं, वो भी उतने ही पार्टिसिपेंट हैं आपकी मेहनत में। तो इस सब मेहनत के लिए, इस सब समारोह के लिए और इन सब लोगों के लिए जिन्होंने इतना अच्छा टीम को ऑर्गेनाइज़ किया, मैं तहे दिल से आप सभी की ओर से आपको ढेर सारी शुभकामनाएं देता हूँ।
Thank you, Dr. Maheshwari, for such encouraging and appreciation. I'll request Jyotsna ma'am also to say a few words before we, conclude the today's program.
Thank you very much, Kamal. It's a pleasure to be with IHW after a break of a few years. I was saying to Kamal that I look at the faces around me of all the doctors, and each one is younger than the other. Would you agree, Dr. Julka? Yeah. And it gives me the satisfaction of having worked with quite a few generations of doctors. I am only an NGO worker, but I've been working in this field with the Indian Cancer Society since 1985. So you will see how I have met with so many generations of doctors, and it gave me great pleasure to be able to award them. The biggest honor for me was to hand that award to Dr. Julka. He was our teacher too. I don't know if you remember, in IRCH, when we started Cancer Sahyog, we wanted information, and you were very kind about coming and doing a small training session. Now we conduct training sessions on our own, and we are very proud of the fact that we have taken cancer awareness to the digital space. We have a program on Swayam platform of the Government of India. We do a faculty development program with university professors all across India, and I mean all across. We've been in 21 states. And now we have produced an app which we call Rise Against Cancer. Like all our products, it is always free to the consumer. So do use it. Do pick it up. We want information in the palm of every hand. I thank you, Kamalji, for the encouragement you have consistently given me. And I love your team of pretty young women around. They really make me feel good. And thank you all. God bless you.
Thank you so much, ma'am, and congratulations to all the winners. I don't believe in saying 65 years old or 80 years old. I always say 65 years young and 80 years young. And now I request Mr. Kamal Narayan to felicitate Mrs. Jyotsna Govil. Please put your hands together. Thank you so much, ma'am, for being a part of the event, for your time and for your contribution. Thank you so much. Now I request all the winners to please come on stage for a group photograph. Please. Once again, the stage is all yours. Please come and join us for a group photograph. Thank you so much, and congratulations for all the achievements. Thank you so much. If you wish, you can definitely carry your trophies with you. Ladies and gentlemen, we have reached the climax of this wonderful event, that is 6th edition of Cancer Summit and Awards, an initiative by Integrated Health and Wellbeing Council and Rapid Global Cancer Alliance. I request Mr. Kamal Narayan to please come forward for the closing remarks. Thank you so much, sir. Please. Just sit by, sir.
Okay. So once again, thank you each one of the participant for today's summit. We had wonderful discussions on various key and important topics, and also a very befitting award ceremony, and where we could recognize the wonderful work of so many young and veterans both. So thank you each one of you for your participation. Thanks our partners who helped us in organizing this event, Pfizer, Genavinta, your which all partners we have. Okay, Merck and OncoStem, Tata 1mg, and also digital media partner Only My Health. So thank everyone, and have a wonderful evening ahead, and a great year ahead also of the great work which you continue in the cancer care, and in supporting the patients and all those who need the care from you.